It's coming from Dr. Venkat Giri's phone.
He is working on Sunday. It's a very good thing. We should be proud of it.
Sir, most of the times he attends meetings also from the OT. He is so busy in the evening hours also.
Is it 9 o'clock? We can start.
Yes.
Yes, it is sharp 9.
Let's start.
Should I start?
Meenal, start.
Okay. Good morning to all national and state committee members, respected seniors, colleagues, and my dear friends. Voice echo होता है.
Madam, please unmute yourself and try.
I have unmuted.
You can speak now.
Okay, now the voice is good. Welcome, Dr. Pandya, sir. Good morning to all national and state committee members, respected seniors, colleagues, and my dear friends. Very warm welcome from Thane Anesthesiology Society and Indian Society of Anesthesiology, Thane branch. I, President Dr. Meenal Gadge, along with Secretary Dr. Manisha Ghosh and our team, welcome you for today's wonderful academic feast, that is National Sponsored CME, organized by Thane ISA. We have taken a lot of efforts to make it successful and give you a take-home messages, whether you are institutional or private practitioner, and hence it is a mixed bag. I hope it becomes a successful and wonderful experience for all of you. Now we will have a flag hosting ceremony in the esteemed presence on behalf of all dignitaries present here, Dr. Manisha Katikar, Dr. Anjali Bhure Madam, Dr. Venkat Giri Sir, Dr. Pandya Sir, Dr. Katkade Sir, and my dear friend, Dr. Manisha Ghosh. It is my honor and privilege to hoist our ISA flag as a president of Thane City branch. ISA flag was designed in 1969. Sandeep. And carries the color designated for medical gases we use in anesthesia practice. The flag projects the achievements, the dedication, and unity. At the same time, flag reminds us to pledge for community upliftment through our services, as well as exhibits awareness to non-anesthesiologists. Thank you so much for joining us. I will hand over to Dr. Manisha Ghosh to start the scientific session. Dr. Manisha Ghosh.
Thank you, Dr. Meenal. A very good morning and a warm welcome to all of you. Without further ado, let us start off with the scientific session. It is most disappointing for an anesthesiologist when his spinal does not act, or it has inadequate action, or if it wears off fast. Would the continuous spinal be a solution to this? Let us find out from Dr. Malti Panchwak. The coordinator and moderator for this session is our scientific committee secretary, Dr. Nilima Kelkar. Dr. Nilima is a private practicing anesthesiologist and a very conscientious anesthetist. She keeps our WhatsApp group active with numerous practical decisions. Dr. Nilima Kelkar, over to you.
Thank you so much, Dr. Manisha. Good morning, everybody, all the dignitaries and my friends. Our first topic for today's session is continuous spinal anesthesia. I am especially happy to introduce Dr. Malti Panchwak, as she is my dear senior from KEM days. Dr. Malti is senior consultant at Sahyadri Super Speciality Hospital and MJM Hospital, Pune. She has special interest in regional and neuroanesthesia, and she has many papers and paper presentations to her credit. Welcome, Dr. Malti Panchwar. To chair this session, I welcome Dr. Manohar Bharne sir. Sir is senior anesthesiologist practicing in Thane for last 35 years. He is Vice President Thane ISA and he is Senior Consultant at Kaushalya Medical Foundation Trust Hospital. Welcome, sir. Over
Thank
to you,
ma'am.
Dr. Malti Panchwar.
So good morning to everybody, all the early birds who are here to listen to the wonderful platter of topics that ISA Thane has brought to us today on the 16th of January 2022. Warm thank you to the office bearers of ISA Thane and to Neelima Kelkar, Manisha Ghosh and Meenal Gadgil in particular, who have very seamlessly coordinated with everyone and brought this to fruition. So let's start with today's first topic, which is continuous spinal anesthesia. So it just means that it is a technique where a catheter is introduced into the intrathecal space and regular top-ups will lead to a continuous anesthetic which is being given. I'm sure when as a resident or in the early parts of our career or even later, many of us would have wondered why we are not able to, or how wonderful it would have been if we were able to introduce a catheter into the intrathecal space and had the opportunity to give anesthetic just as much as we want and to top it up just as much as we want to achieve the desired effect. So this is because of the challenges that a single dose spinal anesthesia produces. Basically, it is very difficult to control the spread of the anesthetic and to exactly block the segments that is needed for a surgical anesthesia. This is more of a challenge in elderly patients where the action is more unpredictable and there is a lot of interpatient variability. Another challenging problem that occurs with using higher volumes to ensure good blockade involves hypotension. Again, this is more common in the elderly age group, and this hypotension can be detrimental to them even. For some reason, if the anesthesia needs to be prolonged because of some increase in the surgical time, it is difficult to prolong the effect of a single dose spinal anesthetic. We tend to resort to then other techniques, maybe just add a little bit of sedation or use intravenous propofol or convert to general anesthesia as the case requires. These are some of the cases that we have, in whom we have used continuous spinal anesthetic. This is just brought here to show what variety of cases are challenging, which we frequently encounter in our daily practice. And it's not necessary that these cases come only to tertiary referral centers. These may happen to you even in smaller setups. And though ideally it would be best to refer such patients to better equipped setups, some of us have to deal with these patients wherever we are and in whatever setting we are. And certainly spinal anesthetic, the CSA would be a very important technique to consider to get a fairly safe patient and a fairly predictable outcome at the end of your anesthetic. So consider a 66-year-old with moderate aortic stenosis for a neck femur fracture, or another elderly patient with a poor ejection fraction for a bipolar hip prosthesis in the lateral position. Again, an octogenarian with cardiorespiratory problems, probably on NIV or requiring some kind of respiratory supplement for a periprosthetic hip fracture and implant removal with reimplant. So prolonged surgery needs to be done, an orthopedic procedure in a very unstable patient, and it's urgent surgery. It is not like patient can be optimized and taken up later. A super elderly patient for prostate surgery with poor ejection fraction, or a young patient for emergency section who hasn't undergone an antenatal checkup, and suddenly at admission you realize this patient has severe mitral stenosis or some kind of cardiac problem, and has not been diagnosed, treated, or has been diagnosed, treated, but still has a complex cardiac condition needing section, and you're hesitant about using general anesthesia or a continuous epidural in these patients for whatever reasons. The factors that we typically consider when choosing an anesthetic technique are the time required for surgery, what is the kind of surgery, which surgical area is being targeted, what is the expertise of the surgeon or the anesthesiologist while choosing your anesthetic technique, patient's medical complexity, so what kind of medical conditions and specific requirements of those medical conditions, whether you have an ICU backup in your setup, whether different kinds of monitoring are available, and whether resuscitation and help is available wherever you practice. So there are multiple ways and multiple anesthetic techniques which can be used, and our very own AORA has done a wonderful job in acquainting all of us with wonderful and very much possible techniques, regional anesthetic techniques to be used in compromised patients. However, continuous epidural anesthesia and spinal anesthesia still hold a lot of charm, one because of the simplicity of these procedures and because of the comfort of doing this for so many years. But there are issues with both of these. The epidural anesthetic technique doesn't give good relaxation in difficult spines. It's difficult to access the epidural, and probably unintended dural puncture can happen. Single dose, we have already checked just revisited all the challenges posed by a single dose spinal anesthetic. Certainly in these challenging situations, a continuous spinal anesthetic can be considered. So before we go into further details of how it is exactly to be done, we must quickly check out what are the factors which affect the level of the spinal blockade. There are multiple influences. The most important of all being the characteristic, the local anesthetic solution that we use, its varicity, dose, the concentration at which we use, and the volume that we inject. Patient characteristics or the technique of your spinal block and the diffusion characteristics of the CSF also influence, but not to that great an extent. So we'll just see a little more about these. In the elderly, the problems are slightly different when you use a neuraxial blockade, basically because the number of neurons within the spinal cord are reduced. The myelin sheaths which cover the neurons have deteriorated, and the connective tissue barriers also reduce, and therefore the diffusion is much quicker. Because of changes in the configuration of the lumbar and thoracic spine, the level of action for the same volume that is used can increase, and the CSF volume is also reduced. So all these contribute to altered block characteristics, which means there is an alteration in the dose-response relationship. So not only in the elderly, but in any patient profile, there are two very important factors which affect the block height. One is baricity, the other is the volume that we inject. Now the baricity, we have two kinds of solutions available, isobaric and hyperbaric. In the elderly especially, the effect of using isobaric solution is only marginal, or the effect of isobaricity on the block height in elderly is marginal, which means it's more predictable. Whereas hyperbaric solutions in the elderly cause a higher sensory block, a quicker onset of motor block, and causes more vasodilatation with hemodynamic consequences which are evident. Now, most of us tend to use slightly lower than normal volumes in the elderly. However, I know a few who use very low doses, that is maybe up to 4 milligrams of bupivacaine in the elderly patients. Now, the problem with using low and very low volumes or the neuraxial blockade or the spinal anesthetic in elderly is one who could probably have no block in the spinal anesthetic at all. Or you could achieve a good sensory level, but there is no to poor motor action. Or you can, if you're lucky, and as it happens most of the times, you get a good sensory and motor block. However, this acts only for a short duration of time, and if your surgery gets prolonged for some reason, you may have difficulty in continuing the anesthetic, or you'll have to think of an alternative. So if you increase the volume, you tend to have hypotension. If you reduce the volume, the duration is shorter and you may have patchy action. So choosing the correct volume is always something of a challenging situation. It could be confusing, and even for the most experienced people, choosing the right volume is of concern. Now, there are wonderful papers, and I have picked up about 4 of these papers published in the last 5 years, where they have conducted huge number, tens of thousands of patients. They have conducted studies on what is the association between hypotension and organ injury in the elderly and high-risk individuals. All of these papers have concluded that 5-day and 30-day mortalities are both higher in high-risk elderly patients with hypotension occurring perioperatively. So adverse postoperative outcomes are associated with both duration and degree of intraoperative hypotension. So what kind of organ injury? Typically, they have picked up myocardial infarction or myocardial infarction after non-cardiac surgery. And both of these were quite high and resulted in mortality between 2 and 3% within 30 days of surgery. The incidence of myocardial injury after non-cardiac surgery was most likely if the systolic blood pressure was lower than 100 and heart rate was more than 100 beats per minute. Surprisingly, they also found that higher systolic values of more than 160 was also associated with MINS, which is myocardial injury after non-cardiac surgery, and myocardial infarction. So we need to work with a fairly narrow range of systolic blood pressures in the elderly to be able to reduce the adverse postoperative outcome and to reduce their in-hospital stay, and therefore reduce the burden not only on the family but also on the hospital's occupancy. So there is certainly a very positive correlation that, so it's logical, and there are papers which have also been published that intraoperative hypotension leads to perioperative events which lead to cardiac, kidney, or cerebral injury. So it all means that you have to choose an anesthetic technique and prevent hypotension. Preferably keep your systolic blood pressure between 100 systolic and 160 systolic, and try not to let the heart rate go up beyond 100, because all of these increase the chance of adverse postoperative outcome. So when you choose an anesthetic, you have to be able to assure that you are able to prolong the anesthesia for as long as is required, that if you are able to titrate, the titratability has to be predictable, which is not really the case with epidural anesthesia in few cases. Because you're using a catheter-based technique, incremental dosing should be possible. This should also give hemodynamic stability while at the same time not compromising on the surgical anesthesia. The muscle relaxation has to be good. This can be an issue when you're using an epidural technique. So in your mind, keep comparing single shot anesthesia with continuous epidural anesthesia and compare it with what advantages a continuous spinal anesthetic would offer. It all boils down to the fact that if we could provide a safe continuous spinal anesthetic, there is nothing like this technique. So what kind of indications are there for which we use the CSA technique? The sick, elderly, morbidly obese, previous spinal surgery in whom single shot techniques or epidural techniques may not result in predictable action, laparotomy when GA may be less preferable for whatever reasons, and especially in the days of COVID, all of us have tended to try and avoid general anesthesia wherever possible. If you want to give immediate or analgesia up to the first 24 to 48 hours. We're using the same catheter that has been inserted, or obstetric patients with cardiac disease. So now this part of the lecture onwards is the actual practice of the CSA technique. So CSA can be conducted if you have made an unintentional dural puncture, or you could electively decide to conduct a CSA and make an intentional dural puncture, put in the needle into the intrathecal space and introduce a catheter there. Depending on the size of the catheter that is used, 24 gauge and lower, it is called a macro bore catheter. 25 gauge and smaller are micro bore catheters. Why is CSA then not so popular if everything is so fine with it, and all the problems that a single dose technique has is being covered by the continuous spinal technique? We need to revisit history to understand why this problem has occurred. Since August Bayer first gave the spinal anesthetic in, I think, 1898 or so, there have been multiple techniques devised to provide a continuous technique. So it's not anything new. The continuous anesthetic technique, many people have thought about it since the early part of the 20th century. In 1906, Dean introduced an intermittent spinal anesthetic in which he left the needle in place and intermittently gave anesthetic through it to prolong the surgery, to prolong the anesthesia. The techniques that came later were not really satisfactory. Malleable needles were introduced, 12 gauge needles were introduced with 15 gauge ureteric catheters. So all of these very predictably ended with patient complaining of severe post-operative headaches. And so it didn't really gain in popularity at all. What was concluded over many decades was that a finer bore catheter needed to be introduced to reduce the headache. So accordingly, in the latter part of the 1980s, 26 gauge introducer needles, spinal needles with 32 gauge microbore catheters were introduced with US FDA approval. This was used for maybe perhaps 4 or 5 years, before which, after which, a very important landmark paper published in 1991 about 4 cases of cauda equina syndrome, in which the patients developed urinary and bowel complaints and some extent motor dysfunction in the legs as well, following a continuous spinal anesthetic. 3 of these were done with microbore catheters and 5% lignocaine, and 1 patient had paracaine and an epidural catheter. After this paper, there were many other sporadic reports of cauda equina syndrome occurring with 5% lignocaine and microbore catheters, and the US FDA very promptly banned the use of these microbore catheters in 1992. Everything took a backseat till the early part of the 21st century, when some more investigators found out that 5% lignocaine was the cause. Then AstraZeneca and other companies which were producing 5% lignocaine withdrew their lignocaine, and hyperbaric lignocaine is no longer available. Now let's just quickly see what is the meaning of cauda equina syndrome and transient neurologic symptoms that occur because of a spinal anesthetic. So these actually encompass a syndrome or a basket of symptoms where patient complains of either back pain and or dysesthesia radiating bilaterally to the legs or buttocks. Rarely, patient can even have reduced motor power in the legs. Cauda equina syndrome occurring with 5% lignocaine has been reported to vary between 10 and 40%. Intrathecal lignocaine is 7 times more prone to causing cauda equina syndrome as compared to bupivacaine, prilocaine, or procaine. The more concentrated the solution is, the likelier it is to cause the syndrome. If there is a sacral maldistribution of local anesthetic, that means pooling of local anesthetic in the sacral area where all the nerve roots which exit from the lower part of the lumbar vertebrae or the sacral vertebrae are exposed to higher concentrations of solutions, the chance of having cauda syndrome is higher. Also, in very high lithotomy positions or and lithotomy positions given for extended period of time, neural ischemia secondary to sciatic nerve stretching has also been a contributory factor. So since 1992, when they were first reported to the present, there have been multiple changes which have occurred in the needle and the kit that has been made for the CSA. The Quincke needles have been replaced by Sprott needles. The end holes in the catheters have been replaced by side holes. The recommendation is to introduce the needle and the catheter in the cephalad direction and keep the catheter less than 5 centimeters in situ in the intrathecal space. Lignocaine has been replaced by bupivacaine or ropivacaine. Isobaric solutions may be preferred to hyperbaric solutions. And because all of us have become more aware, there is better monitoring and we are able to pick up these symptoms earlier on and implement and institute reparative measures as necessary. And of course, skin preparation to prevent infection has been a very important part in each one of us, our practices. So what are the advantages of using CSA? The single most greatest advantage of the CSA technique is the ability to titrate doses. You can give really small doses. You can use diluted doses if necessary, if you think that diluted doses can work well, especially in the super elderly age group. It affords great hemodynamic stability and much lesser toxicity because smaller doses are used. And the anesthetic technique or the anesthetic action is much more predictable than a continuous epidural anesthetic. So what are the disadvantages? Again, a PDPH is likely to occur if you're using it in the younger age group. That means for obstetrics, if the indication is an obstetric anesthetic, the chance of PDPH is higher. In the elderly age group, PDPH is not that common at all. But more, in my practice at least, or the way we have practiced or the indications for which we have chosen, technical difficulty is more common, technical difficulty and failure more common than PDPH. If it's a technically difficult insertion, or if you think that it has not been possible to introduce it with a kit, you can certainly try an epidural needle with an epidural catheter, but both of them introduced into the intrathecal space. This makes it easier. But sometimes the anatomical variation in the spine itself is such that it's not possible to introduce any of this. And that's one of the disadvantages of this technique. One has to take all precautions to prevent infection. And if we pay attention to the kind of local anesthetic solution we use and the volume and the total dosage that we are giving, then neurologic symptoms are likely to be prevented. So what are the sets that are available? One is, if we can divide these sets broadly, one would be a catheter over the needle. The other is a catheter through the needle. Catheter over the needle is a more complicated technique where Wiley has a set in which an introducer needle with a 2He kind of end is introduced into the epidural space, through which a spinal needle which has a catheter braided over it will be introduced through the 2He needle. A dural puncture made, the needle enters the intrathecal space, and then the 2He needle is removed. It's a peel away kind of epidural needle that will be removed, and the intraspinal catheter will remain in the intrathecal space, and the needle which gained entry can be removed and the cannula attached to a catheter later on. This is a closer look to how this is a fairly complicated technique. It can be quite nightmarish. I have seen people using this, though I haven't used it myself. This is another kit by B. Braun. It is called Spinal. I'm not sure if these two are available in India. And I am told that the learning curve for using this is very, very prolonged. And I have used this Payung catheter through needle kit, and this is very easy to use. And it's a technique that is familiar to most of us. The first part of preventing failure or reducing the difficulty is to familiarize oneself with the kit. So let's just have a look at what the kit comes with. It comes with a spinal needle, which is a 21 gauge Sprott kind of needle. This is how the needle tip looks. It is a blunt nose needle with a side hole through which the catheter can be removed. It also comes with a cassette, much like we introduce a CVP. The catheter for the CSA technique is housed in the cassette. Then it also comes with a locking assembly and a filter. So this is a close-up of the needle. Now I will first show how there can be technical difficulties while introducing. The needle has gone in easily enough. The CSF tap has been obtained. We are doing this in a sitting position for a patient who is posted for a pelvic surgery or prostate surgery. Now it's just like when you introduce a CVP line, the needle has gained access into the space that you want, and the catheter has to be introduced there. So you hold it against the thumb guard and you just thread the catheter in. You also measure the distance or the depth of the intrathecal space by measuring the distance. These needles are graduated, so you're able to measure the length that is inside. Now, if there is difficulty in introducing for some reason, one has to be very careful and not push with force. If there is such a difficulty, because we have earlier mentioned that the needle is blunt nose and the tip can be abutting against the anterior part of the vertebral body anteriorly, you just pull out the needle by a millimeter or so and then try and reintroduce. Always remember that if the catheter has gone beyond the epidural needle hole or the spinal needle hole, you should not withdraw the catheter through the needle, and the entire assembly is to be withdrawn in one piece. So in the same patient, we tried withdrawing the needle, but we were unable to thread. We tried a paramedian approach, again got a spinal tap. So obtaining a spinal tap is not difficult in most of the cases. It's the introduction of the catheter which can pose difficulty. Now here I have on purpose removed the catheter out of the cassette because sometime in the past some person in the audience asked me, will it not be easier if you remove it from the cassette? Now you see how difficult it is to introduce the catheter if it is partially or fully removed from the cassette. It cannot be fully removed, but partially it can be. It makes it more difficult and more challenging. Therefore, I would suggest that you try not to remove it from the cassette and keep it within, and do not force the catheter through the needle. It walks in beautifully. If you're in the right space, it just walks in beautifully. And when you're introducing, always keep an eye on the needle marking at the skin and the catheter marking as it enters the needle. So here you can make out it's a 9 centimeter needle, 3 centimeters is outside, and the catheter is at the 20 centimeter mark there. So about 7 to 8 centimeters is the length of the needle from the skin to where the catheter enters. So if we leave it at 20 centimeter mark there and remove the needle, we have about 12 to 13 centimeters at the skin. So you will notice this is at the 13 centimeter mark. Then you withdraw the catheter further to leave just about 2 to 3 centimeters inside the intrathecal space. Since we got the depth of the space was 6 centimeters, we are leaving at about 8-9 centimeters. Once the catheter has been introduced, and way of checking is to look for a drop of CSF. This is very reassuring. It's not necessary that you will find this drop of CSF every time, but seeing this reassures you that you're in the right space. Now, for most of you who have already, sort of decided, oh no, this is too difficult. What if this happens? This happens not so commonly. This is a small video to show that it is really not difficult to introduce it. It is fairly easy if you have good anatomy and if you have chosen the space well, you are able to introduce it fairly quickly. Again, notice that we've kept it at the 20 centimeter mark where this is entering. And once the catheter is introduced, the entire catheter comes out of the cassette, and the guide wire, or the stillet, very fine stillet, which is inside, will be removed. Only then the catheter comes out of the cassette assembly, and the needle can be removed. At every step, one must ensure that you can see the CSF drop. Once the catheter is introduced, we need to fix it. Now, the fixation is as important as introducing the catheter, because this is where the next part of the drama begins. The catheters are fine. They're not like epidural catheters. So kinking is an issue. So how you fix it is very important. The angle at which the catheter comes out of the skin, the angle at which the catheter has been introduced, all of these determine whether there is kinking or not. Personally, I find using the paramedian approach reduces most of these problems, and using this catheter fixation device that is there for the epidural catheters, which comes with the Portex set, affords me greater comfort and security, knowing that kinking is unlikely to occur, or even migration is unlikely to occur. And again, at the end of this step, we check that the CSF drop is still present. Then this is attached to the connector which comes with the filter, bacterial filter. Now you can attach your syringe, which you have prepared, with the local anesthetic solution, which is, in this case, we are using bupivacaine. I use isobaric bupivacaine or hyperbaric bupivacaine or isobaric ropivacaine. Any of these in different concentrations based on the patient's complexity, any of these can be used. All of these give good results. Isobaric tends to give much more predictable result than hyperbaric, but isobaric takes a slightly longer time to act. One more way of reducing anxiety of whether your action is going to be adequate or not is introduce the catheter in the induction room if you have the luxury of having an induction room or a procedure room. Introduce it, tape it, give a small dose to check that your injection is happening adequately. And then when the patient is wheeled into the operation theater, just give the induction dose. Wait for the action. It takes a couple of minutes and you're good to go to give the position to the patient, and scrubbing and everything else can be done subsequently. The induction dose, or the first dose that is given, is generally about 0.5 cc. This is what I use. 0.4 cc is the dead space or the filter with the catheter. And I give 0.5. So 0.1 cc actually enters the intrathecal space. Once you have ensured that 0.5 has gone well, the next subsequent doses can be in 0.25 cc increments or 0.3 cc increments, or you can even give 0.5 cc depending on what comfort level you have and the patient's medical conditions. So you can give very small doses, wait for a couple of minutes for the action, check for the action, check the adequacy of the level that or the blockade that you have achieved, and then go ahead. The first dose, the duration of the first dose typically lasts 40 to 60 minutes. You need to give a top up at the end of that, depending on whether you have used double diluted solution or whether you've used very small induction dose. So the duration of action varies. The second dose again can be similar concentration and dose because you have learned something from the first dose that you have given. So you can decide whether to use double diluted, whether to use slightly more concentrated and smaller volume, bigger volume, or similar volume to get how much longer the surgery is likely to, go on. So these are multiple things that you consider before you decide what should be the second and third dose. We have never used, even for 4-hour surgery, a dose more than 2 to 2.2 ml. So it has been an international recommendation even to not exceed dose of 4 ml in any patient. And this is unlikely to happen. This is another video to show a second method of fixation. You could use this IV adhesive transparent dressing, which is Tegaderm. But using this, you have to be careful. You can see, if you noticed carefully, that there was a kinking where the catheter entered or exited from the skin. So at the end of surgery, when the time comes for removal of the catheter, you can keep the catheter in to provide postoperative analgesia, and you could use very diluted doses of local anesthetic. You could add an opiate to it, or you could give a small dose of opiate at the end of surgery, which will give you analgesia for the next couple of hours and remove the catheter. Or leave the catheter in situ, maintain strict aseptic technique, even in the recovery room and later on. However, in my setup, I never ever used it for postoperative analgesia. Always the catheter was removed at the end of surgery in the operation theater after a very small dilute dose of opiate was given through it. Because the catheter has a dead space of 0.4 ml, one has to be aware that you have to flush it. When you, at the end of surgery, when you want to just say, all right, let me give a dose of opiate and let me get out, you will be injecting 0.4 ml of the local anesthetic, whatever you used. So the anesthetic action can get repeated. So you have to factor that in during the surgery itself and use dilute, normal saline or something to flush out what is there in the catheter and the filter assembly, and then use it for an opiate for postoperative analgesia. While removing the catheter, it's always best to remove it in the same position that you put it in. Of course, if you put it in the sitting position, it's not possible to lay them or make the patient sit again. Then lateral position is the position that is used for removal. Sometimes there is difficulty in removing the catheter, then flexing the spine opens up the spaces and helps make it easier. This is to show that the holes in the catheter are side holes and not end hole. This is another video to show how the tensile strength of this catheter. It's extremely stretchable. The catheters are made of polyamide, extremely stretchable, fairly distensible, and the catheter breakage is not common at all. But once it gets stretched for some reason like this, if it gets caught in something and gets stretched, though it may not break, it is not possible to inject anything through this. So try and avoid stretching the catheter, because this will become useless otherwise. So can CSA be performed only in the lumbar area, or can we perform it in thoracic? Dr. Naresh Paliwal has a lecture in the latter part of the session today. He will be talking on segmental spinal, and a great part of what he talks will be spinal anesthetic given in the thoracic area. Though I have not done it myself, this is a wonderful paper by Starnari and Associates, published in Minerva Anesthesiology. It's in Italian. This is the only center that I am aware of which does thoracic CSA on a regular basis. This is a wonderful paper that they published on 90 patients. It was a retrospective study who underwent major abdominal surgery. A 21 gauge needle and a 24 gauge catheter were used. Introduction of the catheter was at the T6-7 or the T10-11 levels. Bupivacaine heavy or levobupivacaine along with fentanyl were used. This was the sole anesthetic used in all cases except in one where general anesthesia was required to be given. All patients were continued with postoperative analgesia, very dilute doses of levobupivacaine, and fentanyl combination was used for post-op analgesia for up to 3 days. Nearly 70% of the patients required intraoperative noradrenaline, though at small doses of 0.2 to 0.3 microgram per kg per minute. And these did not need to be continued post-operatively. Their hospital mortality was about 5.6%. But of interest here in this paper was that the delirium occurred in about 14% of patients, which is lower than the rate of delirium in patients who have received general anesthetic or in patients who have had a lot of hypotension. So what are the do's and don'ts when you're conducting a CSA in your setup? First, let's look at the don'ts. Do not withdraw the catheter through the needle shaft. Remove the entire assembly together. If you insert it longer than 2 centimeters and keep it within the intrathecal space, it's likely to get caught up between the nerve roots and you may have difficulty in removing it. Or if you go too high up or too low, you need to give higher doses to achieve adequate blockade. And this can again result in higher concentrations and pooling of local anesthetic and a good setting for cauda equina syndrome. Do not exceed the maximum recommended dose of whatever anesthetic you're using, again, for the same reason that you want to prevent cauda equina. So what are the do's? Insert the needle around the center of the area to be blocked. This is true for whether you're giving a single shot anesthetic or whether you're using a CSA. Personally, I find a paramedian approach easier than a midline approach, and few other authors have also found this. Take all precautions to prevent infection. If you feel you need to glove and gown yourself up, feel free to do so. All precautions must be taken because infection can be very disastrous for the patient. The initial dose can be given in the supine or in the lateral position, depending on what kind of surgery. If it's a neck femur surgery, you have not given a block and the patient is having pain, multiple factors will determine in what position you're giving this. Always start with smaller volumes. You can even give diluted volumes, check what the patient's response is, and then you can up titrate or down titrate your next doses. It's okay to use fentanyl, which we use commonly. Then I always tend to use just 10 microgram of fentanyl with my dose and try and not exceed 25 microgram in the entire surgical duration. So the first dose would be 10 microgram. And if I need to give a top up at the end of the hour, then I add another 10 microgram and the next doses would have about 5 microgram and I don't exceed 25 microgram throughout the surgery. So I have always removed at the end of surgery, but there are authors who use it for postoperative analgesia. So the best way to start, if you have never done this before, is to convert an unintended, if you have tried an epidural and you have caused a dural puncture, go ahead and put in a catheter through it, maintain all aseptic technique and convert the wet tap into a continuous spinal anesthetic and follow the same dosing schedule that we just discussed. If you keep the catheter in situ for 24 hours, then it's likely that the incidence of PDPH also reduces. So before you say this is not possible or it's risky or give it a try, see how you feel. Maybe you get comfortable with it and certainly give me a feedback on how you found this. Thank you.
Thank you, Malti. That was a very comprehensive talk. I think you have answered most of the questions in your talk. But Dr. Bharne sir, do you have any comments or anything you want to ask?
Yeah. Thank you, Dr. Malati, for your excellent and elaborate overview of CSA. My question is, I am doing a lot of orthopedic surgeries in quite elderly patients. How do we use this technique for postoperative analgesia?
So the thing is, I have never used it for postoperative analgesia, basically because I have no trust in our paramedical services postoperatively. So what I have always done is, especially in periprosthetic fractures with very long incisions, I give a fentanyl dose with very diluted ropivacaine towards the end of surgery or just before we are shifting the patient, and remove the catheter in the OT and then shift the patient to the recovery room or to the ICU, wherever it is, and then maintain any other kind of analgesic, or maybe even give a block, a femoral block or a 3-in-1 block later on. That will just prolong it for some period of time. I don't use this for postoperative analgesia. There are some centers, like I told you, in England and probably Germany, and the one in Italy that I know of, which use very low doses of ropivacaine or levobupivacaine. They use even 0.1% bupivacaine along with fentanyl, 0.2 microgram per ml, and they use it in the wards. They don't even keep these patients in the ICU. But I'm not sure if we can do that in our kind of setups.
One suggestion,
Yes, sir.
to popularize it, you can hold workshops of this technique in near future, if possible.
Yes, sir. Actually, the thing is the kit itself costs about 4,000 rupees. The Payung kit is available. It costs about 4,000 rupees. The epidural set, which is 800, depending on which company you use, between, let us say, 800 to 1,500 rupees. Using it in workshops will probably be more possible if you're doing it virtually. Using it on patients may be more of a difficulty, because these are generally, we do it in medically complex patients. You already have many things on your mind. So I'm in these instances, I am a little against live workshops.
Thank you very much.
Thank you, sir.
Thank you, sir. Dr. Naresh Paliwal, sir, wants to ask Malti that
Yes.
do you use hypobaric drugs?
Hypo?
Hypo.
No, not hypo. But when we double dilute it, if we double dilute isobaric, it tends to become a little hypobaric. This has to be kept in mind.
Paliwal, sir, does that answer your question?
Basically, isobaric drugs are on the side of being little hypobaric.
Yes, sir.
And if you can use hypobaric drugs, you can further reduce the hemodynamic fluctuations actually for lateral position surgeries, or for surgeries which are in prone position. You can use a posterior spinal anesthesia, which only blocks the posterior roots, that is sensory roots. That can be taken with advantage using hypobaric drugs when catheter in situ. And another question I want to ask is, which bupivacaine do you use? Because bupivacaine isobaric is, I don't think it is available.
No, bupivacaine, either levobupivacaine or hyperbaric bupivacaine. It is not isobaric ropivacaine is used, or hyperbaric bupivacaine, which is double diluted.
Hyperbaric will remain hyperbaric only. Whatever
Yes,
dilution you do, just the concentration will be reduced.
I
Because
think
already there is
levobupivacaine
8%.
is isobaric. Levobupivacaine is
Yeah,
isobaric.
levobupivacaine with density of 0.9990 is on the verge of being little hypobaric, and with addition of fentanyl, it further becomes little hypobaric.
Yes.
And if you use the sitting position, the tendency is that the block level may remain a bit higher than desired while
So that
using
is why
these drugs.
using the first induction dose in sitting position has to be considered based on the surgery for which you're giving the anesthetic. Giving the first dose in whatever position that you have introduced. That is why those slides about baricity and volume were very important, because you have to have a clinical basis for deciding which dose you want to give when and in which position.
Yes. And last question is, do you use saline before removing the catheter to prevent the PDPH? There are recommendations that if you use 10 to 20 ml of normal saline before removing the catheter, you can prevent the PDPH further.
A very, very great chunk of what we have done are all in patients who are elderly, 65 plus. I have never had a single incidence of PDPH in that age group, even when we have used 18 gauge epidural needles with catheters through them. But in the one instance we had used in the obstetric patient, we left the catheter in situ for 24 hours, though we did not inject anything. There was a mild headache on the third and lasted till about the fifth day, but then it was very mild. I do not use a saline flush regularly, but I keep the catheter in situ in very young. we had another orthopedic onco case which went on for nearly 12 hours or so. There was a huge tumor to be removed from the femur, in which case in the young patient, and because of economic constraints, this became an easy thing to use. This patient did have PDPH. So depending on the age, whether irrespective of whether you use a saline flush or not, the chance of having PDPH is higher, but the volume of cases in which I have done in younger age group is not so much for me to be very able to confidently conclude about this, but this is what the literature says.
Okay, madam. Thank you.
Dr. Yogendra sir wants to ask one question. I think we'll take this as a last question. And Dr. Malti, there are a lot of questions for you in the chat box. It will be good if you can answer, because of short of time, we can't take all the questions here.
Sure.
Dr. Yogendra sir. Sir, you are, Dr. I think Sandeep, you have to unmute, sir. Yeah.
I have already answered a few questions on behalf of Dr. Malti.
Okay, thank you.
This is my own very favorite method of giving anesthesia.
Wonderful.
Dr. Naresh Paliwal did comment about levels and all those things, but the level doesn't go anywhere higher than what we want. I have always kept my catheter for 24 to 36 hours, but I have always knotted my catheter at the distal end. I don't want anybody else to come and feel pity on that patient. Let me give something epidural, he'll be painless. And that will be a disaster for all of us. So I have never done. And that injection of 20 ml, once I connect my syringe to the system, I don't like to disconnect that syringe because I do not want any chance of sepsis inside. Whatever I injected, I just simply disconnect and knot it up. After that, I don't want any more injection in that. But an excellent technique. Surprisingly, everyone talks about PDPH. I have also never seen a single PDPH in my time that I have been using. Thank you very much. It was an excellent talk. Very good.
Thank you very much.
Thank you, sir. Thank you, Malti. It was a very comprehensive talk. Now I request Dr. Bharne sir to felicitate Dr. Malti with floral bouquet on behalf of ISA Thane.
Thank you.
Thank you. I thank you, Dr. Bharne sir, for chairing the session. I would like to felicitate sir with a floral bouquet. Thank you very much, sir, and thank you very much, Dr. Malti.
Thank you very much.
Yeah.
Thank you.
Dr. Malti, if you can answer the questions, there are a lot of questions in chat box and Q&A section. Yeah.
Yes.
Okay. Thank you.
Doing it. Thank you.
Yeah. Over to you, Dr. Manisha, for further proceedings.
Thank you, Dr. Bharane, Dr. Malti, and Dr. Nilima for that excellent session. I have realized that we need to have Dr. Malti again with us for a whole day because there are lots of queries and lots of interest generated by this wonderful, wonderful topic. Thank you, Dr. Malti. Our next talk, the number of cases with coronary artery disease are increasing day by day. Soon, every third patient coming for surgery will be having a stent or some sort of coronary artery disease. How to handle these fragile hearts for non-cardiac surgery will be told to us by Dr. Deepak Tempe. The moderator for this session is Dr. Sonali Saraf. Dr. Sonali Saraf is a senior consultant at Jupiter Hospital, Thane, and her special interest is in transplant anesthesia. Over to you, Dr. Sonali Saraf.
Hello, a very good morning to all of you. For this session, I invite Dr. Anjali Bure as the chairperson. Dr. Anjali Bure is the Vice President of ISA National and Governing Council Coordinator. She is Professor and Head of Anesthesia at NKP Sarve Institute of Medical Sciences and Research Center and Lata Mangeshkar Hospital, Nagpur. Welcome, Dr. Anjali Bure. And for this talk, it's a great pleasure to invite Dr. Deepak Tempe. He is the Professor of Excellence, Department of Anesthesia and Intensive Care at JIPMER, New Delhi. He is the former Dean and at Maulana Azad Medical College and Associated Hospitals at New Delhi. And we all know Sir because he is an excellent teacher, for which he has received the B.C. Roy National Award as an eminent medical teacher in the year 2006. He was one of the first Indians to be associated with the editorial board of the BJA and the Journal of Cardiothoracic and Vascular Anesthesia. And he's author of many books and also has contributed to a chapter in our favorite Miller's Anesthesia. He had more than 150 papers to his papers published in various national and international journals. Welcome, Dr. Tempe, and we can begin the session.
Good evening, and thank you very much, ISA Thane, for this kind invitation, especially to Dr. Manisha, Dr. Sonali, and of course, my dear friend, Dr. Sunil Katkade. I'm very happy to be a part of this CME program. Please allow me to share my slides. Okay. So as you know, the longevity has improved, the life expectancy has improved. Consequently, the number of patients undergoing non-cardiac surgery who have associated systemic disease has also increased. And one of the commonest systemic disease is cardiovascular disease. And amongst the cardiovascular disease, it's the coronary artery disease that is very common among the patients who undergo non-cardiac surgery. Nowadays, almost every alternate patient is having some sort of a systemic disease in him, and that makes the job of an anesthesiologist very challenging. Now, in the recent few years, or maybe more than 1 or 2 decades, the guidelines for the patients with CAD undergoing non-cardiac surgery have been evolving, and there have been several updates, and also there are several unanswered questions in this area. With the result, although the topic given to me is patient with CAD undergoing non-cardiac surgery, I may like to re-entitle it as changing trends in anesthetic management of a patient with coronary artery disease undergoing non-cardiac surgery. So I'm mostly going to talk about the recent changes that have taken place in our understanding on this subject. I have nothing to declare. So let us try to understand what is the scope of the problem. Now, this paper that is published in 2017 has given this very interesting data that worldwide there are more than 200 million major non-cardiac surgical procedures that are being performed. And amongst them, 1 in 20 suffer from myocardial injury, infarction, or cardiac arrest, which results in death within 30 days. And the perioperative cardiac complications account for 1/3 of the perioperative death. So that's the kind of problem that we are having at our hands. And this another publication, which is slightly old now, 2012, but very interesting data, which shows how a patient who has suffered a perioperative MI versus no perioperative MI, the survival is so good, much better in patients who have not suffered perioperative MI at the end of 30 days and also at the end of 1 year. So, and if you probe it a little further, you will see that most PMIs occur within 48 hours of surgery. And the PMI is associated with 15-fold increase in the risk of in-hospital death, and also 4.3-fold increased risk of 30-day mortality. So from this, what is apparent is that I am convinced that the major objective that you should have while dealing with such patients is to avoid perioperative MI. So the entire team, the surgical anesthetic team and the entire perioperative team should focus its attention on preventing the perioperative MI. So in the next 25 minutes or 30 minutes, I'm going to talk about how to go about preventing the perioperative MI. So there will be less of anesthesia, but more of the other aspects of this particular issue during my presentation. So I would like to start with giving you two or three basic anesthetic principles whenever you are dealing with a patient who has got cardiac disease, any cardiac disease, not only coronary artery disease, but any cardiac disease who is subjected to non-cardiac surgery. Number one principle, if surgery is elective or less urgent and cardiac disease is severe enough to require surgical correction. So if the patient, in this instance, patient has got severe coronary artery disease which requires either intervention or CBG, and the non-cardiac surgery is elective, you should subject him to cardiac intervention first, either in the form of balloon angioplasty or stenting or coronary artery bypass grafting. Secondly, if the cardiac surgery or intervention procedure is not indicated, so he has coronary artery disease, but it is not of the magnitude which requires any intervention, and maybe just medical intervention or medical therapy is sufficient, then you should optimize the medical management before non-cardiac surgery and stratify the risk for that particular patient. Third principle is if surgery is of emergent nature. So now the non-cardiac surgery is of emergent nature, you cannot wait, and it does not allow sufficient time for treatment of cardiac lesion, although it warrants treatment by way of CABG or stenting, then surgery should be undertaken with low or elevated risk, and you need to optimize the cardiac condition before surgery. You can do it by either elective ventilation or by mechanical support such as IVP or injection of Lasix or some such thing. Or you can also, another option is to have a combined procedure. So you perform the CABG along with the cholecystectomy, CABG along with the gastrectomy or things like that. So even that option is there. So all your management is based on these fundamental principles of management. So that brings us to the question of preoperative evaluation. If we have to assess and tell the risk that is involved, then preoperative evaluation becomes very important. And I would like to make certain statements here. That is, pre-op evaluation is not simply to give medical clearance. Nowadays, many cardiologists and physicians, they write the patient is cleared for surgery. And even the anesthetist write a referral saying that please give your opinion regarding clearance for surgery. Now that kind of language is not warranted or not desirable, not recommended. What you should do instead, you should perform an evaluation of patient's condition. What is the severity of the coronary artery disease? How badly is he affected? And take into account the non-cardiac surgical procedure that is being performed and make recommendations concerning the evaluation, management, and risk of cardiac problems over the entire perioperative period. So that is the job of an anesthetist or any cardiac surgical patient. How do you do it? Now, the latest guidelines are not very recent. They are published in 2014 ACCHA guidelines. However, there have been several updates following this. These guidelines were published, so which guide us regarding the management of these patients. So this presentation will be mostly based on these guidelines and based on my own experience as well. Also, the 2014 guidelines clearly mention that the decreased trial by the Poldermans, which formed one of the major components of recommendations related to perioperative beta blocker therapy, has been withdrawn. It has been found to be fraudulent, so it has been withdrawn. Therefore, now it is made clear in 2014 guidelines that they should not be considered, and you have to assess the guidelines subtracting or eliminating the Poldermans result. So I will touch upon it later on also. So if you look at the 2007 guidelines, there are some term which was used as active cardiac conditions. What are active cardiac conditions? Unstable coronary syndromes, decompensated heart failure, significant arrhythmias, and severe valvular disease. So if you eliminate valvular disease, because we are talking of coronary artery disease, if the patient suffers from unstable coronary syndrome or decompensated heart failure or significant arrhythmias, this patient will not undergo any non-cardiac surgery. Most of the times, he will be in coronary care unit for the treatment of the cardiac lesion itself. And I used to talk about this long time ago, and also I will find a mention of this in my book, that this is redundant, this should be eliminated, and that is what the 2014 guidelines have now eliminated, this kind of approach. So the basis for this is related to what I just mentioned. So let us look at what are the risk indices. Now you want to assess the patient. So what are the various risk indices? So very briefly, let us discuss some of the important risk indices. So we have now revised cardiac risk indices, and there are 6 in number. So history of ischemic heart disease, history of heart failure, congestive failure, history of cerebrovascular accident, vascular surgery. Now that's a surgery kind of non-cardiac surgery. So this this is taken help of in the algorithm that the guidelines have proposed. Insulin-dependent diabetes mellitus and preoperative creatinine more than 2 milligrams per deciliter. So these are the revised cardiac risk factors. And if there is 0 to 1 risk factor present, then there is a low risk of major adverse cardiac events. If there are more than 2 predictors of risk, then there is an elevated risk of major adverse cardiac events. You should also take into account the non-cardiac surgical procedure. So there are 2 categories nowadays, the low risk and the elevated risk. The intermediate category, for reasons unknown to me, have been eliminated by the recent guidelines, but I think they are important. So any procedure such as major abdominal surgery, maybe Whipple's, where there's a lot of fluid shift and blood loss, etc., should still be considered as intermediate surgical procedure. So the less than 1% of risk of major adverse events, if it is a low risk surgery, and it's a high risk surgery, then the major adverse cardiac events are more than 1%. And a risk calculator has also been developed, which I'll again show in my next slide. And the liver and renal transplant patients, they constitute a separate entity. So they should be dealt with separately in terms of the non-cardiac surgical procedures, because they have a different scenario. For instance, the patients with cirrhotic liver, they have a lot of issues related to cirrhotic cardiomyopathy and arrhythmias. So they form a separate group of patients, and they should not be mixed with the kind of recommendations that I'm going to talk about now. So there are two newer tools of risk assessment created by the American College of Surgeons, and these are the NSQIP MICA risk assessment tools. That's the website. If you click on that website, you can enter all the patient data, the type of surgery, age, sex, the comorbidities, and you'll get a risk as to this much is the risk of major adverse cardiac event. So that's another tool that is available nowadays with us. And finally, I want to talk about the coronary artery disease itself as a risk factor. When I was a student, we used to talk about how to delay the surgery after acute MI or myocardial infarction to more than 6 months. So the results are better. But that even holds true even now, because in 2011, this paper was published, which has shown that if the interval between the myocardial infarction and the non-cardiac surgery increases, then gradually the postoperative MR rate decreases up to 6 months. And also the mortality, 30-day mortality also goes on decreasing to about 60 to 90 days. It stays nearly same after 3 months to 6 months. And if you see what happens if the rate of reinfarction as well as 30-day and 1-year mortality is decreased if a patient has been subjected to revascularization before non-cardiac surgery, either by way of stenting or by way of coronary artery bypass grafting. And CABG improved outcome more than stenting, especially if surgery is performed within 1 month. Now, this question is often asked as to how much should be the time interval between a patient who has undergone CABG and the non-cardiac surgery. Now, there are no definite guidelines or papers available to address this question. But if I show you what I feel that you should allow at least 4 to 6 weeks in order for the tissue healing to take place and the optimization of the medication. But if you really look at it, I'll show you some more data which says that if there is a recent MI of less than 6 months, it's an independent risk factor for perioperative stroke, which leads to 8-fold increase in the mortality. So if you look at this, then I would be inclined to delay any non-cardiac surgery for at least 6 months, even in patients who have undergone CABG. Now, this data that I have shown you also suggests that 60 days at least should elapse after MI and before non-cardiac surgery in the absence of coronary intervention. And if there is a coronary intervention, at least one month, but ideally 6 months would be best if you want to take into account the risk of stroke in these patients. Now I come to the algorithm that has been proposed based on these various parameters. This is the 2002 algorithm, very complex, several 8 steps are there, very complex. Let's not dwell upon it. Let's move on to the 2007 guidelines and where the changes have taken place. So in the 2007 guidelines, step 1 was whether or not the patient requires emergency surgery. If yes, then he undergoes surgery with whatever risk that he has to undertake. But if there is no emergency surgery, the surgery is elective, then you need to find out if there are any active cardiac conditions. And which are the active cardiac conditions? I discussed this. The unstable coronary syndrome, decompensated heart failure. For these, the patients usually do not undergo non-cardiac surgery. Even if he suffers from acute appendicitis and if he has got unstable coronary syndrome, the surgeons are reluctant to operate on this patient. And vice versa. If the patient develops acute MI after major non-cardiac surgery, the cardiologists are reluctant to perform any intervention in these patients. Why? Because the mortality is very high if you perform such interventions in these patients. So therefore, now there is a change from here onwards in the 2014 guidelines. So what do the 2014 guidelines say? If the patient is scheduled for surgery with a known CAD or risk factors for CAD. What are the risk factors? The 5 risk factors that I have shown to you earlier. I have eliminated the 6th risk factor, that is the type of surgery, which will be taken into account in the subsequent steps of this algorithm. So if the patient has this known CAD or risk factors, and if the surgery is emergency, then he should undergo surgery with whatever risk that is involved, and you take all due precautions. But if it's an elective procedure, then you need to find out whether or not he has acute coronary syndrome. If he has acute coronary syndrome, he goes to cath lab evaluation and cath lab evaluation and further intervention that is required. And if there is no acute coronary syndrome, then you need to evaluate. Now, in our clinical practice, for most non-cardiac anesthesiologists, it is this group of patients that will come to you. So you will have that he doesn't have acute coronary syndrome, he has coronary artery disease, and he has some risk factors. And you need to evaluate these patients to understand what is going to be the risk for these patients in terms of the non-cardiac surgery that is being proposed in these patients. So let us start from the step number 3. And how do we evaluate? So the revised cardiac index risk index that I have shown you, there are several others, NSQIP, that I have shown you. There are also others such as the Duke's cardiac risk factor evaluation, Duke's criteria. You can perform a 6-minute walk test to understand how severe is the cardiac disease. So all these risk indices can be evaluated. And if you find that he is low risk, so let us say he has only one risk factor, he has only history of coronary artery disease, everything else is normal, then he stands a low risk and you can proceed with the surgery. But if he has elevated risk, which means that his risk, he has more than 2 or 3 risk factors, his Duke criteria also suggests that he stands a higher risk, then you need to take into account the functional capacity. Now, I hope you understand what is metabolic equivalent of task, MET. There's no time to explain you all this, but in a person who has got a metabolic equivalent of more than 4, that is considered as adequate or acceptable, which means that the person is able to perform his normal day-to-day activities. So he can perform normal day-to-day activities and house chores adequately. So he has metabolic activity score of more than 4. And if it is more than 4 to 10 or more than 10, such as he can play a game of tennis or he can do swimming, then you can proceed to surgery, no further evaluation. But if his metabolic equivalent is less than 4 or it is not known, then he needs further evaluation. And what is the evaluation method? You need to, and evaluation is supposed to be performed only if it is going to alter your therapy or make a change in your plan for surgery. Maybe delaying the surgery is also one of the options that is there. In that case, you need to evaluate this patient further. But if any evaluation is unlikely to lead to any change, then you can proceed with the non-cardiac surgery. But if yes, then you should evaluate pharmacological stress testing, dobutamine stress echo, and if it is normal, you can perform the surgery. If it is abnormal, then he can be revascularized and then subjected to surgery. So although this is the algorithm, I would suggest that all of us, once you reach the step number 5, that you have the elevated risk surgery and there is a patient who has got coronary artery disease, most of us will proceed to evaluation. And that is what is in practice. We don't take into account the functional capacity. If it is good, then we just proceed with the surgery. So for the theoretic part of it, it is okay to know this step 6 and 7. But in clinical practice, I think that once you have elevated risk surgery, maybe vascular surgery, you should subject him to dobutamine stress echo or echocardiography and treadmill test if it is possible. So that's the algorithm. So for those of you who have not understood this algorithm, I have tried to summarize this in simple language. Number 1, history, physical examination, and CVS examination is must in all patients, because that will tell you whether patient has heart disease or not, whether he has got failure or not. Therefore, it is important. Patients with acute coronary syndrome undergoing elective surgery need to be evaluated and treated as per guidelines. So they don't go for non-cardiac surgery. They go to the cardiologist for further evaluation. And cardiac evaluation is required in patients who have poor or unknown functional class. So in summary, this is what the algorithm says. Now let us consider some important perioperative considerations. So we have understood how to evaluate the patient. Now let's take into account certain perioperative considerations. For that, a bit of pathophysiology of CAD. So here is a vessel which is occluded by a plaque. But see that this plaque is stable, and although there is narrowing, patient will not have any symptoms. But if the cap ruptures, if this plaque becomes unstable, this plaque ruptures, there will be a bleeding there and thrombus formation, and there will be acute MI in this patient. So when this patient who has a stable plaque undergoes non-cardiac surgery, if you produce sympathetic activation and events which lead to hypertension and tachycardia, and as you know, the non-cardiac surgery itself is a prothrombotic situation, so that will lead to creation of an unstable plaque. So our objective is to prevent this, maintain the stability of the plaque. And for that, certain medical management is required. Number one is the beta blockers. First and foremost are the beta blockers. A few words about beta blockers. Now, this paper that was published in 1996 showed that the patients who received atenolol versus placebo, their survival was much better as compared to placebo, as long as more than 2 years. And then, of course, this Polderman's paper, which I mentioned, which showed that in the patient who has got a CAD, which inducible angina is there, in them, if you give them bisoprolol versus standard care, there was a reduction in mortality of 30 times reduction in mortality at 4 weeks interval. And this formed the main basis of recommendation for beta blockers in the 2007 guidelines. But since this paper has now been withdrawn, this does not hold true. And based on this paper, the 2007 guidelines recommend the beta blocker therapy. So if the patient is undergoing vascular surgery, then irrespective of the nature of the disease, beta blocker was recommended. And if the patient has a high-risk coronary artery disease, then irrespective of the nature of the surgery, beta blocker was recommended. So there was a strong recommendation for beta blocker. Now this does not hold true. And what is post-2000, if you see, the literature started appearing, giving us evidence against the beta blockers. And in 2008, the POISE trial, which showed that although the myocardial infarction was less with beta blockers, the cerebral vascular events were higher and patients died of cerebral vascular events. And the focused update by ACCH in 2009, they recommended that initiation of therapy, particularly at lower risk group, requires careful consideration. So that was in 2009. And subsequently, this meta-analysis was published in 2014, which, clarified most of the issues related to the beta blockers. And this meta-analysis eliminated the Polderman's trial. And if you see that the 30-day non-fatal MI was marginally better in patients who were on beta blockers, and the 30-day non-fatal stroke was actually better in patients who were on placebo, and the 30-day mortality was also marginally better in the control group. So it proved that the conclusion of this systematic review was that the perioperative beta blockade started 1 day or less before non-cardiac surgery helps prevent non-fatal MI, but at the cost of increased risk of stroke, death, hypotension, and bradycardia. So beta blockers, although are useful from the cardiac point of view, they were harmful in terms of the cerebrovascular events. And therefore, the 2014 guidelines now have diluted the recommendations significantly. Class 1 recommendation only for those patients who are already on beta blockers. Class 2A, that means it may be beneficial. This has been significantly modified. Can you understand anything from this? Management of beta blockers after surgery to be guided by clinical circumstances. So what are the clinical circumstances? So it's a lot of subjectivity is involved here. So what is clinically relevant to me may not be to another person. So I will become very concerned if the heart rate is more than 90 and blood pressure is more than 130. The other person may not be concerned at these levels. So there's a lot of subjectivity in the current guidelines regarding the beta blocker therapy. One more recommendation is that class 3 recommendation, that is, it is harmful if you start it on the day of surgery. So this is about the beta blockers. The second group of medicines that you must take into account is the statins, which have excellent pleiotropic effect and membrane stabilizing effect, endothelial stabilization effect. And I'll just cite this 2008 meta-analysis again of 19 studies. Over 30,000 patients were included. The results are summarized here. So you see the patients who received statin, the mortality was less, the atrial fibrillation was less, and the stroke was less. So there is immense benefit in terms of statins if you administer it to patients who are having coronary artery disease and who are undergoing non-cardiac surgery. So subsequently, there are some more reports which showed in 2013 how the deaths are less in patients who are with statin. Another report which shows 5-fold reduction in reduced risk of 30-day all-cause mortality in patients who received statins. And this another paper, a recent paper, which has shown us that statins had a protective effect on major adverse cardiac and cerebrovascular events. So that's another important paper which has shown that not only cardiovascular but also cerebrovascular events are also, prevented or minimized with the help of statins. So there is a strong recommendation for statins, grade 1, class 1 recommendation, patients currently taking statins. Class 2A, that is, it is helpful. Patients undergoing vascular surgery, that's a elevated risk surgery or major non-cardiac surgical procedure. And class 2B, patients with clinical indications. So those patients who are already taking statins for some cardiac indications, lipid lowering effect, for instance, they are taking it. So in those patients also, you can continue these statins. Now I move on to the next important area, which concerns all of us, and that is patients who have undergone percutaneous coronary interventions. Now, if you see some of the papers, one published in 2001, now these patients are on dual antiplatelet. So they receive clopidogrel and ecosprin. And this paper has shown that as the time period of administration of these medicines increases more than 1 year, you see that there is a significant better outcome in terms of myocardial infarction, revascularization, and deaths. So they do very much better as compared to placebo, those who are on clopidogrel versus the placebo. And if you look at these two curves, I find that they are moving apart. So it seems as if I continue clopidogrel for longer period, this placebo will go up and the clopidogrel will stay where it is. So the effect will be even better. That is what it looks like from this study. Another paper, more recent, quite old now, but compared to the earlier paper, you see that the reduction in the myocardial infarction and deaths are significantly reduced as compared to those who are without clopidogrel. So clopidogrel, this is the bare metal stents with clopidogrel and drug-eluting stents with clopidogrel. They do much better in terms of the myocardial infarction and mortality. But there is a flip side to it. What is the flip side? There is a incidence of spontaneous bleeding. So if you look at this, the gastrointestinal bleeding and intracranial bleeding, spontaneous bleeding, this is nothing to do with trauma. And there are also deaths. So it is due to this reason that most of us did not follow the recommendations. So these were the earlier recommendations. Very straightforward. If patient has undergone balloon angioplasty, wait for 14 days. Bare metal stent, wait for 30 to 35 days. Drug-eluting stent, wait for more than 365 days if you want to perform non-cardiac surgery. But many clinicians did not follow these rules, especially neurosurgeons, orthopedic surgeons. They did not follow these rules. All of them discontinued clopidogrel, and many of them even ecosprin before performing the non-cardiac surgery. So these have now been revised in 2014, and I'll briefly go through this algorithm. So if the stent has been placed within 4 to 6 weeks and it's an elective surgery, then you have to delay surgery until optimal period, that is 30 days for bare metal stents and 1 year for drug-eluting stent. But if stent has been it's an emergency surgery, then you have to continue dual antiplatelet therapy unless the risk of bleeding is greater than risk of stent thrombosis. Now again, this is subjectivity here. So if the surgeon thinks that the risk is more of bleeding, then he will discontinue the dual antiplatelet therapy. And if the stent has been placed after 30 days but before 1 year, and he requires there is a risk of surgical delay is greater than risk of drug-eluting stent thrombosis. So if patient has got a cancer and we cannot wait for 1 year, then there is a provision here. So you can perform the surgery after about 6 months. And if there is no such risk, then you have to delay till 365 days. Secondly, if the drug-eluting stent has been placed more than 1 year now, or bare metal stent has been placed more than 1 month before the non-cardiac surgery, and if the surgery demands discontinuation of the antiplatelet, then you can continue aspirin and perform the surgery and restart the clopidogrel. If no, then you can continue the current DAPT regime and perform the surgery. Now, the major change here is that there is a provision for performing non-cardiac surgery 6 months after the drug-eluting stent has been placed, if the surgical delay is going to be counterproductive. Now, even this has been revised in the year 2016, and it is much more simpler now. So you have bare metal stent with the dual antiplatelet and drug-eluting stent with dual antiplatelet. So if it is bare metal stent, you wait for 30 days. You will produce harm if you perform surgery. So delay and perform surgery after 30 days. If it is a drug-eluting stent, then more than 6 months, it is permissible. You can proceed if this non-cardiac surgery is really indicated. 3 to 6 months, then there is a provision made, then you may consider proceeding. If this non-cardiac surgery needs to be performed, there is a delay is likely to be harmful in non-cardiac surgery. But in less than 3 months, there is still no recommendation. You cannot perform surgery before 3 months of dual antiplatelet drug-eluting stent placement. So now final part of my presentation is about the anesthetic goals so after having understood the risk factors and the various parameters that you take into account for the stent placements, then the two goals that you must have, anesthetic goals: patient should be pain-free and sleepy. That is our fundamental function. And secondly, you must maintain the hemodynamics. And maintenance of hemodynamics in patients who has coronary artery disease boils down to prevention of perioperative MI. So your sole objective is to maintain hemodynamics to such levels that there is the risk of perioperative MI is minimized. How do you do that? There is one more paper that I would like to cite here, which has been published in 2008. This is a new piece of information. So these authors showed that association between post-operative mean arterial pressure, a lower mean arterial pressure in the post-operative period was associated with high sensitivity troponin T levels, higher levels of troponin T levels, and the cutoff was MAP of 62. So I would suggest a cutoff of mean arterial pressure of 62 in post-operative period in those patients who have coronary artery disease and who are subjected to non-cardiac surgery. Now, we know that the inhalational agents provide pharmacological preconditioning and therefore myocardial protective effects. So this paper looked at whether the total IV anesthesia is better or inhalational agents are better, but they found that the patients undergoing non-cardiac surgery did not benefit from anesthesia based on halogenated anesthetics. So there was no clear-cut benefit provided by the inhalational agents. So there is still dispute whether we should use total intravenous anesthesia or the inhalational agents. Now, there is a big controversy about regional versus general anesthesia. There are many papers which show that the surgery can be performed with regional anesthesia. And there are several papers which show that the general anesthesia can also be useful. So the controversy will be going on. In my opinion, it is not the type of anesthesia that is important, but how the anesthetic is administered is perhaps more important. How the hemodynamic stability is maintained is more important than the actual anesthesia per se. So this paper I'm citing for regional anesthesia and pain, which is a very interesting paper. These authors showed that combined spinal anesthesia versus continuous spinal anesthesia versus propofol and or sevoflurane for hip fractures, they showed that bupivacaine was titrated to T10 level. And they showed that the number of hypotension episodes and ephedrine requirement was lower in continuous spinal anesthesia. That's very interesting. They're trying to justify that regional anesthesia is better than the general anesthesia. But there are several loopholes in this paper. For instance, the nature of cardiac morbidity was not defined. Total hip replacements were excluded, which lead to a lot of hemodynamic compromise. And propofol or sevoflurane alone is not the choice of anesthesia for general anesthesia in patients who have coronary artery disease. So, when you read such papers, you should not get influenced by these papers and try to use your, common sense and the literature that is available, which shows the justification of one technique over the other. And only then, you should adopt such techniques. Just don't blindly follow such papers. So briefly, there are several ways in which you can perform hemodynamic monitoring and which can range from ECG to the transesophageal echo, and depending upon the severity of the coronary artery disease and the nature of the non-cardiac surgery, you can choose this. But I'm just going to focus on the PA catheters controversy. It is now said that the PA catheters may be used only if the medical condition warrants, so that there is heart failure, severe valvular disease, or combined shock states which cannot be corrected before surgery. PA catheter is recommended, and there is no benefit. Routine use of PA catheters is not indicated. That's what the guidelines say. This is in 2014, but a survey performed in 2015 has shown amongst the SCA members that majority still continue to use the pulmonary artery catheter. But mind you, this is for cardiac surgeries. But I'm just trying to show you how the guidelines need not be followed by the clinicians. And the surveys, they depict a much different scenario than what actually the guidelines suggest. So this is for cardiac surgery patients. So this same thing may happen for non-cardiac surgical patients. Also about the transesophageal echo. Now there is a class 2A indication, and very important, if the hemodynamic instability persists despite the attempted corrective normal therapy, then TE should be performed if expertise is readily available. This is very important. You may have the TEE machine, but no operator to perform it. Then there is no point in following this guideline. This guideline is useful only if TEE is available and there is an expert person available to perform the TEE. And recently in literature, if you see, there are several papers I have seen that case reports. One paper I saw in obstetrics, a cesarean patient who went into LVF, the cardiac anesthetist was available, he performed TEE and the management was changed and the patient survived. So this has to be very carefully used, and there is no benefit. Routine use of TEE is not recommended in patients who undergo non-cardiac surgery and those who have pre-existing coronary artery disease. Now, there are various inotropes that are available at your disposal to control the hemodynamic management, and there is no time to discuss all these. But very briefly, I would like to say that if you want to have a good beta stimulation, use epinephrine. If you want to have beta stimulation with peripheral vasodilatation, dobutamine. If you want to have pulmonary vasodilatory effect, milrinone or amrinone. And if you want to have peripheral vasoconstrictive effect, use norepinephrine. So this is how I will try to summarize it. And so I would like to summarize the anesthetic management. And remember, opioids form, as for if the general anesthesia is to be used, opioid-based general anesthesia is the technique of choice, which will provide you the best hemodynamic stability. So proper preoperative evaluation is very important. Quantify the risk. Tell your patient what is the risk that is of major adverse cardiac events. Medications, you will have to regulate his beta blockers, statins, and antiplatelet therapy. Be a part of discussion of the multidisciplinary team. Tell your views and be sure about whether beta blockers should be administered or not, statin should be continued or not, and things like that. And hemodynamic stability, you must have adequate hemodynamic monitoring and appropriate choice of dosage of anesthetic agents. So whether it is spinal, epidural, or GA, I do not have evidence, clear-cut evidence to tell you that GA is better or regional is better. But so long as you are able to maintain hemodynamic stability, you will reduce the incidence of perioperative MI and the outcome will be better. So I would like to conclude that anesthetizing a patient with coronary artery disease has become a part of everyday practice. Anesthetic technique should be targeted towards preventing the perioperative MI. Guidelines in patients with implanted stents are more clear now, and it seems that non-cardiac surgery can be performed after 3 months of drug-eluting stent if there is an urgency of performing the non-cardiac surgery. And cardiologists should take into account the impending non-cardiac surgery. So if the cardiologist knows that this patient also has got prostate enlargement and he is waiting for his prostatic surgery, and he requires stenting, he should use bare metal stent or just do angioplasty so that his prostate can be removed after 14 days or 1 month, and subsequently the bare metal stent can be replaced by the drug-eluting stent. So this kind of approach should be there. This is where the multidisciplinary team approach is important. I'm sure that, thank you very much. I'm sure that there would be many questions in your mind because this is an area which is still evolving and there are a lot of gray areas. There are many unanswered questions. And if there are any, I would like to, I'll try my best to answer those questions in order to satisfy you. So thank you very much for your kind attention.
Thank you so much, sir. It was an excellent presentation and a very good this thing in terms of take-home messages that we have. There are quite a few questions in the chat box. Dr. Bhure, would you?
Yes. Sir, good morning. Very easy and nicely you have make us understand the concept of CAB patients coming for non-cardiac surgery. Sir, one question I would like to ask that you have mentioned about the risk stratification indices. Which index would you recommend, sir, in our practice?
I would like to go by the revised cardiac risk index. It's a very good index. So history of coronary artery disease, history of congestive cardiac failure, history of cerebrovascular events and diabetes and creatinine. These are very important risk factors. But in addition, I would like to take into account the functional capacity. It is very important that if a person can run 2 miles, then he is very unlikely to have, without angina, then he is very unlikely to have any coronary artery disease. So the kind of activity that an individual can perform, if he is able to perform, is very important in my view. But as you know, most of these patients are elderly, and they are, they have arthritis or they cannot walk. So it is very difficult to assess their functional capacity. So in that case, you may have to end up doing the between stress echo. But if a person, you can assess the functional capacity of an individual, it's a very good way of, assessing whether or not he has coronary artery disease or the severity of the coronary artery disease. So let me also clarify here that the severity of coronary artery disease is not related to the number of vessels. So a person who has got 3 vessel disease or 4 vessel disease is not more severe than a person who has got a single vessel disease. If a single vessel disease has produces inducible ischemia with small activity, then he is at more risk than a person who has got 3 vessel disease but easily managed by medication. So all these fineries are there. But in my opinion, the revised risk index is very good. Also, the NSQIP website, please do visit this website and play with it. Just put the patient morbidity, risk factors, age, sex, and the type of surgery, and it will give you the percentage of risk of major adverse cardiac events. So if you change those parameters, so in the beginning, if you have a 60-year-old male, then make it 80 years old. Well, keep all other parameters same, and you see how the risk changes. Yeah, so it's a very useful gadget that we have nowadays to assess the risk of these patients.
Thank you, sir. Sir, what about bridging therapy? What is the concept of bridging therapy?
So this is for the antiplatelet agents. You can use an agent such as tirofiban, which is has a short half-life. So you can start this. You can discontinue clopidogrel and give him tirofiban, which has a shorter half-life, so that the bleeding risk is reduced. And in the post-operative period, you can restart the clopidogrel. But it was described earlier, but I don't see much of its importance nowadays. Essentially, you should take into account the surgeon's views, that even involve an oncologist if possible, and the cardiologist and yourself. You can all sit down together and take a call whether you want to discontinue icosapent and clopidogrel or want to resort to the bridging therapy. So,
sir, perioperative hemodynamic stability, you have mentioned about the MAP. What about the heart rate, sir? Especially patients who are preoperatively taking beta blockers.
See, this is a very difficult question to answer. And if you look at the POISE trial, they had a cutoff of 50 beats per minute. So they administered beta blockers to anyone who had a heart rate of more than 50, which is a very strong cutoff. Nobody is going to administer beta blocker if the heart rate is 55 in clinical practice. I can only tell you my personal view. I would accept heart rates up to even 90 beats per minute. So at times it is very difficult to regulate the heart rate. You might end up producing some other problems in an attempt to lower the heart rate to less than 60 or less than 70. So I'm happy if it is less than 80, but I'll accept it up to 90. And only after 90, I would do something.
Very lucid, doctor. Thank you very much.
Ma'am, I'll just enumerate a couple of questions in the chat box about if the patient is not on a perioperative statin and needs to undergo surgery, would a single dose of statin make any difference? And secondly, there is a question also, if the patient is not on a beta blocker, as you said, a single dose of beta blocker in the preoperative period, would you start if the heart rate is more than 90 in that case?
Let me answer the statin question first. If the patient is undergoing any vascular surgery, then statin should be started, and I would delay the surgery for 3 to 4 days and start the statin. For all other cases, I will not start statin. For all other types of non-cardiac surgery, other than the vascular, which is a high-risk surgery, I will not like to start the statin. But for vascular surgery, yes, I will delay the surgery for 3 or 4 days. And many times our surgeons are also ignorant. I have found that they have posted in my practice. They scheduled a vascular patient undergoing aortofemoral bypass for without starting the statin in this patient. So I would delay the surgery and start statin in these patients. But other types of surgery, no. For beta blockers, as you know, the single dose beta blocker is not the recommended as per the recommendations. But in case the heart rate is more than 60, I will prefer to start the beta blocker a day prior or 2 days prior, because although the guidelines say that the beta blockers, if they need to be started, they should be at least a week before the surgery. But if your aim is to reduce the heart rate, why can't I start it on time, on table? If my heart rate is going up, just because he has not been administered beta blockers earlier for 7 days, it shouldn't stop me from administering the beta blocker. So I personally would be very much in favor of administering beta blocker if the heart rate is more than 90 or 100. And provided the depth of anesthesia, that don't treat tachycardia by beta blocker is that if the tachycardia is associated with hypertension, beta blocker is a must. But if the tachycardia is associated with hypotension, please do not use beta blocker.
Sir, another one quick question before we conclude the session. Are there any preoperative biochemical biomarkers available that we can ask for to quantify
yes,
the
BNP
risk?
levels. Yes, there is a recent paper which has looked at, I don't remember the exact value, but it's somewhere around 70 of BNP levels, which indicates that yes, this patient has got myocardial damage or injury already, and he stands a higher risk. So that kind of BNP levels can be a good guide for estimating the risk in your patients.
So there are a few more questions in the chat box. Sir, if you would be able to answer them, that would be great. But thank you so much for being a part of this Thane ISA CME. It was a pleasure to have you. I request Dr. Anjali Bure to felicitate Dr. Deepak Tempe for being a part of this.
It's my pleasure as well. It's my pleasure as well, and I enjoyed interacting with some of you during last 3 weeks or so. And I left my email ID and mobile number at the last slide, so all of you are most welcome to write to me any doubts, and I will respond to them. Those. Thank you so much.
Thank you so much, sir.
As a token of our love, we would now present a bouquet to Dr. Anjali Bure for being a part of this CME and for guiding us. Thank you, madam.
Sonali, thank you.
Over to Manisha for the further sessions.
Thank you, Dr. Bure, madam, Dr. Tempe, sir, and Dr. Sonali for that excellent discussion. It has given us the confidence to anesthetize these fragile hearts, and I'm sure we will follow all the tips that sir has given us. We are on schedule and we will now start with the inauguration ceremony. If things were different, we would be welcoming all of you into our lovely city of Thane. However, the pandemic has put a hold on all this. But let us bring Thane into your homes. Join Dr. Aruna Gaitonde, madam, as she gives you a virtual tour of our vibrant city, Thane. Dr. Aruna, madam.
Thane Anesthesia Society and the Indian Society of Anesthesiologists Thane City branch welcome you all for the ISA-sponsored National CME. Thane, a bustling, dynamic, vibrant city, has something for everybody. Dotted with numerous lakes, it has aptly earned the title of Lake City. The most popular among these are the Masunda Lake, the Uppavan Lake, the Jail Lake and the Kacharali Lake. These are great places for morning walks and socializing. For the religiously inclined, we have the 8th century built Kopineshwar Shiva Mandir, which has the largest Shivling in Maharashtra. The 450-year-old St. John Church has a serene atmosphere which calms the soul. The Jama Masjid, the Darbar Sahib, the Jewish synagogue, and the Parsi Agyari offer solace to minds of different faiths. The majestic Yaur Hills, with its breathtaking views, a part of Sanjay Gandhi National Park, not only refreshes your senses but also houses a rich variety of flora and fauna. To tingle the taste buds, we have the spicy Mamledar Misal and tangy Vada Pav of Rajmata and Kajanan. Thane also boasts of world-class healthcare facilities at numerous big and small hospitals, while Chhatrapati Shivaji Municipal Hospital is a boon for the underprivileged. The art scene at Thane is active and vibrant at the state-of-art Gadkari Rangayatan and Kashinath Ghanekar Auditorium. One cannot miss out the bustling malls at Thane, where you can shop till you drop, no matter what your budget, or catch a movie at multiplexes. So, I welcome you all to our beautiful beloved Thane, a city full of warmth and charm.
Thank you, Dr. Aruna Madam, for that lovely introduction to our city. I now invite our President, Dr. Meenal Gadgil, to preside over the much-awaited inauguration function. Dr. Meenal Gadgil. Meenal, unmute yourself, please.
Sorry. Thank you, Manisha. Good morning to all national and state committee members, my teachers, delegates, our chief guest, Dr. Sunil Katkade sir, and my dear friends. Warm welcome from Thane ISA for today's inauguration of national sponsored CME organized by Thane ISA. We are very lucky to have today our chief guest as Dr. Sunil Katkade sir, who is a founder member and of our Thane ISA. And we have seen his work and love for Thane ISA since 1978. And we are very, very lucky to have him today with us. And he has helped us as well as our Thane ISA to come to this glorious height, today's glorious height. I welcome Dr. Sunil Katkade sir as a chief guest today, and I request our secretary, Dr. Manisha Ghosh, to felicitate him with e-bouquet. Sandeep. Welcome, sir.
Thank you, Manisha. Thank you. Thanks to Thane ISA.
I welcome our guest of honor, our national and state committee members. First, I welcome our President, National ISA, Dr. Venkatgiri sir, who is Senior Medical Consultant in Anesthesia in Kerala Health Services. I request Dr. Katkade sir to felicitate him. I welcome our National Vice President and our GC Coordinator, Dr. Anjali Bhure Madam. She has given us a lot of inputs for today's CME. Thank you, ma'am, and please welcome. I request Dr. Godbole sir to felicitate her. I welcome our National President-elect, Dr. Bhimeshwar sir, for today's CME. I request Senior Anesthetist from Thane, Dr. Bharne sir, to felicitate him with virtual bouquet. I welcome our beloved National Honorary Secretary, Dr. Naveen Malhotra, who is a great leader who told us whatever shortcomings are there, put it on my name and go ahead with your own ideas. Sir, that liberty has given us a lot of responsibility also. Thank you so much and welcome for today's inauguration. I request our Secretary, Dr. Manisha Ghosh, to felicitate him. I welcome our National Treasurer, Dr. Virendra Sharma, and I request our Treasurer, Dr. Parna Thakkar, to felicitate him. Welcome, sir.
Sir, please accept.
I welcome past president and chairman ISA Academic Committee, Dr. Murlidhar Joshi sir, and I request senior anesthetist, Dr. Bhavesh Nanda, to felicitate him. I welcome Editor-in-Chief, Dr. Lalit Mahendritta, and I request Dr. Nilima Kelkar to felicitate him. Welcome, sir. I welcome National GC member, Dr. Ashok Deshpande, sir, who has given us a lot of inputs for this CME. Thanks and welcome, sir. I request Dr. Sonali Saraf to felicitate him. I personally welcome Bala Venkat, sir. I could see him here, and he is a GC member and he is our guru. Thank you, sir, for joining us. I welcome all GC members, presidents and secretary of all states, and my dear friends. Our secretary, Dr. Manisha Ghosh, would like to welcome all state office bearers along with me. Over to Manisha.
Thank you, Dr. Meenal. I request Dr. Meenal Gadgil, our president, to welcome Dr. Manisha Katikar, the president of Maharashtra State ISA. Thana Anesthesia Society became ISA during her secretarial post, and we have a very special affection for her. Welcome, ma'am.
Thank you so much.
I request Dr. Shamini Iyer to welcome Dr. Anita Nehte, Vice President of Maharashtra State ISA. Dr. Nehte is a consultant at Vedant Hospital, Nashik.
Thank you.
I now request Dr. Manjiri Ranade to welcome Dr. Sale, the President-elect of Maharashtra State ISA.
Thank you very much, ISA Thane.
Welcome, sir.
Dr. Viral Haria will now welcome Dr. Avinash Bhosle, the Secretary of Maharashtra State Chapter ISA, with an e-bouquet. Welcome, Dr. Bhosle. I request Dr. Shweta Patil to welcome Dr. Samir Sohani, the Honorary Treasurer of Maharashtra State ISA, with a floral bouquet.
Thank you.
Thank you, sir. I request Dr. Vineet Zadav to please welcome Dr. Hemat Shinde, the MISA News editor, with a floral bouquet. Welcome, Dr. Shinde. Thank you, everybody. We will now have the Deepa Prajwalan ceremony. Request all the dignitaries to please light the diya.
जय जगदीश्वरी माता सरस्वती, जय जगदीश्वरी माता सरस्वती, शरणागत प्रतिपालनहारी, शरणागत प्रतिपालनहारी, शीशमुकुटमाला गलधारी, शीशमुकुटमाला गलधारी, जय जगदीश्वरी माता सरस्वती, जय जगदीश्वरी माता सरस्वती.
The light that we have all lit is a symbol of truth, knowledge, and understanding, and shows us the path from darkness to brightness. We also invoke the blessings of Ma Saraswati, the goddess of academics and art. Thank you, Dr. Vidya Desai, for that melodious rendition. Thank you all the distinguished members for being a part of the inauguration ceremony. I now invite Dr. Meenal Gadgil, our president, and the organizing chairperson to address the gathering.
Thank you, Manisha. With Ma Saraswati's blessing, I welcome you all for national sponsored CME organized by Thane ISA. Thane is a city of lakes and has a cultural values, which we have shown you through this video, as we could not meet you personally this time. Yes, and Thane is a city of intelligent, innovative, and great anesthesiologists. And for this, I want to share with you that during this year, we have won World Anesthesia Day Celebration Award, as well as our members, Dr. Sabia received in essay competition award, Dr. Parna Thakkar in singing competition, and Dr. Bharne sir in instrumental competition. We have launched a new project during this year as an e-bulletin, which has become a great success. Actually, during my presidential speech, I had said that it is my dream to have a national CME sponsored by Thane ISA. This vision was given to us by our founder, Dr. Sunil Katkade sir. Dr. Manisha Katikar and team and Dr. Anjali Bhure madam, they have encouraged us to apply for it. And Dr. Venkatgiri, Dr. Malhotra sir and team gave us this opportunity to organize first national sponsored CME by Thane ISA. And our dream has come true. And yes, it is again a coincidence that it is our platinum jubilee year. That is Amrut Mahotsav. We have stepped into a platinum jubilee year on 30th December, and ISA has completed 74 glorious years. It is great honor for every anesthesiologist to be a part of this prestigious organization. Thane ISA is also very active and vibrant branch and doing many activities with participation of Thane ISA members. We have a wonderful and successful project as a journal club meetings, which we are taking every month. And whether they are virtual or physical, it is a great success with huge number of delegates. The key point behind it, that we always keep practical topics. As today also for this CME, we have kept practical topics. And we give platform to Thane anesthesiologists to participate in it. So it is a wonderful experience for all of us. Our COLS activities has given us recognition in public, funds in our accounts, as well as we have trained many people as a lifesaver. During difficult times of pandemic, our anesthesiologists have worked in ICU, in hospitals, in operation theaters to contribute for the social cause. We have received prize and lot of appreciation for our drama, Indra Devachi appendicectomy, which all Thane ISA members have done it. And we have acted in ISA, IMA, even in gynec conferences. Today also, for this conference, we have more than 1,000 delegates and registrations. So this is a great achievement. We thank for all activities to my dear Thane ISA members and assure that under the guidance of seniors, we will try to improve more and more and work harder and make our branch more spacious and more important for everyone. And thank you so much. Long live ISA. I request Dr. Manisha Ghosh for further proceedings.
Thank you, Dr. Meenal, for your vision and for your inspiring words. It will make us work harder to achieve all that we desire. I would also take this opportunity to welcome Dr. Rajiv Gupta, the National Governing Council member, who has very kindly joined us and encouraged us. Welcome, Dr. Rajiv Gupta, sir. I now call upon Dr. Avinash Bhosle, the Honorary Secretary of Maharashtra State Chapter of ISA, to say a few words. Dr. Bhosle is a freelance practitioner in Satara since the last 26 years. He is an associate professor at KIMS Karad and associate professor of emergency medicine at Government Medical College, Satara. He is an active social worker involved in many projects and also a fitness enthusiast who has run many marathons. Dr. Avinash Bhosle, sir, please guide us with your kind words.
Thank you, Manisha. Good morning, all respected dignitaries, office bearers of ISA National, Maharashtra State, all office bearers of ISA Metro, city branches, the guests, invitees, faculties, delegates, students, and my friends. I warmly welcome you to this ISA National Sponsored CME organized by ISA Thane City Branch. It is a great pleasure for me to be with you all at this inaugural function. Relatively, your branch is new compared to others, but now it is rapidly progressing and with your dynamic and enthusiastic, innovative office bearers, Dr. Minal, Dr. Manisha and Parna, and all the members of Thane branch. I am happy and proud of you all. In such a short span of 4 years, you have taken this branch to a new height at state and national level also. I know you are celebrating your fifth foundation day in next week only. That is on 22nd January. My salute to Dr. Katkade sir, the visionary who is working for all the anesthesiologists from Thane and nearby since last 45 years. We are very proud of you, sir. Maharashtra State ISA is an active branch having 32 happening branches and all are active and more than 5,000 members. Since we took charge of State ISA only 3 months back, I am proud to tell you that Maharashtra State bagged a record of 78 awards at the national level this year. We carried out a lot of activities, academic as well as non-academic. Every month, we are arranging one masterclass academic feast with renowned faculties, one interactive session as debate or how I do it, and giving opportunity to our members. A stress vaporizer session is also conducted to reduce occupational stress and to improve efficiency and to get job satisfaction. All virtual programs were houseful. We also arrange non-academic activities like Diwali Pahad Gani, Navratri celebration, cultural program, essay competition, which were participated by many and appreciated by all. We are also providing a digital platform to conduct webinars for all the city branches of Maharashtra state. All branches are conducting COLS and awareness activity regularly at their city level. For anesthesia awareness and COLS, we had Pan Maharashtra COLS program that was conducted on 17th October. We have active fit anesthesiologist club, sports club, cultural group club. We are doing so many things to activate our branches and members. We believe in teamwork and we are trying our best. We will continue to do more in the future for every member and for ISA. ISA headquarters has launched so many initiatives which really are a need of our. We will try to implement all these in coming years. At last, we invite all creative criticism, suggestions, and feedback for overall improvement of our activities. I congratulate all the members of ISS Thane branch for their dedicated hard work to make this CME a grand success. My best wishes to this CME. I wish you all good luck and a healthy and happy new year. Thank you. Long live Maharashtra State chapter of ISA. Long live ISA. Thank you. Thank you very much.
Thank you, Dr. Avinash Bhosle, for those lovely words. We are inspired by the state and our city will continue with the good work. I now invite the President of Maharashtra State Chapter of ISA, Dr. Manisha Katikar, to address us. Dr. Katikar needs no introduction. She has worked hard in every role that she has taken in the ISA and has grown stronger and stronger every time. Besides being a wonderful anesthesiologist, she's also a strong academician and has publications under her belt. She's also the associate editor of Indian Journal of Anesthesiologists. She's involved in many social projects as well and has been awarded with the COVID-19 Warrior Award. To you, madam, our appreciation and our gratitude. Dr. Manisha Katikar, would you please say a few words to us?
Thank you, Dr. Manisha, for nice introduction. Respected Katkade sir, the chief guest of today's function. Respected National ISA office bearers, Dr. Venkatgiri sir, Dr. Anjali Bhure madam, Dr. Naveen Malhotra sir, and all the respected dignitaries of National ISA, my associates, state dignitaries, and my dear friends and colleagues. First of all, heartiest congratulations to the team of ISA Thane for this great academic feast they have arranged on Sunday morning. Under the able leadership of Dr. Minal Gadge, Dr. Manisha Ghosh, Dr. Parna Thakkar, this is really a wonderful event, and I must say Hats off to their enthusiasm. They have received more than 1,000 registration, and that tells the success or in fact that tells the efforts they have taken for this CME. Avinash has done my job easy, but just to add few words to that, when I took charge as president of Maharashtra State Chapter ISA, I had mentioned two things in my presidential address at ISA or Nagpur. We are looking forward to many academic events lined up in this year till our state CME at Borivali. Along with that, we plan to have various non-academic events throughout the year like walkathon, Yoga Day celebration, Kavi Sammelan, Bhakti Git program, Teachers Day celebration, Pulse activities, and so many more. I feel lucky to have an enthusiastic team of office bearers, both at state level as well as city level. With their constant support and efforts, I feel confident that we'll accomplish the state goals. With many academic events lined up this year, the COVID-19 third wave has affected us. With the COVID appropriate behavior like this academic feast that has been arranged online, we will continue our state chapter activities with same zeal and enthusiasm. We are ever ready to serve the mankind as frontline COVID warriors as and when the need arises. I again welcome all the national as well as state ISA dignitaries for this function, and thank you very much for giving me this opportunity to be a part of this team. Thank you very much. Dr. Manisha Ghosh, please.
Manisha, you are mute.
Yeah, I know. I'm sorry. I was just with Dr. Deshpande on the line. He is unable to join for some reason because he was to address us next. But I think we will just sort that out later, but we will continue with this CME. I now request Dr. Meenal Gadgil, our president, to take over the function. What?
Yeah. Thank you, Manisha. Hello. Hello.
Yes, Meenal madam, you are audible.
Now I would like to request Dr. Naveen Malhotra, our Honorary ISA National Secretary, to give us guidance. Sir has got huge response for membership drive. And to my surprise, his secretarial office was accessible not only during office hours, but on mail, WhatsApp, and social media for 24/7. Hats off to you, sir. He has organized more than 10 new programs like Yuva ISA, ISA Fitness campaign, ISA Cultural campaign, etc. We are lucky to have such a dynamic, down-to-earth, and easily approachable personality as our secretary. Thank you so much, sir. And over to you, Dr. Naveen Malhotra.
Thank you, Dr. Meenal, for such a nice and warm introduction. And since you are told that I am approachable, so I can see Dr. Deshpande and Dr. Virender Sharma also now logged in. So Dr. Deshpande can say a few words and I can wait. And then Dr. Virender can also speak. So then I'll come later on. So since he is logged in, Dr. Deshpande, please.
Thank you so much, Dr. Naveen Malhotra, sir. Yes, Dr. Deshpande has logged in. I'm sorry for the little glitch, Dr. Deshpande, but please say a few. Dr. Deshpande is our national GC member and he has been very helpful to us in the CME, and I'm very sorry that this had to happen only with you. But sir has been the past secretary of Maharashtra State as well as the past president of Maharashtra State, and he is the head of the department of the skill lab of Bharati Medical College in Sangli. Sir has guided us nicely like a father figure and we owe a lot of him for the tips that he gave us. Dr. Deshpande, sir, please say a few words.
Good morning, everybody. Dr. Katkade, sir, chief guest of today's function. Dr. Giri, sir, national president. Dr. Bhimeshwar, president-elect. Dr. Anjali Bhure, madam, vice president of the ISA. Dr. Naveen Malhotra, Dr. Virender Sharma. Dr. Manisha Katikar, president of the Maharashtra State. Dr. Avinash Bhosle. The other guests which are there, the speakers of today's CME. Dr. Meenal, Dr. Manisha, who took a lot of efforts for this. and all the members of the Thane ISA Society. Today is the second national CME of MSc ISA in 2022, that is the Platinum Jubilee year. It is a great pleasure to have a CME at Thane because I know the Thane branch since their installation. We would have loved to be physically present over there, but we could not help it now. Nice scientific program and the nice attendance of the delegates to the tune of the 1000, and to mark it, to close it before the CME is one of the greatest achievement of the Thane ISA branch. There is nothing like that if you want to close the delegates for that. Now that's a great achievement of the ISA team. I am very sure that you will do it in future also in the same enthusiasm, and this CME will be a great success. Thanks for calling me over here and giving me a chance. Jai Maharashtra, Jai ISA, and Jai Long Live ISA. Thank you very much. Thanks a lot.
Thank you, sir, for your kind words. I now request Dr. Meenal Gadgil to please take over.
I request Dr. Malhotra to say a few words.
Dr. Virender Sharma, please. Dr. Virender Sharma, trainer, is also logged in. Dr. Virender,
Okay.
please.
Respected Dr. Virendra Sharma, can you guide us?
Thank you, ma'am. Good morning. Chief guest of the function, Dr. Katkade sir, President ISA, Dr. Venkat Giri, Vice President, Dr. Anjali ma'am, Honorary Secretary, Dr. Naveen, President-elect, Dr. Bhimesh, my colleagues in the Governing Council, President of Maharashtra State, Dr. Manisha, Secretary, Dr. Bhosle, and other office bearers of Maharashtra State. Well, a few things I would like to mention. The first is the way of invitation which I received, and a daily reminder. I mean, even if you want to forget, every morning you open your mail, you get a reminder you have to attend. I mean, I appreciate your sincerity, and these are some of the unique ways. The second was that diya which you sent to all the guests and simultaneous lighting. I mean, see, these are out-of-box ideas which I really like. See, one CME around 2 years back, which I attended, was in Borivali, and today it is being organized by Thane, although virtual. But the pattern is the same. The enthusiasm, the sincerity with which the whole city branch unites. And one thing which I appreciate, as
Yes,
I'm a GC coordinator for private practitioners, Maharashtra is one of the few states in which I see most of the private sector anesthesiologists also involving in all ISA activities. I mean, that makes us so proud. As at many other places, I see so many excuses. But really, you all are very much attached to the ISA. You all feel enthusiasm to participate in all the activities of ISA. And for this, I congratulate right from the past state office bearers to current and the current office bearers of the city. And that tempo is maintained. The number of awards which you get is a reflection of your work and sincerity. And the CME has been designed very meticulously, and all the best for this. And thank you very much for inviting me. Thank you.
Thank you so much, sir. Thank you for your kind words. And emails and everything, many things are done by Dr. Manisha, our secretary, who is very, very enthusiastic, but all have participated in organizing this CME. As well as I want to say that we had this CME, we were helped by Dr. Manisha Katikar and Dr. Anjali Bhure madam also. And that's why it is running up till now very smoothly. I'm very happy about it. Thank you, sir. Thank you so much. Now I would request Dr. Bala Venkat Subramaniam sir, who is here and who is our guru, who has visited Thane many times, and to say a few words. Dr. Bala sir.
Thank you very much, President Dr. Meenal Gadgil. It's such a pleasure to be with you virtually. I've been physically there several times right from your inauguration, and it's so happy to see you grow the right way. What really I like is the way you've grown academically. I think eventually what the patient needs from us is to get an updated knowledge and implement it clinically on the patient for an excellent outcome. And sharing knowledge and knowing the new updates, implementing in clinical practice is exactly what you have done, and you have reflected to every single anesthetist of the city of Thane. I'm indebted to you and the entire office bearers. I still remember Dr. Sunil Katkade sir putting his heart and soul in getting the Thane ISA work. And on this occasion, I'm very pleased to see how meticulously you have planned the virtual CME. It almost feels like being there. And that wonderful presentation of Dr. Aruna and Dr. Manisha Ghosh and Dr. Prana. I take this opportunity to thank all of you and look forward to seeing you physically very soon. Wishing you all the very best, madam.
Thank you so much, sir. Actually, when you spoke, I'm really missing to meet everyone. Means those days I remembered when you were here and we had a grand successful CME. So we are missing it, but definitely within a year we can have again physical meetings and we will be with all of you, sir. I request Dr. Rajiv Gupta, sir, who to say a few words and guide us. Dr. Rajiv Gupta, sir.
Okay, I think there are certain network issues, so now I can come in.
Finally.
No issues. Greetings from ISA National Headquarters and heartiest congratulations to Team ISA Thane. See, everybody is showering praises on you and you rightly deserve it. You rightly deserve it because of your enthusiasm and your warmth. The way you have invited, I agree with my other colleagues, you have been very, very meticulous in the planning, its execution, and your enthusiasm is really praiseworthy, and your warmth is there even now in this chilly weather at Rohtak with 8-degree temperature. This warmth is there on the Secretariat's table also. I still vividly remember the invitation from Dr. Sunil Katkade 2 years ago. And very happy that you have selected him as the chief guest of today's
Oh, I have missed it.
Ale sir, mute kariye please. Dr. Katkade, I remember he had invited me for that ISA sponsored ISA CME at Thane 2 years ago. And I had seen whatever the members are saying, the office bearers of Maharashtra are saying, it is true. Thane ISA is a very, very vibrant branch, with lots of academic activities, journal clubs, and very nice cultural performers across the age, senior most to the junior most. And yes, I have attended few of your journal clubs, read it about it and seen them also. They are excellent. Keep on doing good work. And Dr. Sunil Katkade as chief guest deserves special applause also and mark of respect also, sir. Thank you for guiding ISA Thane. And the vibrance of the office bearers, Dr. Meenal Gadgil, Dr. Manisha Ghosh, Dr. Parna Thakkar, ably guided by a very, very strong and good human being team of Maharashtra, Dr. Very respected, very dear, Dr. Manisha Katikar, Dr. Anita Mehta Madam, Dr. President-elect Dr. Saleh, Dr. Avinash Gosli as secretary, and Dr. Samir Sohani as the treasurer, and Dr. Hemant Shinde as the editor of the MISA News, which is also a very, very good thing. My colleagues in the Governing Council, President Dr. Venkat Giri, Chairman ISA Academic Committee, Dr. Muralidhar Joshi, who has been the brain behind all the academic activities and is guiding me also personally how to go about the academic activities throughout the year. And I can tell you, the vision is very, very clear. ISA is basically an academic, clinical, and research-oriented body with social welfare. So definitely there are numerous programs being started. It's not by me, by the team ISA. We always believe in team ISA. Last 3 years and previous also, and will continue in future also, these programs are going on. But our focus is mainly on teaching, clinics, and research. And very, very new activities are lined up for the near future, whether they are the pro-cons, whether they are the debates, whether they are the consensus guidelines, everything related to the teaching will be there. For clinics, There will be skill labs, skill centers across the country. And for research, there will be ISA guidelines also, and also research methodology workshops also coming up. And in addition, definitely all those social programs will be there for the holistic upliftment of the ISCNs across the country. Thane video was very good. And as I told in 2 years ago also, in North, Thane means Chal Thane. Chal Thane. So I was very happy to note that there is a jail lake also. So that is also good. You have lived up to this thing, that there is a jail lake also in your presentation. And I congratulate the whole team of ISA Thane and ISA Maharashtra. This is back-to-back second CME being hosted by ISA at Maharashtra, 2nd January Karad, and now 16th January this thing. And I salute your vision also. We came about, you foresee 2 months ago that we want to go virtual. And yes, with the third wave and Omicron coming up, this was a very, very nice and fruitful decision. And yes, I repeat and reiterate openly, whatever good things are happening today, the whole credit goes to Team ISA Thane. And if there are any shortcomings, there is only one person who is responsible. He is Naveen Malhotra. Thank you very much for inviting me here. Long live ISA, Jai ISCN, Jai Hind. Thank you very much.
Thank you so much for your kind words, sir. And we will definitely take advantage of your new activities and participate in that. Thank you so much, sir. Dr. Rajiv Gupta, sir, can you log in now? I would request Dr. Rajiv Gupta, sir. Sir, can you see his?
I think there are some network issues. You can please proceed on with the ceremony.
Okay. Now I would like to request Dr. Murlidhar Joshi, who is immediate past president and chairman ISA Academic Committee, to give us advices. Over to Dr. Murlidhar Joshi, sir.
Sir, President Dr. Venkat Giri, sir, and then dignitaries on the dais and off the dais. It's very nice to see a new year, so much activity happening in Maharashtra. Of course, nothing new about Maharashtra. So much of activities keep on happening. I can see so many of my colleagues and friends and seniors. Dr. Saleh sir is there, and then Dr. Meenal and Dr. Manisha, and of course, so many of them. I can't really say, I can't keep on telling the names. Probably we have 1,000 delegates, so I think I'll complete the whole thing. But one thing is, I would like to say, I don't know why Thane joined late to ISA. I really don't know, because the first railway engine started from Thane to Pune. I think Dr. Saleh sir can correct me if I'm wrong. 18th century, am I right, sir? Dr. Saleh sir? Yes, the first railway engine started from Thane to Pune in 18th century. But I don't know what exactly was the obstacle for Thane to join the ISA mainstream, joined just about maybe 4 or 5 years back. But nevertheless, it's great. And the amount of response what we're getting, I think almost we have the double engine thing, what we're happening, I think probably back to back. We had 2 CMEs, ISA sponsored CMEs. One was at Karad last weekend, and this time it's Thane. Of course, next weekend it's going to be at Tamil Nadu. It's good. It's good for ISA. It's good. And I think in this period of the Platinum Jubilee celebration, I think we should celebrate. Probably, I would request Saleh sir to take lead along with Dr. Manisha Kartikar. So, sir, please think about that one. First railway engine started from Thane to Pune. Sir, think about it with the Platinum Jubilee celebration. Sir, if you think it will happen, I know it. If you think it will happen, something you can do about that one. I think Dr. Manisha Kartikar, Maharashtra State Branch President, and also Saleh sir, President-elect, and also Dr. Meenal as President. आप सोचेंगे तो कुछ तो हो जाएगा, कुछ तो हो जाएगा. आप सोच लो, बस एक रेलवे इंजन चला लो थाने से पुणे, बस ऐसे के नाम पे. That will be historical. एक बार सोच लो सर, हम आपके साथ हैं. हम आपके साथ हैं सर. I know you can do it. It's not a big deal, but you can do it. But it should be a steam engine, not a diesel engine. But if it's provided by the government of India, sir, I think that will be the stamp picture for probably ISA if the president and other governing council agrees. That will be great, sir. That will be great. Think about that one. So, Thane to Pune, एक diesel engine, no, not diesel, steam engine with maybe a few bogies where IS members are there with ISA flag. Think about it, whether you can make a historical trip on that one. With these few words, but excellent scientific program, great ambience, and so many people are there. 1,000 members is phenomenal, sir. Phenomenal, sir, this time. But I say, hopefully we'll meet everybody physically. Long live ISA. Jai Hind. Namaste. Thank you so much.
Thank you so much, sir, for your kind words. And definitely our seniors will think about your advices, whatever you have given. I want to just say Dr. Rajiv Gupta had to go for some emergency, but he has congratulated Thane ISA. Thank you, Dr. Rajiv Gupta, sir. Now I would request our National Vice President and GC Coordinator, Dr. Anjali Bhure Madam, to deliver her speech. She is HOD at Lata Mangeshkar Hospital, Nagpur. Actually, she was a motherly figure who kept taking care of us throughout this organizing CME. Motherly as not as her age, definitely she is much younger, but she has taken care as like a mother. I will call you, I will find out what problems you have. So she has really, that touch was motherly touch, and her attitude and helping and holding our hand was excellent. Thank you, ma'am, for that. And I would like to request you to deliver your speech.
Thanks a lot, Meenal. Good morning to all. A very bright and happy morning. Today's chief guest, our own Dr. Sunil Katkede sir, a true visionary leader. Honorable President Dr. Venkat Giri sir, President-elect Dr. Bhimeshwar sir, Honorary Secretary Dr. Naveen Malhotra, Honorary Treasurer Dr. Virendra Sharma, Editor-in-Chief Dr. Lalit Mehdi-Ratta, Chairman ISA Academic Committee Dr. Murlidhar Joshi sir, Governing Council members Dr. Ashok Deshpande sir, Dr. Rajiv Gupta, Maharashtra State Chapter ISA Office Bearers, Honorable President Dr. Manisha Katikar, Vice President Dr. Anita Nehte, Secretary Dr. Avinash Bhosle, Honorary Treasurer Dr. Samir Sohni, President-elect Dr. H.K. Sare sir, Misa News Editor Dr. Hemant Shinde. Today's organizing committee, organizing chairman Dr. Meenal Gadgir, Honorary Secretary Dr. Manisha Ghosh, Parna Thakkar, scientific committee members Nilima Kerkar, Shamini, Sonali, other distinguished guests, our esteemed faculties, and dear members. I welcome you all to this ISA-sponsored National CME, which is organized by Indian Society of Anesthesiologists, Thane City Branch, and Thane Anesthesia Society, Thane. This is the second National CME organized in a row in the Platinum Year celebration of Indian Society of Anesthesiologists. I appreciate the initiative of ISA national body for encouraging various branches to hold CMEs and workshops where it is not possible to organize conferences. Today's CME will be completely on a digital platform in line with the social distancing norms due to the monster virus. Now, I appreciate and welcome all the eminent faculties of today's CME of national and international repute coming from different walks of life who have gathered here to share their knowledge and vast experience with the delegates. It is truly an excellent opportunity to learn the updates under their able guidance and expertise. I welcome all the delegates, and I'm sure that this CME will be a successful event with your active participation and interactive sessions. I would like to thank the organizing committee, Dr. Sunil Katkede sir, Dr. Prakash Page sir, Dr. Chandrasekhar Godbole. These are our patrons. And organizing chairman Meenal Gadgir, organizing secretary Manisha Ghosh for their warm hospitality. As a national coordinator of this CME, I admire their hard work, dedication, cooperation, coordination, perseverance, and tremendous enthusiasm. They have not left any stone unturned to make this national CME a grand success. So thank you, Thane branch. Thank you, each one of you. Long live ISA and long live ISCS. Thank you so much.
Meenal, unmute yourself. Meenal.
Yeah. Thank you, madam. Thank you, Bhure madam. While taking our names also, her voice was modulated and her face was showing the love. Really, thank you, madam, about it. Actually, my family members, my kids also know who is Manisha Katikar, who is Anjali Bhure by this time, because thank you for their helping us for each and every step. Now I request our national president, Dr. Venkat Giri sir, to deliver his speech. Sir, you are at the highest position in Thane in ISA. But to everyone's surprise, he is from a small town of 50,000 population and as a city branch only 15 members. So this is our democracy in ISA and credentials of sir who has been taken to him to the highest position. His main goal is to provide safe practice, financial well-being, work-life balance, and legal support to his fellow ISA members. Thank you, sir, for your vision. Thank you so much, sir. Over to Dr. Venkat Giri, sir.
Namaste. I'm very happy to participate in this ISF on CME organized by ISA Thane branch. President Dr. Meena, Chief Guest Dr. Sunil Katkade, and all dignitaries, my colleagues in GC, faculties, GC members, the delegates, and everyone. Once again, namaste. I don't want to wish all the names because my vice president, our vice president, already told every name in person. So I will avoid repeating that. And already we are, I think, we were in time. You started in time and everything. Now we are going behind schedule. 11:30 we should have finished. It's already 11:35. So I was congratulating you for keeping the time. Now we are. Anyway, once again, congratulations. And this is the Platinum Jubilee year of ISA. And we have a lot of programs during this year. And we have started many programs for each branch to conduct. But always remember, ours is an academic society for the welfare of our members. First is academics. So that's why we are conducting this ISA CMEs and educate our members and update the knowledge. What we have learned long back. Maybe I did my MD 20 years back. That time there is a lot of changes. So by attending the CMEs, we can update on new drugs have come, new techniques have come. We have to unlearn what we have learned and relearn the new thing. That's what we will have to do that. So physically, we are not able to do, but virtually, there are advantages also. More people are getting the knowledge because if it is physical, I think this 485 people would not have joined. It would have been some 200, 300, but we have the 485 people, it's a very good attendance, and we are imparting knowledge to all, and they get the knowledge from people from all around. But when it's a physical, we get people from nearby. Many people may not be able to come, but it's not like when it is virtual, we get the topmost people from everywhere. Today morning, I was hearing that two things, which is a neuro, that is continuous spinal, the catheter and all. She was explaining the cost, everything. That's really nice to hear these things. So we have whether we practice or not, it is different, but we should have the knowledge. If somebody asks that, we should be able to do. That's why. Second thing, during the now, what I see is we have to think not only our NSS subject, we have to think of other things also. What I always press everybody, like you should have work-life balance. You should have a good family life. In our governing council, we actually plan for one family meeting of the council. I don't know whether with this COVID we are able to do or not. First governing council meeting should be with the family so that we interact each other. Because I am in the council for more than 15 years, but if we ask about the other colleague, what is family, what is children, we may not know that. That should not be. We should have. Or sometimes why people ask what is done doing, what his daughter doing, how many children. We do not. Though we are so close for so many years and traveling together and sharing rooms and being in that. But that should not be there. This year we should definitely have some family meetings, know each other. That's one program which I foresee and tell everybody. Second thing is that see, in our CMEs, we do a lot of subject talks there, but we should have some talks on non-subject, that is like work-life balance, stress, then the alternate. I always say that there should be talks on income, alternate source of income and investment opportunities. ISF, PPF is doing on that. See, we have seen during this COVID season, many people had loss of income. The income has come down drastically, and even paid employees were given half salary or less. So we should always, when the money comes, yes, you save it. Don't spend luxuriously on big car and all. Keep some money for saving. I am planning a CME in class about many topics. 5 or 6 topics are only on this. We should teach our members and colleagues. Yes, keep saving for the rainy days. Yes, we may be having luxury is there today, but we can get that. But you should have some. There were some talks which I have heard other day that okay, if your income is 2 lakhs, 1 lakh you have to keep for the future, 1 lakh to spend for now. 4 lakh. That's why you have to plan for the future. Next, after your retirement, what you should do. It may not be retirement only. Even sometimes our illness or something, we may not be able to at least have that plan. That's one which I strongly believe. Other thing is family balance fund. It is for our colleague. We should not think at the old age and all. See, at this age of 58, I will get my retirement benefit and my pension, but not all are that privileged. If it is at the age of 40 years, when children are in medical college, engineering college, or studying in another country or so, where you need a lot of money, if the earning member dies, it is really difficult for the family to survive, because we have seen many people with a lot of difficulties in surviving. That's why the family member. A lot of people should join that. We should think it is not that what I get, what I give, the joy of giving. If you see in the Rotary or Ryan, you see that joy of giving. But we have to give that. Give to others. I have helped my colleague. See, this 300 may not help, but all the 10,000 people, if you give 300, it becomes 30 lakh. That will be really helpful. Now we have hardly 3,000. We should promote that and make. Not thinking that if I survive for 60 years, I should be happy that God has given me good health and energy to make money, and I've earned, but I have given somebody. That should be our motto, and we should definitely join Family Women Fund and help our colleagues. Many, all are not privileged. There are some who really require. Don't think it is for your children after your death and all. It is for our colleague. That's what we have to think. Yes, children after death, if it's early, not at the old age where they will be said they may not require this money after that. Other thing is, we have planned quiz in the ISA website. People should visit there. Maybe it will be ready from January. Daily quiz on the subject and other things. We have planned a very good quiz. People should visit and have that. There will be some prizes also for that. We are planning for that. CPR is another thing. Yes, we have to teach our own family members and colleagues first and others. We have to definitely, we are very much behind than Western countries. Yes, we have to teach CPCR or even the basic life support. We have to definitely tell, and IRC is doing that work, and we have to take up and do this. Every member should take it as a prestige and a privilege to teach CPR to others. And this year we have SAR Congress in India. It will be on 12th, 13th, and 14th of August in Cochin. The brochure will be released in a day or two, and all of us should make it a grand success in this Platinum Jubilee year of ISA. And one more thing I wish to tell is to respect our teachers. There should be one agenda in this Platinum Jubilee. See, 5th September, Teachers' Day. Our teachers will be very happy if you respect them call. Just giving a call on them on 5th September. Tell that, sir, you have taught me this thing. I always call my teachers on 5th September. She's so happy, my actually. Yes, I was waiting your call. There are 2 or 3 people. So how much joy is my student has called me. That is what. So we have to make that habit, so that's how we keep in touch with others and teachers and all, because they have taught us. If they have not done, we would not have come to this point. Yes, we have to respect our teachers. Please, all our colleagues should call their teachers, remember and make them and respect them. This should be our. And this is for now, and I once again wish all the best for you all. Please make yourself updated with the knowledge, not only subject. Please keep in mind other things also, family and all, work-life balance and all. The number of anesthetists are increasing. It is not like earlier. Practice is coming down. Freelance may not be there after another 5 years, because it's already vanishing in many places. In my state, yes, every year there are 500 new anesthetists coming. Retirement maybe hardly 50 or less than 50. So in 5 years, doubling of the anesthetic will come. So income will be 50% half. So that's what is that we have to think for the future, and we have to think alternate source of income and alternate. See, we may have a lot of things. Yes, and along with such a learn family medicine or family practice, you can get a double benefit that you have the evening free time. You get a patient, you refer to them, you get one case, you get one case. These are things we have to think for keeping ourselves for the future, because practitioners should always keep that how to keep our practice, because what we have learned in medical college, what we practice is different. And we have to keep with this and go ahead. All the best once again, all the members. Keep in mind all these things and go ahead. All the best, both Chane and all the members. Thank you for inviting. Thank you.
Thank you so much, sir. Thank you so much. As you said, sir, Thane is also a small and young branch, and we will definitely work more harder, and definitely we will do work on FBF fund as you have suggested now. And sir, we have kept all our educational activities on virtual platform only for a year, because as you said, there are many more participants and they can get benefit of the educational activities. So thank you so much, sir, for this. And now I request our today's chief guest, our Dr. Sunil Katkade sir, to deliver his speech. He started his practice in Thane when it was a small village. And now Thane has been changed into a mega city. And yes, sir, from private practitioner to chief medical director and advisor at Shri Mahavir Jain Hospital. He is fatherly figure to all of us. Let's listen from him how he achieved his goal, which is a dream of each anesthesiologist. Over to Dr. Katkade, sir.
Thank you, Dr. Meenal. Respected President, National, Dr. K.M. Venkatgiri, sir. Vice President and GC Coordinator, Dr. Anjali Bure. President-elect, Dr. M.V. Bhimeshwar, sir. Honorary Secretary, Dr. Naveen Malhotra ji. Honorary Treasurer, Dr. Viren Sharma. Editor-in-Chief, Dr. Lalit Mediratta, Chairman IS Academics and immediate past President, Dr. Mullidhar Joshi, sir. GC member, Dr. Ashok Deshpande. Governing Council member, Dr. Bala Venkat, sir. My dear senior friends. I would also like to welcome Maharashtra ISA office bearers, President Dr. Manisha Katikar, Vice President Dr. Anita Nete, President-elect Dr. H.K. Sale, Honorary Secretary Avinash Bhosle, Honorary Treasurer Dr. Samir Soni, and my great friend, Dr. MISA News Editor Dr. Hemant Shinde. Good morning, all. I'm thankful to ISA Thane for giving me the honor to be chief guest for today's National CME. I also am thankful to ISA National for allowing a local person to be a chief guest for a local CME. Thank you ISA National for giving this unique honor to a local person for a small city. I salute all the COVID warriors who have been fighting this war endlessly for the last 2 years. Anesthesiologists have taken a great part and played a great role. I would like to express my deepest respect to all our distinguished guests and participants. I congratulate to all office bearers, speakers, delegates, and every person who made this CME a great event. Especially to Dr. Meenal, Dr. Manisha, Dr. Parna, and every person who guided ISA Thane. ISA Thane is a dynamic association with bubbling enthusiasm. It has a great future. All of us are family. Every anesthesiologist in every corner of the world is a family member. The moment you say to another anesthetist, I'm an anesthesiologist, you become a family member of this particular person. We are also going to be great entrepreneurs. I appreciate the great advice given by President Venkatgiri, sir, to be an entrepreneur. I request all the anesthesiologist families to be united, be progressive, to make our local and national body powerful. We must make our country proud. We must make yourself proud, make your parents and teachers proud. The opportunity literally is in our hands. It is not in anybody else's hands. Sir, I would like to narrate, as you mentioned, I started my career as a general practitioner in 1975, and I used to travel in a small boat and I used to travel by a small truck also. That gave me leadership qualities also. Then I joined anesthesiologist, and I also work as the honorary professor of anesthesia in JJ Hospital, in a particular in cardiac surgery. I humbly remember the suggestions of late Professor Balasaheb Deshpande sir to conduct ISA Maharashtra conference at Thane. Dr. Naveen Malhotra sir, it was from Pune to Thane. And now I promise Thane is Kai Une. So Jithe Une Tite Thane. When there is some negative thing, we all will be there to help, sir. And we'll definitely carry your dream and suggestion forward. I also promise Dr. Muralidhar Joshi, who has come with the history, thank you, we'll carry it forward. Long live Indian Society of Anesthesia Thane. Long live ISA National. With best wishes, love and regards. Thank you all for giving me this opportunity. Jai Hind. Thank you, sir.
Thank you, Katkade sir. Thank you so much. Sir, you are, for us, you are not a local person at all. You are a national person for all of us. And I just forgot to say, Dr. Venkatgiri sir, we are for togetherness and togetherness in anesthesiologists. We are arranging cultural meetings and a few other occasions. Actually, to celebrate our birthday, fifth year celebration of Thane ISA, we had arranged on 22nd of January, but we couldn't do it. But we will definitely take it forward and do it whenever it is going to be possible. Thank you so much. Thank you all dignitaries for giving us advices, your thoughts and your guidance. Now we will try to follow them and make our branch more prominent. Now I request my beloved friend, Dr. Manisha Ghosh, our secretary, to deliver vote of thanks. Yes, before that, I just personally want to thank dear Manisha for her lot of efforts for today's CME. She has put her heart and soul in today's program. She is a dynamic, enthusiastic, sincere, hard-working, very busy anesthesiologist. We are very, very lucky to have her as a secretary of Thane ISA. Thank you, Manisha. And I want to thank her family members also to help us for today's CME. Over to Manisha.
Thank you, Dr. Meenal, for those really kind words. No program is complete without the vote of thanks, and it is my privilege and honor to extend a warm vote of thanks to all the members of the National ISA Governing Council for their support, for giving us this CME, and for helping us make it educative and informative. My special thank you to Dr. Anjali Bhure Madam for holding our hand and showing us the correct way to do it. Our heartfelt gratitude to Dr. Naveen Malhotra sir for owning responsibility for this CME and taking responsibility for all the errors that may have inadvertently and unintentionally occurred. The support from Maharashtra State ISA has been unprecedented, and we have received tremendous support from each and every member of not only the Governing Council, but of every city branch from Maharashtra. Our president, Dr. Manisha Katikar, has been available at all times 24/7 to answer all our queries, however small and trivial they may seem. And she has literally guided us with lots of affection, and we are very grateful to her. We are very much indebted to our mentor and our founder, Dr. Sunil Katkade sir, who gives wonderful suggestions which makes our work better and better. We are also very, very grateful to all the speakers and chairpersons for readily accepting our invitation and making this CME a glorious one. I'm also grateful to Karar Secretary, Dr. Shraddha Bahulekar, who was fresh from a CME and who has given me lots of tips about how to go about it. I'm also thankful to the team of ISA Nagpur for shifting their CME to the evening slot and giving us a free way. And I also want to thank personally each and every member of my team, without whose support nothing would have been possible. I want to thank Dr. Godbole sir, Dr. Bharne sir, and Dr. Rajan Joshi sir for their stoic presence. Thank you to Dr. Churchill, who's working very hard to release the second edition of our e-bulletin next month. I want to thank Dr. Shweta Patil, our COLS coordinator. She calls herself technologically challenged, but conducts a beautiful online CPR session, which was attended by over 100 delegates. A huge thank to my entire team. The last 7 days have been difficult for all of us because More than half of them have been in various recovery stages of COVID, but in spite of all that, we have managed to put up a great show. Dr. Manjari Ranade has been battling COVID along with her entire family. Thank you, Nilima, for always being there. She was down with COVID, but she compiled all the data for me. Dr. Shamini Iyer is down again with COVID. She can barely talk, but during our trial run, she wrote down her speech and gave it to me to speak and see that it was all right. Dr. Ketki, another COVID victim, has had severe photophobia. She could not even look at her mobile, but she has answered all my queries and answered all of them with the help of her little daughter. I want to thank Dr. Vineet, who is probably very unwell with a sore throat, but he took great efforts to make our Makar Sankranti greetings and does all our flyers. Dr. Sonali Saraf, a very, very busy anesthesiologist who's busy day and night with transplant, but she calls me up and tells me, Manisha, you need anything, I am there for you. Dr. Viral, like his name Amulya, has been very valuable in making a wonderful AV on ISA programs, which we will be telecasting shortly. Dr. Bhavesh is our solid support and go-to person. He in fact called up and scolded me कि इतना क्यों कर रही है, थोड़ा आराम कर. But I could sense the brotherly affection in his scolding also. Dr. Parna Thakkar, who lives in Dadar but whose heart is in Thane. She had a Satyanarayan puja in her house a couple of days ago and prayed for the great, for our CME to be a great one. And last but not the least, my immense gratitude to our dynamic president, Dr. Meenal Gadgil, for leading from the front, working side by side and showing immense patience and yet being firm when required. If anybody sees her WhatsApp status, it says connecting people. And that is exactly what she does with charm, grace, affection, and respect. Last but not the least, thank you to all the delegates. We have more than 1,010 registrations for this CME, and they have been ably handled by our digital partner, Mr. Sandeep Thote and iPlit. I'm also thankful and grateful for all the little things that everybody has done to make this CME a grand success, because it is the details that ultimately make the thing a success. And I recognize that whatever we have done, we have not done it alone, but we have done it with the blessings of God, our family, and the entire team. Thank you very much. Dr. Meenal, can we now continue with the scientific session?
I think so. I think so.
Thank you, everybody, for being a part of this. Yeah.
Manisha, there is going to be a clip, no?
No, afterwards. Yeah. Thank you, everybody, for being a part of this inauguration function. We are a little behind time, but I think we will compensate for that in the lunchtime that we have allotted. The next stop. For all happiness that mankind can get is not in pleasure, but in relief from pain. How true are these words by John Dryden? And the next topic by Dr. Naveen Malhotra, sir, our honorary secretary, deals with just that, post-operative pain. This session is being moderated by Dr. Viral Haria, a young anesthesiologist and a pain physician from Thane. Dr. Viral Haria.
Thank you. Good morning to everybody, and thank you for the warm welcome, and thank you ISA Thane for this opportunity. On behalf of ISA Thane, I hereby invite the chairperson for our next session, Dr. Ashok Deshpande sir, who is a very senior anesthetist practicing in Sangli since more than 40 years. He is attached to Bharati Medical College in Sangli. His special interest is in regional anesthesia and simulation, and he is head of the skill lab at Bharati Medical College. Respected sir, kindly introduce our speaker, Dr. Naveen Malhotra sir, to the audience, if you can hear me.
Deshpande sir, you have to unmute yourself.
Deshpande sir.
Good morning, everybody.
Yes, sir.
As such, Dr. Naveen doesn't need any introduction because he is well known to everybody throughout India. But still, as a part of this program, I will introduce him. He is a senior professor of anesthesiology, and he is the head of the pain management at PGI-MS Rohtak. He has received ISA Bhopal Award. He has also received KPR Young Anesthesiologist Award. He had 195 publications in his name, and he had 392 presentations in his name. His original work is submentotracheal and retromolar intubations. Above all these, he is our smart, always having a smiling face, very smart fellow, Honorary Secretary of the ISA National, Dr. Naveen Malhotra. Hand over to you, sir.
Thank you, Dr. Deshpande and the moderator for the kind introduction. Thank you for, my mother also thinks that I am very smart. Thank you, Dr. Deshpande, for acknowledging that. And yes, since it's my responsibility also, so I'll cut down to my talk and save some time because I know lunch time is also only 20 minutes. So I'll, 15 minutes, I'll compensate and be quick. Post-operative pain management is the topic which has been allotted to me. And we all know the revised definition of pain, that it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And more importantly, the 6 key points, that pain is always a personal experience that is influenced to various degrees by biological, psychological, and social factors. Pain and nociception are different phenomena, and pain cannot be inferred solely by the activity in sensory neurons. And throughout our life, individuals learn the concept of the pain. And a person's report of an experience of pain should be respected. And although pain usually serves as an adaptive role, it may have adverse effects on function and social and psychological well-being. And verbal description is only one of the several behaviors to express pain. Inability to communicate pain does not mean that patient is not having pain. Post-operative pain is often untreated or undertreated and may lead to subsequent chronic post-surgical pain syndromes. And as we move to daycare surgeries, post-operative pain control has become increasingly more challenging, and consistency is very, very important. Why we should treat pain? It's a human right. Our moral responsibility, decrease suffering and post-op complications, decrease likelihood of chronic pain development, increase patient satisfaction, and enhanced recovery. We should treat pain for all these reasons. And also we have been talking this through and out that it has got different adverse effects on almost all the organ systems, and it delays wound healing. There are psychological aspects also, and even it can lead on to complaints and litigations. What should be our aim? I think time has now come for us to aim for pain-free hospitals. This should be our motto, that our each and every institute, starting with medical colleges, should have acute pain services and pain clinics, managing chronic pain. I have been going as an NMC assessor to different institutes. Chronic pain clinics have increased over the time, but still in majority of places, it's more or less on papers. And acute pain services, which is the essence of today's talk, I'll come to that, is still, we have to do a lot of things to achieve this ultimate goal of pain-free hospitals. What are the challenges towards pain-free hospitals? Understanding the magnitude of problem. How often we do post-op rounds that we understand the magnitude. We have to change the attitudes, train our residents. We should have clear-cut, laid down standards, SOPs, and pain management protocols. And we have to break the self-related barriers of knowledge and acquire new skills and work as a team. When this topic was allotted to me, I just thought what I should talk to you. What is the practical things which are happening across the country, that there are minimal post-operative visits. They are restricted to majority of corporate hospitals only, and private practitioners and in medical colleges, post-operative visits are very, very less. And at times, even when the PAC is done just before the surgery, because our private practitioners are so overburdened with conducting anesthesia, what to talk about post-operative visits and post-operative pain relief. And in medical colleges, I will said, there was a survey done, which I'll come to you just in a few minutes. Why acute pain service is required and what it comprises of. It comprises of a dedicated healthcare personnel driven services which assesses, monitors and treats pain and also take care of the side effects on a 24/7 basis. It's not like that, okay, now I have finished anesthesia and I'll go in the evening or before coming to the OT, I'll see the patient. Patient can have pain anytime during the 24 hours. And acute post-operative pain is still a neglected and unresolved issue in day-to-day practice. As I've told you, most of the APs are running in corporate and big teaching hospitals. And pain is not routinely measured or documented in majority of the hospitals, except for the thesis cases or research projects. This was a 2015 study. A survey was conducted in India to get a real-time insight into the acute pain services in India. There were 146 responses only, and from few corporate hospitals and medical colleges. 68 acute pain services were functioning in India, and 20 didn't have any training programs, and 34 didn't have any written protocols. And anesthesiologists were involved in post-operative pain management only when epidural analgesia was employed. As I told you, either they put it for clinical reason or for a research or a thesis work. So this was a few years ago. The situation has not changed much. What are the solutions? We have to educate our patients, our surgeons, and ourselves also. We need to have protocols for post-operative pain management and a multidisciplinary acute pain services. And there has to be greater communication between the patients and the clinicians. The surgeons and anesthesiologists have to talk. Anesthesiologists have to share the responsibility, have to go this extra mile. Rather, now it is a duty also. And with increase in anesthesia resident seats coming up in medical colleges, there has been last 4 years, I've seen more than threefold increase in MD seats. And now these students have started passing out since last 1 year. We can utilize this manpower for having a dedicated acute pain services in each medical college. We should aim that our institute, our hospital should be a pain-free hospital, having both acute pain service as well as chronic pain clinic. And this is a teamwork. We have to work along with the staff also, because the nurses, the support staff, it is very, very required. And then definitely it will require all the human resource as well as materialistic supports and the manpower. So it is a teamwork of the involving the clinician, the patient, the staff, and the administration. And we all know, we have read this in that there are definitely it's a benefit, and there will be decrease in patient pain perceptions, pain intensities, leading on to improved patient satisfaction, fewer adverse effects, and we can identify and prevent chronic post-surgical pain develop and deploy new targeted interventions, and definitely form education and training about the evidence-based pain management. We can have different protocols according to our own institute, according to our setup, according to our manpower. The subsequent protocols which I shall be discussing is just a prototype, but it depending upon the setup, you can have more also, you can have less also. So the changes necessary to implement and move forward is not a single step, but it is a continuous improvement and ongoing change. So if today we take up this challenge that we will develop pain-free hospitals, we'll make our hospitals pain-free hospitals by having acute pain services and chronic pain clinics. We do understand that this is a step forward, but it will involve continuous improvement and ongoing change. But we have to start, and what better way to start today? There has been proven that there is enhanced recovery after surgery if there is a good acute pain management. And ERAS pathways include multiple preoperative, intraoperative, and postoperative interventions so as to have an adequate level of analgesia with maximum patient comfort and reducing or avoiding opioid consumption. It is an important component of ERAS to have an adequate post-operative pain relief, and there have been numerous studies which have proven that it has led to decreased complications, improved outcomes, improved quality of life, and thereby saving lots and lots of healthcare resources, not only in time of money, manpower, but also drugs and other things. So even in the pre-hospital phase, we have to start thinking about the pain management plan. Can we do some sort of preemptive analgesias, use some gabapentinoids like drugs, study the profile of the patient? Then in the preoperative phase, the multimodal medications and renal blocks placements. Intraoperative phase, talking about multimodal analgesia and now opioid sparing, and postoperative also the multimodal analgesia. So in all the phases of patients stay, peri-hospital stay, from pre to discharge, pain management is an important component of enhanced recovery after surgery. There can be numerous causes of postoperative pain. It can come from incision, it can come from cutting and coagulation, or the operative sites, tight cast, tight dressings, needle trauma, extravasations, urinary catheter, ambulation. Pain can come from any of the cause. And duration can range from as short as 24 hours to as long as 4 days. If it is a thoracotomy, which is more painful, and upper abdominal pain surgeries are more painful, with requiring more analgesic consumption and increased severity of pain. But yes, all surgery will cause pain. We have to treat pain. And for treating pain, we have to assess. Use any assessment method which is for your institute or hospital, whether it is VAS, NRS, FACES, whatever you want to do. But for treating pain, you have to assess pain. And I shall be restricting my talk mainly to the adults today. And multimodal analgesia, balanced analgesia is the key to success to any acute pain services. We use different drugs with different mechanisms and sites of actions so that the lowest dose and benefit is most, and we ultimately aim for better analgesia with least side effects, and always consider multimodal analgesia when you are treating pain. There have been terms of preemptive analgesia, preventive analgesia, and yes, whenever we talk of the giving drugs before the surgical incision, so the results are that their hypersensitivity is definitely, see, if there is nothing has been given, the hypersensitivity is more. But suppose if it has been given earlier, then hypersensitivity is less. And if you continuously treat the pain, the pre-surgical and the post-surgical analgesia, if it is provided, then the nociceptor input is decreased and hypersensitivity is decreased to a great extent. So always not only think of preemptive analgesia, but preemptive and preventive analgesia throughout the course of surgical procedure. There are numerous modalities available, the pharmacological one, the acetaminophen, NSAIDs, opioids, TCAs, neuroleptic agents, and regional anesthesia, local infiltration, topical local anesthesia, and then some role of non-pharmacological approaches also. Typically, with our classroom teaching, where all the agents are acting, whether it's the local anesthetics or the opioids, which act at the level of the spinal cord and brain. So we have to treat the pain at different levels of the neuronal transmission. Acetaminophen IV preparation is most commonly used if there are no contraindications. Very safe drug, which can be given up to 4 grams in 24 hours, 3.7 to 4 grams in 24 hours. Definitely with geriatric patients and liver disease, we have to decrease the dose also. NSAIDs are also coming along with paracetamol, come in the first line treatment. COX-1 and COX-2, there is no physical dependence, no tolerance. Yes, some ceiling effect is definitely there. And these drugs are almost commonly used in the day-to-day practice by the surgeons, whether it is patient is taking orally, then diclofenac, otherwise IV preparation or IM preparation are there. Ketorolac, the IV preparations, which is very commonly used. These two drugs are very commonly used, and also some people use piroxicam. Definitely, we have to take care of the GI and other disorders and cardiac risks. And Ketorolac, as I was telling, very commonly used in 30 to 40 milligrams 8 hourly. And opioids, they are still essential element of pain management, though we are moving from opioid to opioid-free analgesia and anesthesia. But still, if it is required, they are used, and they can be agonists, which are commonly used, are morphine, fentanyl, or partial agonists like buprenorphine, especially which is used nowadays for transdermal patches, and agonist antagonists like pentazocine, nalbuphine, and norepinephrine. And we have to definitely take care of all the side effects. Opioids, they're associated with numerous side effects and overdose. We have to take care of these things, and the management has to be there for the opioid overdose also. Tramadol, commonly used as a orally sustained release prevention, or IV, up to 400 milligrams per day is used, and even infusions of tramadol have been used. Local anesthetics, very commonly used agents in conjunction with the our pharmacological agents. And yes, all of them, ropivacaine, and lignocaine, they all have been used, and we all know the maximum doses commonly used with adrenaline and ropivacaine. And we have to take care of the potential side effects, and also have lipid emulsions also available in the OTs where we are using for potential overdose. Regional anesthesia techniques form an integral component of postoperative pain management now, in addition to systemic analgesics. And with USG coming up in majority of the institutes, I can say with conviction that now we are dealing as a USG guided regional anesthesia techniques are an important component of multimodal postoperative pain management. We can go for n numbers of peripheral nerve blocks, surgeries of hernia, hydrocele, ilioinguinal and ilioepicystic nerve blocks, surgeries of arm and hand with brachial plexus. Thoracic, we can go for intercostal, paravertebral, intercrural, thoracic epidurals, pec block, genital anterior plane block, rectus spinae block, for circumcision, penile block, lower limb, n number of blocks, femoral, sciatic, popliteal, and for paracervical block for DNCs and cone biopsies, and abdomen, tab, KOL, rectus spinae. All blocks can be done. So thoracic surgery, yes, we can go for as less as intercostal block to thoracic epidural anesthesia. Thoracic paravertebral blocks are available, ES plane blocks are available, and pectoral serratus anterior plane block are commonly done under USG guidance nowadays. So I think it is beyond my scope to go into the individual blocks for paucity of time. For abdominal surgeries, TAP block, lumbar paravertebral block, ilioepicystic nerve blocks, KOL block, quadratus lumborum block, and ESP blocks are commonly used. And for upper extremity nerve blocks, we can think of interscalene, supraclavicular, infraclavicular, or axillary nerve block. They can be usually put as a continuous infusions which are done for such blocks. And lower extremity, we can go for lumbar process nerve block, the psoas compartment, femoral nerve block, combined with lateral cutaneous nerve and saphenous nerve block, obturator nerve block, adductor canal block, and the other blocks. Epidural analgesia is an integral component. We all have been doing it and following with the background infusion and patient-controlled infusion of local anesthetic with the opioids. It can be done at all levels. It has been done, whether it is thoracic or lumbar or even cervical also, I can say. And for levels differentiate, if you are going for the higher surgeries like pneumonectomies and mastectomies and thoracotomies and thymectomies, you have to go for T4 to T8. Upper abdominal surgeries, esophageectomies, gastrectomies, T6 to T8, and middle abdominal T7 to T10, and lower abdominals go slightly down, T8 to T11, and lower extremities L1 to L4. So you have to put it in appropriate levels so as to consider give good analgesia and sedation. So post-op analgesia, which is used in common surgeries, are for post-cesarean. The systemic, oral, and IV includes the choice of NSAIDs, acetaminophen, opioids. And for local, we can think of infiltration of incision site with local anesthetic, epidural analgesia, and patient-controlled analgesia. And blocks include TAB block, KOL block, ilioinguinal and ilioepicystic nerve block. For laparoscopic surgeries, the systemic analgesics include acetaminophen, NSAIDs, dexamethasone commonly used, infiltration of wound sites, epidural analgesia, intraperitoneal installation of local anesthetics, and peripheral nerve blocks, including TAP block and rectus sheath block. For hip and knee arthroplasties, systemic analgesia includes acetaminophen, NSAIDs, opioids, and local site infiltration, epidural analgesia, though it has now taken a backseat because of motor involvement, and high volume local anesthetic infiltration in the wound itself. And the nerve blocks includes the rectal canal block, especially for TKR, and psoas compartment block, fascia iliaca block, especially for THR. For daycare surgeries, hernia, hydrocele, anorectal surgeries, systemic includes paracetamol, NSAIDs, and local infiltration of the wound. And if required, you can go for a caudal analgesia and ilioinguinal and iliohypogastric nerve block. Patient control analgesia is definitely used everywhere where there is acute pain services, and you have to take care of the bolus as well as the lockout intervals. So there are different pumps which are available, the electronic ones and the elastomeric infusion pumps, and which can have a continuous basal infusion. And with elastomeric pump, we have got patient control analgesia also. So they can give bolus also, and they can range from 1 to 15 ml commonly, but can go as high as up to 100 ml flow rate. Capacity as low as 100 ml to as high as 400 ml is also available. And then there are variable flow rate, which is commonly used, continuous background infusion plus patient control analgesia with for a bolus, it can be given. So these are all available in market, depending upon the setup where you are working. And there are different regimes also for using patient control IV analgesia and opioids also, fentanyl, morphine, which is commonly used, and for the patient control epidural analgesia. And no doubt it is advantageous because it involves patient participation, precise analytic calculations, reduced requirements, and reduced incidence of breakthrough pain. Transdermal patches, though they have found their way into the acute pain management, they were initially meant for chronic pain management and chronic cancer pain management, but still they are being used. So I'm just covering it, that they are used, especially the buprenorphine patch, but we have to be cautious about the fever and rapid absorption. But still it is being used across the country. To summarize, we have to develop a model for postoperative pain management where which the hospital administration, this set standards for postoperative care in accordance with the national and international guidelines, leading on to formation of postoperative and acute pain teams, which will develop strategies, which includes primarily the overall responsibilities that of we, the anesthesiologist, then the pain nurse, the surgeons involved, and some help from the hospital pharmacy. And we have to develop the plan for pain management, staff training, quality control, and auditing. And then implement the post-operative pain management, depending upon, there are so many blocks available, so many techniques available. You develop your own institute protocol, depending upon the evidence-based medicine, and do post-operative rounds, and you have to go to different wards. It is difficult to have a single place. You can have an SDU for 24 hours, but ultimately the patient will go to their own rooms or to the respective wards. And you have to take care in the ward itself, where you should have a dedicated pain nurse also available who knows your protocol and who can contact you at any point of time. To conclude, excellent post-operative analgesia means improved patient satisfaction and doctor-patient relationship, better rehabilitation, earlier discharge from hospital and return to function, decreased likelihood of chronic pain, and reduced healthcare costs. And ultimately, I repeat, we should aim for pain-free hospitals having acute pain services and fully functional chronic pain clinics. Thank you for a patient hearing.
Thank you, Dr. Naveen sir, for a very elaborate talk on the post-operative pain management. You touched the nice points in your talk, that is pain-free hospitals. Really, that is the need of the day today. And acute pain services, we have to make the availability of the acute pain services also. And we definitely lack in the post-operative rounds, because even from my student days, I remember that We never used to go to the wards again once the patient is shifted to ward. Now I don't know what is the situation exactly. And the pain management is a teamwork. There is no doubt about it. The American Pain Society has also laid down certain norms for this also. And the PG students can go through some of the articles which are there, published by the American Pain Society. There is a need to educate the patient and educate ourselves also. That's a good sign. So we have to talk with the surgeon and the anesthesiologist for the pain management. That is the important part of it. And you rightly said that it is an ongoing change. We have to change it every now and then according to the situation. But above all remains one thing is that it is a multimodal analgesia system which is there. And we have to use it that to reduce the dosage of the opioids. And one good topic which appears on the internet every now and then is that the acute pain management in chronic pain management patients who are mostly on the opioids and they consume a lot of opioids. In them, it is really difficult to manage the acute pain services. Linear anesthesia and non-blood sensitivity testing can be used rightly for the pain control. Thank you very much for the nice talk, and I feel the topic can be opened up for the questions if they are there from the audience. In the chat box, I am not finding any question. One question is there, whether spinal analgesia can be included in the pain management or not. So that's the only question which has been given by somebody. I will tell you the name of the person also. Whether we can introduce the spinal analgesia into this. Sunil Muralidhar Patil, he has asked it. Spinal analgesia, can we include it in the...
Yeah, I think this was before that my talk started, pertaining to some other thing.
That is for another topic, I think.
Oh, okay. I thought it was for this topic.
But I have my small question.
Yeah.
So we are many times doing cases in nursing home, freelance anesthetists. We give spinal, and then once the case is over, we leave the nursing home. So these patients then, when they develop pain in the post-op, for umbilical hernia or lower abdominal surgeries, so we get suddenly a call, can we give Fortwin Finargan? So just enumerate or some minor tips that we can guide the nursing staff in the post-operative period also.
See, this is practically happening in all nursing homes across the country. Initially, they go for diclofenac if patient is either mostly by IM, but yes, some nursing home also give for IV preparations which are available, combined with the paracetamol. This is a common thing. And in the night, usually they go for a Fortwin Finargan so that the patient can sleep. It is commonly done 30 milligrams of Fortwin and 25 milligrams of Finargan is commonly done with good antiemetic effect also and sedation also. Yes, Fortwin, you have to take care of some hypertension and ischemic heart disease patients. That thing has to be taken care of. But I think the problem is that we are not going in post-operative period because remuneration also. But at the end of the day, we have to sit together with the patients and the doctors also, surgeons also, that this services is required. This is human right of adequate post-op analgesia. And if services are good, remuneration will also be given for that. I've talked to so many practitioners. You touched a sensitive chord, that why it is not being done. Abhi to case karwane se fursat nahi milti. Aap keh rahe ho spinal, the surgery is over, they go. At times they go earlier also. They have to go, yes. Right? But we have to change somewhere. We have to change somewhere for better. Or it is possible. It can be done. It can be done. Problem is, we only see other nursing homes. You see if some of your relative gets operated, then go and see that patient in the evening. Then you will say how much pain is there for a simple cesarean section, also simple herniorrhaphy also. And what to talk about TKR and other things. So their surgery is painful, and we should see the patients in the post-operative period to assess the magnitude of the problem. Then we will automatically deal it. In corporate setups, you go, patients pay for it, and they get good pain relief also. You talk of any USG guided block, it is administered there. You talk of any catheter, any technique. So, but I am not focusing this talk only on corporate hospitals. I have focused this talk on across the country's spectrum, whether they are practitioners, whether they are institute people, or whether they are corporate or nursing homes. Right. So we have to develop, we have to make pain-free hospital, not a pain-free medical college, but pain-free nursing home also, pain-free medical college also, and pain-free corporate hospital. Dr. Anjali Bure?
Yes, sir. Sir, I just want to know how long do you think the acute pain services should be provided in the post-op period?
Majority of the time it's 48 to 72 hours, except for few surgeries which can be long, like a major Whipple's procedure or a major gastrectomy or thoracotomy involving pneumonectomy. But usually within 2 to 3 days, patient is on oral medications, and with good acute pain services, pain management requirement is less. But till the patient is discharged, the patient is seen whether the stay is less than 24 hours or stays as long as 2 weeks. You have to see the patient daily, regularly, not as I told you, for the comfort of your time. Patient can have pain anytime. So it's not depending upon your availability that patient will have pain, but he or she can have anytime. So we should be available, our network, pager, mobile, whatever it is there, we should be available 24/7. So my request again is, I know it is a difficult thing, we should dream and believe that we can develop pain-free hospitals. And I'm not talking about acute pain services, but also chronic pain clinics also. Both the things I'm talking about.
Navinji, I have one question.
Sir.
Yeah, definitely we should make the hospitals pain-free. Mostly our colleagues, those who are practicing at nursing home levels, and they live from one place to another place, and distances maybe 1 or 2 kilometers or 3 kilometers sometimes, and the call comes as a doctor raised the issue. Call comes, what is to be given, or something is given before they call them. Usually they give diclofenac injection, and then they called, there was a reaction, then called the anesthetist, he advised on phone, and he was behind the bar, and we have struggled a lot to take him out in Pune city. Everyone is well aware of that. What is the medical legal and what stand we can take? There's a probably administrative question also.
Sir, administratively, it is a very easy question to answer. Any advice on mobile phone or any advice on WhatsApp is legally not tenable. Telemedicine services have been allowed legally by the NMC, but there is a set procedure for that. But otherwise, just because some adverse reaction is there, if you cannot go there physically and manage that adverse reaction, please don't give advice on WhatsApp or on record telephone. You can say that, okay, I'm coming, you start this thing, but that is totally not for medical legal purposes. You go there, physically examine the patient, and then give the treatment. It is a settled law, established law.
I think, sir, can I speak? Sir, I think, Sai, sir, here the question of training our nursing staff and the paramedics will come into play, where they can observe and they are actually trained to look after this. Naveen, sir, what is your call on this?
Excellent, because we have to train our team. It's not an individual work. It should be a team of doctors. It should be a team of dedicated pain nurses. I know there have been some hospitals which we have developed certain particular colored forms, and pain nurses have been trained, not only for acute pain, for chronic pain also. So you have to train your nursing staff, because they will be there with the patient 24/7. You will go for a visiting thing only. So their education, they should know what are the protocols, what problems can occur. If a problem is there, what has to be done, who has to be contacted, everything should be laid down methodologically. There have been numerous talks about post-operative pain management. I have not intentionally touched about the blocks and other things, but we have to develop, we have to start thinking of establishing in each hospital. Our aim, I am again repeating, should be pain-free hospitals.
It's true. Thank you.
Thank you, sir. Thank you for that insight.
I have one thing.
Okay, sir. Please.
Sir, there are a lot of now papers on the net about the transitioning period of the patient's post-operative pain. That is transition from intramuscular or IV to the oral part. And we are lacking in that particular part, and therefore the post-operative pain management is done not adequately, but it is done inadequately. Therefore, they remain in the pain state for a longer time, and thus they land up into the chronic pain syndromes. So there are a lot of papers on this transitioning period from the hospital to the OPD or hospital to the home. and PG students can go through that and they can find out what are the important aspects which are there, which are discussed in so many papers now.
Chronic post-surgical pain is a known entity, sir. And the most important cause of chronic post-surgical pain is inappropriate treatment of acute pain.
Acute pain, true.
Right. And definitely there are other patient factors also and surgical factors also. How thoracotomies will have more incidence, breast surgery will have more incidence of post-surgical chronic pain. If we are harvesting bone marrow, that will also have more incidence of chronic post-surgical pain. And treatment of chronic post-surgical pain starts from preventive and appropriate multimodal anesthesia. You have to rule out all the known causes of pain in postoperative period, whether it is infection or any other nerve interruptions or nerve injuries. And once you have ruled it out that there are no other known causes of pain, then you label it as chronic post-surgical pain. And you have to treat acute pain so as to prevent chronic post-surgical pain. But still, if chronic post-surgical pain develops, gabapentinoids, they are a very commonly used drug in addition with tramadol and tricyclic antidepressants. They are commonly used for treatment. We see lots of patients of chronic post-surgical pain in our pain clinics also, that they are having pain, persistent pain for months and months together following the surgery.
Thank you. Thank you very much, sir. A nice talk from you. Nice answer. Thank you.
Thank you very much.
Thank you so much.
Thank you, everybody, for the wonderful insight in managing our patients for the post-operative pain as well. On behalf of Thane ISA, I would like to invite Dr. Ashok Deshpande sir to felicitate Dr. Naveen Malhotra sir for giving us a wonderful talk and honoring our invitation and joining our CME. Thank you very much, Dr. Naveen Malhotra sir.
Thank you.
This virtual.
Thank you. Pleasure is all mine. Thank you.
On behalf of Thane ISA, I would like to also felicitate Dr. Ashok Deshpande sir for chairing this session and sharing his wonderful insights and also bearing with us for all the technical glitches. Once again, a warm welcome. Thank you very much. We are highly obliged and slightly sorry for the technical issues in getting you online. Thank you very much, everybody.
Thank you, Dr. Deshpande sir, Dr. Malhotra sir, and Viral for that excellent talk. Like it is said, being pain-free is the right of every patient, and keeping him pain-free is our duty. Let us move ahead now. Some days back, I read a WhatsApp forward which said, there are only two people in this world who will ask you, have you eaten? One is your mother and the other is your anesthesiologist. While your mother wants your stomach full, your anesthesiologist wants to make sure that it is empty. Fasting guidelines will be told to us by Dr. Manisha Katikar. The moderator for this session is our treasurer, Dr. Parna Thakkar, who is also our governing council member, and she is a senior consultant at HN Reliance Hospital, Mumbai. Dr. Parna Thakkar, please.
Thank you, Manisha, for the kind introduction. I thank my branch, Thane ISA, for giving me this opportunity to moderate this session today. It's a pleasure to invite our very own Dr. Manisha Katikar, Madam, who's the President, Maharashtra State Chapter ISA. Madam is also the Chief Anesthesiologist and Intensivist at Balwant Institute of Neurosurgery and Trauma Care, Solapur. She is also the Associate Editor, IJA, and National ISA Coordinator of Cultural Event. She was a GC member, Maharashtra State Chapter, ISA, from 2008 to 2010. She was also the founder editor of newsletter of Maharashtra State Chapter, ISA, Misa News, from the year 2008 to 2012. She held various posts at Maharashtra State Chapter, ISA, as Secretary-elect, Secretary, Vice President, and Vice President-elect from 2014 to 2021. Madam received Proficiency Award thrice at ISACON Kolkata 2017, at ISACON Bangalore 2019, and at ISACON Ahmedabad 2021. She also received Coles Award at ISACON Ahmedabad 2021. Madam was also honored with Rukmani Pandit Award at ISACON Ahmedabad 2021. Today, Madam will be speaking on fasting guidelines. I would now invite Dr. Balabhaskar sir to chair this session. Dr. Balabhaskar sir is the professor at VIMS Bellary. He's a member of Publications Committee of WFSA. He was the President ISA National in 2019. Also the past editor-in-chief IJA from 2013 to 2016. He's the chief coordinator for formulation of 5 ISA practice guidelines. He is the editor of Journal of Medical Sciences, RJMS. His areas of interest are research, guidelines, and education. He has publications, over 50 publications to his credit. Over to you, Manisha Katekar, madam.
Good morning, all Asians. Today I'm going to speak on perioperative fasting and feeding guidelines in adults, obstetric and pediatric, as well as bariatric patients. These are the practice guidelines from Indian Society of Anesthesiologists, which are published in Indian Journal of Anesthesia 2020. So whatever I'm speaking for next 10 minutes will be the guidelines that are published in the IJA, and they are meant for practice in Indian subcontinent. So preoperative fasting is nil by mouth before any surgical procedure requiring sedation or anesthesia. This is because we need to completely avoid oral dietary intake in the post-operative period till there is recovery of bowel functions, especially in patients with abdominal surgeries or patient is wide awake with intact airway reflexes. This is because if there is impairment or abolition of airway reflexes, there is pulmonary aspiration of gastric contents. And to minimize the risk of regurgitation and aspiration, we need our patients to be nil by mouth before sedation or anesthesia. A published study has already proved that a gastric aspirate volume of more than 25 ml with pH less than 2.5 will have significant pulmonary aspiration leading to respiratory failure. So why there is a need for ISA guidelines in India? This is because there is large number of surgical procedures that are practiced in the diverse healthcare settings of India. There are differing practice standards, and of course, there is variation in the food items consumed in different regions and states. At the same time, there are different socio-cultural, geographic, and economic factors. Hence, we needed ISA guidelines for perioperative practice of fasting and feeding. These guidelines have been published by ISA with emphasis on safe duration of fasting before and after administration of sedation or anesthesia for elective diagnostic or surgical procedures, with emphasis on type and quality of solid and liquid food ingested safely till the fasting is initiated and feeding is restarted. And these guidelines are meant for general as well as pediatric, obstetric, and bariatric populations. These guidelines are developed by ISA based on country-wide survey, current evidence available in India and worldwide, institutional practice patterns across India, and these guidelines are not applicable for patients with risk of aspiration. The recommendations for these guidelines are withholding solid and liquid food before elective diagnostic or surgical procedures performed under regional or general anesthesia, and resumption of oral feeds in the post-procedure period. The aims of the guidelines are reduce incidence and severity of aspiration pneumonitis, prevent delay or cancellation of surgical procedures, better patient outcome, patient's knowledge of clear liquid, non-clear liquid, light meal and heavy meal to be improved. There should be a guide in consumption of food items before presenting for elective diagnostic or surgical procedures. These guidelines will allow formation of institutional protocols and will stimulate research among the colleagues so that evidence is added for the future. So the grading of guidelines, they depend upon the level of evidence, and depending upon the effect between the true effect and estimated effect, the grade certainty can be mentioned as very low, low, moderate, and high. And there are various levels of strength of recommendation that has been available because of levels of evidence. They can be strong, moderate, or weak. Strong is a high quality of evidence, while moderate is moderate quality of evidence. Weak is a low or very low quality of evidence, predominantly based on expert judgment for good clinical practice. So depending upon these grades and strength, various guidelines have been developed in the obstetric as well as pediatric and normal population, and they have been advised to be practiced in all over India. By definition, preoperative fasting is minimum required fasting duration of oral intake of solids or liquids prior to administration of anesthesia or sedation, necessary to minimize the risk of regurgitation and pulmonary aspiration in patients who are devoid of risk factors for regurgitation. Empty stomach, by definition, means a state when the gastric contents reach the baseline volume after the intake of a solid, semi-solid, or a liquid meal. Baseline volume is the volume of gastric contents of an adult after overnight fasting. Residual gastric volume is the volume of gastric contents at the time of examination or evaluation. And full stomach is presence of solid content or a state of increased volume of the liquid gastric contents above the baseline volumes after the intake of solid, semi-solid, or liquid meal. Clear liquid is a liquid which takes 2 hours to empty from the stomach in human beings. Non-clear liquid is a liquid which takes between 2 to 4 hours to empty from stomach in human beings. Light meal is any food item which takes between 4 to 6 hours to empty from the stomach, while heavy meal is a food item which takes more than 6 hours to empty from the stomach in the human beings. So there are various recommendations for all the sections that has been published, and depending upon those levels of recommendation, we need to practice various points in the guidelines. So there is a strong recommendation for clear liquids should be allowed up to 2 hours prior to administration of sedation or anesthesia. At the same time, there is a weak evidence for allowing volume of clear fluid that might be restricted to less than 450 ml 2 hours prior to administration of sedation or anesthesia, and non-clear liquids may be allowed up to 4 hours prior to administration of sedation or anesthesia. So we need to remember the strong recommendation. Clear fluids should be allowed up to 2 hours prior to administration of sedation and anesthesia. The light meal as well as heavy meal. Light meal may be allowed up to 6 hours prior to administration of sedation and anesthesia. In patient who has consumed heavy meals, it may be prudent to wait for at least 10 hours prior to administration of sedation and anesthesia. Both of these evidences are weak evidences. However, there is a strong evidence for heavy meal consumption not advisable the night prior to surgery. There is strong evidence for routine use of aspiration prophylaxis in adequately fasted patient. It should not be advised prior to administration of sedation or anesthesia. There is a weak evidence for aspiration prophylaxis is advised in high-risk patients as identified by the anesthesiologist, and H2 receptor blockers, proton pump inhibitors, and prokinetic drugs may be used in prophylaxis in high-risk patients. Again, it has a weak evidence. In obstetric section, there is a weak evidence for pregnant patients in early or late pregnancy. When they are administered sedation or anesthesia, they may be considered to be at high risk of aspiration. Clear liquids allowed up to 2 hours prior to administration of sedation or anesthesia in pregnant women. Non-clear liquids may be allowed up to 4 hours prior to administration of sedation or anesthesia in pregnant women. All of these have weak evidences. However, there is a strong evidence that heavy meal consumption is not advisable the night prior to surgery in pregnant women. At the same time, light meals may be allowed to 6 hours prior to administration of sedation or anesthesia, and in patients who has consumed a heavy meal, it may be prudent to wait for at least 10 hours prior to administration of sedation or anesthesia. Both of them have weak evidences. Again, there is a strong evidence for pregnant women requiring sedation or anesthesia should be administered aspiration prophylaxis. Strong evidence is there for clear liquids that can be allowed orally 8 hours after cesarean section under vaginal or general anesthesia. In pediatric section, there is a strong evidence for consumption of water up to 3 ml per kg should be allowed until 1 hour prior to administration of anesthesia. However, there is a weak evidence for both consumption of clear liquids other than water and human milk and fully skimmed non-human milk that can be administered 2 hours and 4 hours respectively prior to administration of anesthesia. There is a strong evidence again for oral consumption of clear liquids in the post-operative period that should be resumed at the earliest where no medical or surgical contraindication exists, and there is a weak evidence for non-clear liquids, non-human milk, formula feeds, light breakfast or light meal that may be allowed until 6 hours. The attending anesthesiologist can decide for or against the administration of aspiration prophylaxis in adequately fasted child, and the attending anesthesiologist can decide on the duration of fasting for procedural sedation within OR or at remote location. In bariatric sections, obese individuals may be considered at high risk for aspiration in comparison to non-obese individuals when administered sedation or general anesthesia. This has a weak evidence. Again, there is a weak evidence for obese patients where preoperative fasting guidelines may be the same as in non-obese individuals. Aspiration prophylaxis may be administered in obese patients. Again, it has a weak evidence. And drugs like H2 receptor blockers, proton pump inhibitors, either alone or in combination with prokinetic drugs, can be administered for aspiration prophylaxis in obese patients. Again, it has a weak evidence. There is a strong evidence for the quality and quantity of gastric contents that should be assessed by the gastric ultrasound in the right lateral decubitus position, and gastric ultrasonography may be used as a bedside tool for assessing the quality and quantity of gastric contents in the preoperative period. This has a weak evidence. So depending upon the definition of various kind of food items, the food items are classified into clear liquids, non-clear liquids, light meal and heavy meal. Clear liquids by definition, it has an approximate emptying time from the stomach less than 2 hours. Non-clear liquids, it is 2 to 4 hours. Because of diversity in food items in different parts of the Indian country, we must know what are the foods that can be labeled as clear liquids. So clear liquids are coconut water 400 ml, black tea or coffee 200 ml, 25% dextrose, juices like watermelon, pineapple, apple, sandalwood sharbat, ruafza, khas sarbat, aerated cold drink, Tetra Pak juice, rice ganji, clear soup broths, dal water, green tea, and maltodextrin preparations. Non-clear liquids can be various rava kheer, that is up to 200 ml, ragi malt 200 ml, sattu drink 200 ml, milk 200 ml, buttermilk 300 ml, milkshake 200 ml, fruit yogurt 150 ml, cold coffee 200 ml, filter coffee 200 ml, and smoothie 200 ml. The light meal will include bread slice 1 with cream of soup, curd rice 150 gram, dal rice 150 gram, fulka with vegetable 1 with 4 spoons of vegetable, curd 200 ml, milkshake with fruit 200 ml, milk and cornflakes 1 cup, idli sambar poha 30 gram, puffed rice 150 gram, Mari biscuits 4 in with milk 150 ml, glucose biscuits 4 with milk 150 ml. All these can be included with light milk with approximate gastric emptying 4 to 6 hours. Well, heavy milk that is the milk with that is a full milk. That is a thali with chapati, rice, dal, veg curd, noodles with curries, pongal with curd, dosa with chutney and sambar, thali rice, curd, pickle, paratha, dahi and pickle, chicken curry and rice, kebab with French fries, pizza, 2 triangles, cake burger, and all this can be considered as heavy meal with gastric emptying more than 6 hours. So depending upon this is a diagrammatic representation of various food products that has been mentioned by various depending upon the food items with various gastric emptying times. So these are the perioperative fasting and feeding guidelines for adults, obstetric patients, pediatric patients, and bariatric patients, published by Indian Society of Anesthesiologists, and they are published by in the Indian Journal of Anesthesia in July 2022. Thank you for giving me opportunity to present these guidelines that has been published by Indian Society of Anesthesiologists.
Thank you, Manisha Madam, for the excellent talk and enlightening us. Thank you, Balabhaskar sir, for chairing the session. Sir, if you have any questions, please go ahead.
I would like to mention first. I would like to mention, in fact, first, these are whatever, this is not at all what I am, it is what my knowledge, it is what Dr. Balabhaskar sir has taken a lot of effort for publishing this kind of guidelines, and there's a huge survey that was carried out. We had also received that time. So it is the great work that has been done by Dr. Balabhaskar sir, and we are so lucky that Maharashtra State Chapter ISA, this national sponsored CME and ISA are so lucky to have the writer and the man behind these guidelines to be here on this dais of the prestigious dais of ISA Thane. Sir, I must say that I must thank you very much. Thank you very much for coming here and sharing the session.
Thanks a lot. Thank you. I saw President of ISA National, the Secretary, the Vice President, Dr. Anjali, and Dr. Deshpande sir. Of course, we had Dr. Manisha herself, the President of ISA Maharashtra, and three of you, Dr. Minal, Dr. Manisha, and Dr. Parna also, representing ISA Thane, Dr. Sunil Katkade, and all the seniors have been here. Nice to be part of this event. And of course, with respect to the ISA national guidelines, it was a highly discussed project which took nearly 1.5 to 2 years to publish also. So the highlights have been, just I will not take much time because the session is on. We have been special in the sense that we have talked about the food items. We always talk about the ASA guidelines, European guidelines and others, but we were always confused about the food items because what is consumed in Western countries is different from what we consume here. So we were fortunate to have the services of a nutritionist, a qualified nutritionist. A lady was there. She helped us a lot. Apart from our survey conducted across India, we conducted a survey including people from north, northeast, south, central, everywhere. She could come up with important evidences with respect to the nutritional value of all the dietary items which were shown in the table. Because we are bothered about the fat content, we are bothered about the carbohydrate and the calorie content. So she produced evidences and she participated. In fact, I joined late this session today, in the sense I wanted to join by 12 at least. I had a discussion with many of our experts, including Dr. Sunanda Gupta, Dr. Sunil Pandya, Dr. Jayashree Sood, so they were all part of my team. So we are trying to see what has accumulated after our publication, what is new, and what has to be done by our group on behalf of the ISA National further. So one most important thing that was also discussed was how to publicize and propagate this. So that way, I'm very happy that the Thane City branch has taken up this topic, and Dr. Manish has done a wonderful job projecting the ISA guidelines. Thank you very much. And my only suggestion and advice for all our ISA members is to please download that pamphlet. It's like a pamphlet which is available in ISA National website, where we have got, it's like a ready reckoner for adult, pediatric, obstetric, bariatric group, plus the food items. So please use it liberally in the private setups also. And in my today's meeting, we have decided to make a patient information brochure where we advise the patient which items can be taken. What was published was from our side. So what we intend to prepare is what the patients could opt to eat or drink in the preoperative period. So that can be shared among our private practitioners, and that can be put up and taken forward. So thank you. And any doubts which need clarification from my side, I'll be ready to answer. The chairperson, please. I mean, moderator, please, you can decide.
Yes. Yes, sir. Sir, thank you very much for being here. And there are many questions in the chat box. So you or Dr. Manisha Katekar, madam, can answer these questions. And we would go ahead now with the program. And so please felicitate Dr. Manisha Katekar, ma'am, with a floral bouquet from all of us. Thank you, ma'am. And sir, please accept this bouquet of roses from all of us. Thank you very much, both of you, for being.
Thanks a lot. I will answer the chat box questions.
Shall we continue? Thank you, Dr. Balabhaskar sir, Dr. Manisha Katikar, and Dr. Parna for that excellent session. I am sure ISA will come up with a lot of guidelines which will help us in our daily practice. I request all of you to actually download that pamphlet from the website and laminate it and put it up in your surgeon's cabin or somewhere in the OT, so that they know how much is the fasting required, what they can give the patients before surgery. So I think that will be very useful. This will be our gift from us to our surgeons. I think today we can do this little exercise. Besides academics, ISA has a lot more to offer for anesthesiologists of every age, or whatever his mode of practice be. We have made a little film which has been made by our dynamic anesthetist, Dr. Viral Haria, which highlights some of these programs. I request all of you to have a look at this little film. Thank you everybody for watching that little film, and thank you Viral for that nice project that you undertook. We will move ahead with the scientific session now. The child is said to be the father of man, but is the small child to be considered as a small adult while anesthetizing? Let us find out from our next speaker, the expert Dr. Nandini Dave. I call Dr. Manjari Ranade, our Joint Secretary, to moderate this session. Dr. Manjari is a practicing anesthesiologist as well as a pain physician and has her own pain clinic in Thane. Dr. Manjari Ranade.
Thank you, Manisha. Let me take a pleasure to invite our today's chairperson, Dr. Milind Pol, sir, on behalf of Thane ISA. Welcome, sir. Dr. Milind Pol, sir, is our immediate past president of Maharashtra State Chapter. He is associate professor at Vikhe Patil Medical College, Ahmednagar. I also take a pleasure to introduce our speaker, Dr. Nandini Dave, for today's talk. Dr. Dave is a senior consultant and head SRCC Children Hospital at Mumbai. She was ex-professor and HOD in Pediatric Anesthesia Department at KEM Hospital. She's faculty for fellowship in pediatric anesthesia and has over 100 publications to her credit. We all know over the years, pediatric anesthesia has become a subspecialty in anesthesia. Today, Dr. Dave is going to enlighten us on the topic of practice in pediatric anesthesia for non-pediatric anesthesiologists. Over to you, Dr. Dave.
Good day and wishing everyone here a very happy and safe 2022. Thank you to ISA Thane for this privilege. I bring greetings from SRCC Children's Hospital, Mumbai. Before I begin, a confession from somebody who practices occasional adult anesthesia. This is truly one of the more difficult talks I have prepared for. Give me a concrete topic like ERAS in pediatric anesthesia or say IV fluids in children, and it's easy for me to prepare and deliver. But what do I talk to an audience of mostly adult anesthesiologists about how to anesthetize an occasional pediatric patient? And I'm aware that there are a lot of seniors attending the CME. So what I've done is present some evidence, some of my experience, some common problems in pediatric anesthesia. And hopefully at the end of this talk, I'll leave you with what to do and what not to do when practicing occasional pediatric anesthesia in the setups you work in. This paper talks about choosing wisely in pediatric anesthesia. And what a group of pediatric anesthesiologists from Germany did was, they came together and looked at evidence-based recommendations, and they agreed about 10 do's and don'ts when it comes to practicing pediatric anesthesia. And this is an interesting read. They talk about no routine blood tests, they talk about parental presence during induction, and so on and so forth. My take is that we must not blindly adopt evidence-based recommendations which have worked in their setups. And what I'm going to do is in the next 20-25 minutes, walk you through my talk, and at the end, present some do's and don'ts, which will hopefully work in the setups we are practicing in. This paper, published in Anesthesia in 2018, looked at severe critical events in pediatric anesthesia, and this is the result of the Apricot study. So the Apricot study essentially was a multi-center observational study, more than 30,000 children, 33 European countries, and the incidence of perioperative critical events was 5.2%. And the risk factors were young age, previous medical history, and the physical condition of the patient. So what we know from this study is that there are certain red flags when it comes to pediatric anesthesia. So children less than 3 years of age, severe comorbidities, congenital and metabolic diseases, syndromic children, and children who are posted for major and complex surgery. So the recommendation is that these patients be cared for by anesthesiologists with specific education, training, and ongoing experience in pediatric anesthesia. So when faced with these situations and these patients, it's okay to say no. Coming to the airway, when we look at children vis-a-vis adults, the good is that a true unanticipated difficult airway is rare. The incidence is about 1/10 that of the adults. The bad is that even if you know that the airway is difficult, awake intubation is not an option. So you'll still have to anesthetize that patient to put in the airway. And the ugly is that we know that they don't give us much time. They're going to desaturate early. So when you look at children like these, syndromic children, children with external ear abnormalities, these are all red flags. We know that the airway is going to be difficult. So how do you define a difficult airway in pediatrics? The syndromic child, the child with a pathology, say an oral pathology or trauma, these are all actually only the tip of the pyramid. More often than not, we are faced with a child who actually has a normal airway, but may be having a functional problem. What do I mean by that? So the normal pediatric airway, and there can be problems with difficult mask ventilation faced by the novice, because once you induce anesthesia, more often than not, the tongue is going to fall back, and then there is going to be airway obstruction because of soft tissue collapse. So functional airway obstruction is actually when pertaining to the upper airway, could be laryngospasm, maybe because of light anesthesia, and the lower airway, bronchospasm. And if you're not ventilating right, the stomach can get inflated and cause more problems. So the importance of keeping the upper airway open is so much so that there was a review article published in Pediatric Anesthesia about airway maneuvers in children. And what are these maneuvers? These are simple maneuvers like positioning the head and the neck, the chin lift, jaw thrust, CPAP, and in the recovery, the lateral position. So it's okay if you can't intubate the patient, but you must be able to ventilate the patient and use these simple maneuvers to keep the airway patent. More often than not, you always need CPAP to keep the upper airway open as the child goes under. So whether you're using a JR circuit or using a closed circuit, keep about a minimal, about 5 to 10 centimeters of CPAP to maintain the airway open. Many of us are used to using OPAs. I almost never use them, unless, of course, the nostrils are not patent because of choanal atresia or posterior nasal polyps. If you're using an OPA, you have to be very sure that the patient is not in a light plane. So that can trigger laryngospasm. But if you know the art of mask holding, more often than not, you don't need an OPA. So this is an editorial in pediatric anesthesia, and the editor talks about how to manage functional airway obstruction in a patient with a normal airway. So traditionally, we are always taught if we cannot ventilate the patient, we should not be administering the paralyzing agent. But what if it is a functional airway obstruction like laryngospasm, which is very common in pediatric anesthesia? So the editor talks about if you have identified a patient as having a normal airway which is not difficult to intubate or ventilate, and you cannot ventilate for some reason as you're inducing, it is okay. In fact, it is better to administer the paralyzing agent, which may be scoline in this case. And then almost always you will have the patient, the laryngospasm will break and you'll be able to ventilate and then further intubate the patient. This is a question we are often asked by the parents. What will happen if anesthesia is administered to my child? Because I've read a lot about neurotoxicity. So what do you tell the parents? So there is compelling preclinical evidence that anesthesia and anesthetic agents are neurotoxic. But the good news is that human studies, there are a lot of studies which are well-controlled, randomized studies, the PANDA study, the GAS study, the MASK study, and they've all come to this conclusion that a single brief, well-conducted anesthetic exposure is safe. It would be unethical to withhold sedation and anesthesia when necessary, and so the risks and benefits of procedures requiring anesthesia must be weighed against the risk of not treating certain conditions. So what do we tell the parents? We say that it's okay, anesthesia is safe, and we should go ahead with necessary surgery. Coming to fasting, we know now that 1 hour of clear fluid fasting is equivalent to 2 hours of fasting. So it's okay to be liberal with clear fluids. Moreover, there is improved perioperative experience for the child and the parents without increased risk of pulmonary aspiration. So what the consensus recommendations are saying today is that you can allow the child to drink clear fluids up to 1 hour of surgery. Now here it is important when you're instructing the child, the parents and the sister that they all understand what we are saying. So this recommendation is for clear fluids, not for milk, not for juices with pulp. So if your whole team understands this, it is all right. Otherwise, you would still want to stick to maybe the 642 rule. Else you might have a child who's had milk up to 1 hour, and then you would have to defer the surgery for a couple of hours. So it's important that the whole team is geared to understanding what we are saying. Coming to induction of anesthesia, if you have a choice, prefer IV induction. Get the IV in, maybe the pediatrician will put it for you in the ward before the child comes into the OR, and that's the best thing. Sevoflurane is not as safe as it is made out to be. Always have an experienced person to help you during induction and during extubation as well. So this was an RCT which looked at inhalational versus IV induction of anesthesia in children with a high risk of perioperative respiratory adverse events. So what this study did was they randomized children to IV propofol or sevoflurane induction, and they looked at the respiratory events at induction, and they found that the sevoflurane group had 3 times as much adverse events as the propofol group. So the recommendation is that wherever appropriate, anesthetists should consider using IV propofol induction in children who are at high risk for PRAE. My take on this is that almost all children are at high risk of respiratory adverse events because they either have an ongoing URI or they've just recovered from an URI. So it is always better, especially for the occasional pediatric anesthetist, to go in for an IV induction with propofol. So what do? You see a child in the preoperative room and the child has got an URI. Would you go ahead? Would you differ? So what the guidelines are saying is that if the secretions are clear, the lungs are okay, you don't hear lung sounds, the child is appearing healthy, there is no fever, it's okay to go ahead and do the case. But if the discharge is purulent, the child has got a productive cough, you can hear a wheeze or creps on auscultation, the child is appearing unwell, or the parent is saying that the child is unwell, go ahead and defer the case. Ultimately, listen to your gut feeling. If you feel that something is off, something is not right, it's okay to defer in the interest of safety. This was a review which looked at perioperative management of children with URI. And what this paper says, amongst other things, is that the experience of the anesthetist is crucial to prevent and treat perioperative respiratory adverse events. Now, in case your child doesn't have an IV, now you have to prepare the child for an inhalation induction. How do you do it? You might try behavioral techniques, especially if you have a way with children, it's nice. But remember, you must use language which is understood by the child. Very often we talk about things and you realize the child is not understanding a word of what you've said. So how do you do it? Well, one way to do it is talk to the child about, okay, I try to say that the anesthetic has a paint-like smell, but it will not be unpleasant to breathe. If you're using the vital capacity technique, you can talk about blowing birthday candles, something which most children are familiar with. If they know how to swim, you can ask them, it's like going underwater and you have to hold your breath and then breathe again. You can make it easier by using scented masks, quiet OR. The preoperative visit is a great time to assess whether the child is going to cooperate with you for an inhalation induction. Use distraction techniques as much as possible. Well begun is truly half done. I have a friend who's a pediatric anesthetist, and she says if she gets the vein in the first go, the rest of the anesthetic goes smoothly. I go one step further and say, if I can separate the child nicely from the parents, my job is half done. So use what you're familiar with. You can use oral or intranasal midazolam if you have a little less time. Some of the old timers are happy with triclophoz and it works really well, but it needs to be given about 45 minutes to 1 hour prior. So a lot of things can go wrong with inhalation induction. So the airway can get obstructed and we know how to manage that. The patient will start hypoventilating, and this is the time you have to gently assist ventilation. But mind you, if you've got your CO on full at that time, you have to be really careful, because with assisted ventilation, the MAC can go really high. And this is the time when CO can depress the cardiovascular system. But you would see the pulse rate dropping, and you'd be really careful. Turn down the CO slightly when you're assisting ventilation. This is also the time when you're really not looking at the blood pressure, so that wouldn't give you any clue. You can have laryngospasm with sevoflurane because it's not as pleasant as it's made out to be. And this is the time, mind you, when you don't have an IV. So you might have to resort to even intramuscular succinylcholine in that point of time. Be prepared. So this is how, you can imagine that this is the little child who's coming in, you've got the shoulder ready, you've got the gel head ring, you've got the ECG leads, you've got the BP cuff, the pulse cuff, everything, the warmer is ready to receive the child. So this is how you would prepare, unlike adults who can walk in and you can take your time, putting the ECG leads, measuring the blood pressure. Children are not going to give you much time, and this is how the devil is really in the details. Age-appropriate equipment is a must. Children come in all sizes. If you look at this preparation, at least 2 laryngoscopes working, checked, the scent is ready for the mask, your sizes of OPA are ready. I'd like you to pause here and wonder what is missing in this trolley. Any guesses? The endotracheal tube. So years of practicing pediatric anesthesia, and I would think I could guess what tube this child is going to take. And sometimes I'm caught out, and you think this tube is going to go in, but sometimes it will be too loose, or sometimes it wouldn't be. It would be a bit tight. So you must have one size smaller and larger than the size you're guessing would take in. The little finger gauge really doesn't work too well. Nowadays we have micro cuff tubes, and they're great tubes to use. And the advantage is they also have the age range written on the back of the pack, so that works really quite well. With the IV, check the IV, double check the IV patency. Check all the IV extensions for air bubbles. Have an OCD about this. Drawback on the syringes to de-air before injecting. The small air bubble which is there at the hub of the 3-way can go in, and truly a bubble can be a bullet to the child's brain. Use a burette set or a syringe pump always to administer fluid. A word of caution about syringe pumps. If at all the IV is extravasating, the syringe pump would still deliver if your settings are not right. A burette set would stop delivery. So use what you're comfortable with, but check that the IV is patent, check that there is no extravasation, check that the restraining splint is not too tight before you hand over the patient to the surgeon. Ensure good analgesia. Children, we know, feel pain equally as much as adults do. So if you have a technique which works really for all surgeries, it is the caudal block. Most of us are all well versed with caudal blocks. That the beauty of it is that, all types of surgery below the umbilicus can be taken care of. And the single shot caudal block is remarkably safe. There's not a single case of epidural abscess, epidural hematoma, or paraplegia after a single shot caudal in the world's literature. Of course, if you can't use the caudal block, use multimodal analgesia, but ensure that the child's pain is taken care of. Otherwise, you'll end up with a howling child in the post-operative area, and it can get quite ugly. Coming to medication errors in pediatric anesthesia, and it's quite common. This is a report from the Wake Up Safe Quality Improvement Initiative, which is a safety initiative from the Society of Pediatric Anesthesia. And what this report says is that the most common type of medication errors in children are dosing errors. And we're not surprised, are we? Because children come in varied sizes. And if the healthcare staff is unfamiliar with this age group, then you can very well end up with dosing errors. So how do we prevent it? This is what we were taught in residency, and this stands me in good stead even today if I'm doing cases. So note down the dosages, the dilutions. We used to paste this on our boils machine. Now we have fancy workstations, we have smartphones. So whatever works well for you, but do note down the dosages and the dilutions before you start anesthesia. How would you manage the airway? You have LMAs available, different types of LMAs. This is the blockbuster LMA, which is available from Turin Medical. It's a good device. It's essentially a third generation LMA. So you have the gastric tube. You can intubate through it. So in case you have a difficult intubation, you can put this in and you can blindly put your tube through this, and it works quite well. But ultimately, the bottom line is do what you're familiar with. If you're comfortable with endotracheal intubation, then it is the endotracheal tube you must use. So it's no point saying I've done this once and I can do it again. It's better if you get adequately trained in workshops or older patients before you can try all this in a pediatric setup. We all have our favorite pieces of equipment. This is mine, and it saved my life and the patients on more occasions than one. This is the Frova intubating introducer. It essentially works like a stillet. So you railroad your tube onto this. The tip is soft, so it's atraumatic. And in case you cannot intubate, you can ventilate through this connector. So it works really well for me. Coming to the last part of my talk, this is from the NAP4 audit. It talks about major complications in airway management in the United Kingdom. And what this audit said is that a third of the events occurred during emergency and recovery, and airway obstruction was a leading cause. So the recommendation was that this phase of anesthesia needs to be recognized as a period of increased risk and planned for. So what is the recommendation? How do you extubate patients, or how do you remove LMA in pediatric patients? Do you remove them deep, or do you extubate awake? So this was a systemic review and a meta-analysis, which looked at 17 RCTs, more than 1,800 children. And what this review said is that deep extubation reduced the risk of cough and desaturation. But when you extubate patients deep, there is an increased risk of airway obstruction. There was no difference in laryngospasm or breath holding, whether you extubated deep or awake. The recommendation is that you may choose your method of extubation depending on the risk of airway complications and depending on your expertise. So do what you're comfortable with, but be prepared for the airway complications depending on what you do. Now, some common post-operative complications. Post-extubation hypoxemia is not uncommon in the pediatric population. And there are a whole lot of reasons why a child is prone to hypoxemia. It could be because, we know they have reduced FRC, they may develop atelectasis. If you're using nitrous oxide, there could be diffusion hypoxia. Laryngospasm is a very common occurrence, and you must be prepared to manage and treat it. And the residual effects of anesthetics, neuromuscular blockers, these are all things you have to be prepared for, and be prepared to start oxygen if need be. Emergent delirium. The incidence is quite high. It can be up to 80% of all pediatric anesthetics. So this is something which we very commonly see. It's actually short limiting. It doesn't last more than about 15 to 30 minutes. But the problem is that it can be extremely distressing to the family. It really questions the quality of your anesthesia, and there is a risk of self-injury during this period. So what do? If you have a patient who's agitating in the PACU, you first rule out hypoxemia, hypotension, upper airway obstruction. If your patient has been fasting for a long time preoperatively, check the blood sugars. Ensure that the pain has been taken care of. And if you've ruled out all these factors, emergent delirium or emergent agitation is really a diagnosis of exclusion. There are scores to score this, if you may, and treat it. If you have a doubt whether it's pain, whether it's ED, fentanyl is a good drug to start with because it will take care of two things. Else you can also use propofol or midazolam. PONV. Again, there are scoring factors. This is from the Eberhardt scoring system. So if your patient is more than 3 years, the surgical duration is more than 30 minutes. Patients have to go establishment surgery. There are points for each, 1 point for each of this. If there is a history of PONV or history of motion sickness, you know that you are going to have PONV, and these are children will not complain about nausea, they'll directly throw up. So you need to plan for this and treat it with either 1 or 2 antiemetics, depending upon the scoring system, or use TIVA if you have to. Post-intubation stridor, we don't see a lot of this if you have planned and conducted your anesthetic very well. And the causes we know are a tight-fitting tube, repeated traumatic intubation, coughing, straining of the tube, too many position changes, and the presence of URI is a risk factor. So most of these complications which occur post-operatively can be actually prevented, and prevention we know is definitely better than going ahead and treating it. So I'll end with some do's and don'ts, the 10 commandments, if I may, when it comes to anesthesiologists occasionally practicing pediatric anesthesia. So know when to say no. It's okay to say no. It's all really about the ABCs. Take care of the airway, breathing, the IV. Know your patient. Do a good pre-anesthetic check. Forewarned is truly forearmed. Trust your gut. It's called gut feelings for a reason. If you begin well, you'll usually end well. Talk to the parents, establish a good communication, try and see how we can separate the child nicely from the parents. Use behavioral techniques if you're good at it, if you might need pharmacological methods to separate the patients, but do it well. Do what you're familiar with. If it's endotracheal intubation you're familiar with, go ahead with it. Check, double check. It's good to have an OCD when you're practicing pediatric anesthesia. Have help at hand at all times. Most of the problems are preventable. So prevent and preempt common problems. And really, most important, remain updated. Platforms such as these are a great way to stay updated. So that's it from me. Thank you for your attention.
Thank you, ma'am. It was an excellent lecture. I'm really a very less practicing pediatric anesthesiologist. But now I think I have got a good insight about how to practice pediatric anesthesia. Dr. Milind Pol, sir, do you want to comment or ask anything?
Yeah. It was very nice and elaborative lecture. Actually, it is oriented towards all the private practitioners, freelancers, working in smaller nursing homes. Only one comment I want to make that, madam, you have mentioned sevoflurane, but many of our colleagues are still using halothane and isoflurane. They have not used sevoflurane. And per se, I'll say that halothane is a better induction inhalational agent. It is used for induction in pediatric cases. And the second thing I just wanted to mention that if the patient have URTI and the patient is posted, say 10 years old patient posted for perforated appendix, and we are thinking of giving spinal, just we want to induce with some agent so that the patient remains calm during spinal procedure. So can we prefer ketamine and midazolam?
Of course.
Because many of
course, yeah. Yes, sir. As I understand, if it's an emergency surgery and we have to anyway go ahead. So all this scheduling, cancelling and all will be only for elective surgeries. If it's emergency, we have to go ahead. And in case your plan of giving the spinal or any regional, doing it under purely regional, if it works, it's a great technique, because then you're totally avoiding airway intervention. So ketamine, of course, why not?
Yeah. I will just go through the questions which are in the chat box.
Ma'am, there is one question which is asked, that use of dexitometate for a sedation in the case of pediatric patients. Will you recommend the use?
Yeah, of course. We use it all the time, especially airway interventions when you don't have an endotracheal tube or an LMA in, or say, for example, you're doing a fiber optic intubation. Dexmed works very well. We use it all the time. The only population I haven't used it is probably the very small. I mean, neonates, I'm a little careful. I don't like to, because you do need that heart rate to stay okay. Dexmed gets the heart rate down, and I'm not very, very comfortable using it in neonates. In infants, yes. For airway procedures where I'm going to use it, I'd do totally TIVA, then yes, Dexmed is a good choice.
Thank you, ma'am. Sir, anything else you want to?
Ma'am, if we are selecting TIVA, is it compulsory to intubate the patient?
No, not really.
To secure the airway?
No, depends on the procedure. Depends on the procedure. I mean, if say you're doing a spine and you're going to use neuromonitoring, then you would have to intubate and then manage the patient on propofol and Dexmed or whatever IV agents, because they have to get the neuromonitoring underway. But if it is a purely, I mean, some surgery where you don't need to manage the airway, you could do it under pure TIVA.
Yeah, because many of our colleagues fearing that the airway securing is must in pediatric case.
No.
That's why I just asked this question.
I think there's a lot of hoo-ha about pediatric patients. Honestly, it's just because we do it all the time, we don't feel. And that's why I said, I'm an occasional adult anesthetist. If an adult patient comes and I'm thinking a lot and everybody's wondering why I'm overthinking, but that's how it is. I mean, what we do every day, we feel comfortable with. It's all about that only.
It is exactly opposite reactions from our side, because we are occasional pediatric anesthesiologists. So we just fear for the worst, and that's why we are asking these questions.
I think, sir, whenever we go to do something which you're not doing routinely, and that's true for me also. I've started doing obstetrics because our hospital has started doing obstetrics. So I think a lot, I overthink, I read, I attend CMEs, and that's how you kind of gain, because ultimately we have all trained in all this, and then we are practicing, and all of us, I mean, most of us in the audience are quite senior, so there is no need to fear, except that I think we should just brush up our knowledge and our skills before we do something which we're not doing on a routine basis.
Your 10 commandments will be really helpful for all our delegates who are attending this CME. And it was a very nice session. Actually, any question from the delegate side, that will be answered by Madam in the chat box. So thank you, Madam, for this.
Thank you so much.
Thank you very much.
Thank you.
Thank you, my privilege.
Thank you, Dr. Paul, sir. Now I take a privilege on the behalf of Thane ISC. I would request Dr. Paul to felicitate Dr. Dave with a floral bouquet.
Thank you.
On behalf of Thane ISC, I take a privilege to honor Dr. Milind Paul, sir, with a flower bouquet.
Thank you very much.
Over to you, Manisha, for the further proceedings.
Thank you very much, Dr. Paul, Dr. Nandini, Madam, and Dr. Manjari for that really crisp, comprehensive, clear, and very good talk. It is now lunchtime, and I'm very proud that we are doing good time-wise. So we still have a 10-minute lunch break before we start again, but don't go anywhere. We have some wonderful films coming up. There is one film which is showing the history of anesthesia, how Thane progressed from being Thane Anesthesia Society to ISA Thane. And there is one little film which showcases our work that we have done over the few years. One film has been made by Dr. Parna Thakkar, which shows the history of Thane. and Thane Anesthesia Society and ISA and Dr. Katkade's contribution to it. And the other one is by myself and Dr. Shweta Patil, highlighting our work in World Anesthesia Day and COLS programs. So please wait and have a look. These are really, really enjoyable films and everybody will like them very much. So that was the blockbuster LMA from Turin, which Madam mentioned. We will now see the Thane Anesthesia Society history film.
Indian Society of Anesthesiologists, Thane branch, owes its existence to its founder member, Dr. Sunil Katkade sir. In 1979, Sir started his private practice in Thane, and in 1980, he held an academic meet where late Professor Dr. Y.B. Bhojraj and Dr. Vasumati Divekar were the speakers. In this meeting, Professor Chandrika Pure was felicitated as he was the Dean of Sir J.J. Group of Hospitals. Due to his passion for academics, Dr. Sunil Katkade sir continued this journey of arranging CMEs in Thane, and later on, Dr. Page sir and Dr. Godbole sir joined him in this mission. Soon these CMEs gained popularity and were attended in large numbers by anesthesiologists from Mumbai to Ulhasnagar. These meetings were rich in their academic content. Great speakers from all over India and stalwarts from other branches, just to name a few, Dr. Manke and Dr. Udwadia were also invited to give a talk. One of the CMEs was also graced by the presence of Padma Vibhushan, Dr. Anil Kakodekar sir. These meets also provided a platform to young anesthesiologists to showcase their work. In 1996, a body called as Academic Society of Thane and Mulund was established by Dr. Katkade and his team. Late Dr. Ambadekar sir, Dr. Dasgupta sir, and Dr. Devekar madam inaugurated the event. The mayor and commissioner of Thane also graced this occasion. In 2003, during the state conference held in Solapur, Professor Dr. Balasaheb Deshpande inspired and initiated the talk of Dr. Katkade and his team, holding a state conference in Thane. Due to logistical reasons during those times, state conference could not be held in Thane. This big dream is yet to be realized. In the following years, the members of Academic Society of Thane and Mulund increased, and finally in 2017, this organization was given the name of Indian Society of Anesthesiologists, Thane branch, under the presidential flagship of Dr. Katkade sir and Dr. Jayanti Bhate as the secretary. The event was installed by the Maharashtra State Chapter President Dr. Hitendra Mahajan sir in the attractive presence of Dr. Manisha Katekar madam and Dr. Divatia sir. After 2 years, the presidential reins were handed over to one of the pioneers, Dr. Godbole, followed by dynamic Dr. Meenal Gadgil, who's currently the president of Thane ISA. Ever since then, Thane ISA has continued to grow under the guidance of Dr. Katkade sir. Compression only life support coal's activities were flagged off in a big way in 2018 by the coal's coordinator Dr. Manisha Ghosh. Coal's activities were admired by Thane Police, Police Commissioner, Thane Mayor Mrs. Meenakshi Shinde, other political leaders, as well as social organizations like Lions and Rotary Club. During World Anesthesia Day celebration WAD last year, second prize was awarded to Thane ISA for Coles activities. Led by Dr. Katkade's inspiration, Dr. Ranjan Joshi composed Jeevan Sanjeevani's song depicting the steps of Coles, which received accolades at the national level. We have also organized street plays and marathon to bring about public awareness of our profession, and these events found a mention in the local newspapers. Annual cultural event called Narcotic Beats is the hallmark of Thane ISA. It brings out the enormous talent and enthusiasm of our members. In 2019, in the state conference, Thane ISNs also performed a drama by the name of Indradevaji Appendicectomy. Our talented artist, Dr. Manohar Bharne, received the first position in the virtual competition, and Dr. Parna Thakkar was awarded a third position in the live singing competition held at the National Conference ISACON at Ahmedabad in November 2021. ISA Thane has supported other medical organizations like IMA, AMC, and local gynac, surgical, and pediatric organizations. Our body has generously extended help to ISA families at the time of crisis. ISA member Dr. Katkade sir has donated a sum of 2 lakh rupees to the state ISA, and every year in the state conference, 2 prizes are sponsored by him. He was also instrumental in the release of e-bulletin by our team last year. Dr. Katkade sir is currently the Chief Medical Officer and the Director of Mavi Jain Hospital, Thane. He and his team, along with the Thane IASINs, played a pivotal role in providing treatment and care to the COVID-affected patients during the pandemic, and also extended their full support to the Thane Municipal Corporation during these difficult times. He and his team also provided relief to Kerala State and Kolhapur at the time of floods. The hard work of Thane ISA has paid off, and today we are holding the national CME. On this august occasion, in the presence of national and the state faculty, I announce that we will strive to make the long awaited dream of holding the state conference in Thane come true. May Almighty bless us. I sincerely thank one and all.
Thank you, Dr. Parna. That was a lovely film and it has made me emotional. I'm sure we will all fulfill that state conference dream of ours very soon. And I'm sure under the guidance of Katikar, Madam, she's also smiling that we will have that opportunity soon enough. Thank you very much, Parna. That was really, really lovely. We still have time for the bad film. So let's do it before we start the post-lunch session. Okay. I think it's exactly 1:45. We have a few seconds before 1:45 and we can start our post-lunch session. Sandeep? Thank you, madam, for being online. I hope you had some lunch. Dr. Meenal, shall we start with the post-lunch session? It is 1:45 and we are pretty much on schedule.
Yes,
Yeah.
please start.
Yes. Thank you. Thank you, Dr. Meenal. The most common anesthesia mishaps are related to the airway. The intubation and the extubation are the most critical events for an anesthesiologist. What's new in airway management? Learn from the expert, Dr. Jigishu Diwatiya sir. To moderate this session, we have our Vice President, Dr. Bhavesh Nanda. Dr. Bhavesh Nanda is a solid support of Thane ISA and has a special interest in obesity anesthesia and critical care management. Dr. Bhavesh Nanda.
Thank you, Manisha, for introducing me. Airway management is an essential, integral part of what every anesthesiologist do every day. And hence, everybody wants to master this skill. What better way to learn from the very best Dr. Jigushu Diwatiya? The next topic is what's new in airway management. Dr. Jigushu Diwatiya is a professor head, Department of Anesthesia, Critical Care and Pain, Tata Memorial Hospital. He's a past president, editor-in-chief, IJA, past president, Indian Critical Society of Medicine. Also, he's a past president of All India Difficult Airway Guidelines. He has over more than 165 publications in national and international journals and invited as a faculty member in all the conferences. I would also invite to chair this session Dr. Hitendra Mahajan. He is a consultant anesthesiologist at Ashoka Medicover Hospital, Nasik. He has been invited as a faculty in multiple conferences. He is a multifaceted personality involving in mountaineering, sports. He's a past president, Maharashtra chapter of Thane ISA. Over to Dr. Jigushu Diwatiya for this next topic. What's new in airway?
And thank you for inviting me to speak at this very prestigious CME to speak on what is new in airway management. This very wonderful systematic review which looked at 62 high-quality studies involving almost 34,000 patients, in whom 10% of patients were difficult to intubate. And what this review found was that of all the tests that have been done, the most important or the most predictive test for difficult intubation was this upper lip bite test. So if you are unable to bring your lower teeth to bite the upper lip, then this is highly predictive of difficult intubation with a specificity of close to 96%. Now, I found this very interesting because this test is not commonly performed. We perform many of the other tests, such as the Malampatti and the hyomental distance or the thyromental distance, but they are not as predictive. And this likelihood ratio should be more than 10 if this test is to be a good test of prediction. And it is only the upper lip bite test which actually has the best positive likelihood ratio. So this is a very important sort of test which we should probably incorporate in our practice. Now, we often talk of the full stomach, and we have these arbitrary time frames. 2 hours prior, you give liquids, and 6 hours prior, you should not have solid food. But how do we know whether the stomach is actually empty or not? And now gastric ultrasound is a very simple bedside tool which can be performed by almost anyone to help us determine whether the stomach is empty or not, and what is the type of food or what is the type of material which is present in the stomach in the patient at the bedside. So you put the probe in this position, as you can put it horizontal, vertically like this, in the supine and in the lateral position. The lateral position is even better with the patient in the left lateral position. And here under the left lobe of the liver, you can see the gastric antrum. Now, this is a fully collapsed gastric antrum, just a very small slit which you can see and tells you that the stomach is empty. This is a pancreas, superior mesenteric artery, and the aorta. So to get a sort of idea of the anatomy, right? Now, if you have this antrum, which is looking quite full, and you get this frosted glass pane appearance, this suggests that there is solid food in this recently ingested solid food. And if the solid food is broken down, then you get lots of this chunky material, these white shadows in the gastric antrum. And that suggests there is, again, there's solid gastric contents present in the antrum. This is a full gastric antrum, but this is full of liquid. So this is clear fluid which is present in the gastric antrum. And so you get some idea that this is liquid which is present in the clear liquid present in the antrum. And if there is gas, right, along a fizzy fluid which has been given, so you get gas bubbles, you get what you call as this starry night appearance of the gastric antrum. So by doing this ultrasound, you know what is the qualitatively whether the stomach is full or not, and what type of material is there in the stomach. You can also estimate the volume of gastric contents by various formulae and tables. This is one sort of formula which you see in the cross-sectional area of the stomach in the right lateral position using the formula called the Perler's formula. And you can also actually estimate the volume of gastric contents. And so by knowing what is the volume of contents and what is the type of gastric content, you can risk stratify your patient. So if it's empty, it's at low risk. If it's solid material, any amount of solid material, this is a high risk of aspiration. If there is clear fluid, then you could actually try and determine what is the volume. If it's less than 1.5 mils per kg, it could be low risk. And if it's more than 1.5 mils per kg, it suggests a high risk of gastric aspiration. So this is a nice, simple way in which you can actually measure the volume and the type of gastric contents and risk stratify a patient as far as the risk of aspiration is concerned. Now, very often, we have often been told that in a difficult airway, you must do an awake intubation. You should prepare for an awake intubation. But what sort of situation and when should we actually really seriously consider an awake intubation? And these are the Canadian guidelines which have been recently published, and they really help you make a decision in whether or not to go ahead with an awake tracheal intubation in a patient with an anticipated difficult airway. So if you've got a predicted difficult intubation, right, and let's say there is absolutely no chance of direct laryngoscopy or video laryngoscopy, for example, total trismus, right? So that is one indication that's clearly indicated. If there is some mouth opening, but there are other factors, which suggest that not just intubation, but even face mask ventilation or supraglottic airway insertion are going to be difficult, then again, you should consider awake intubation. So you predict a difficult airway from the laryngoscopy and intubation point of view, as well as face mask and supraglottic ventilation, then again, you need to consider an awake intubation, right? If these are not there, but there are physiological issues, for example, a very obese patient or someone or a very small child, right, who have a physiological, who are likely to desaturate very rapidly because of their physiological problems or pathophysiology that is there, right, then that patient may also need an awake intubation rather than paralysis and rather than induction of anesthesia with paralysis. And there might be a risk of aspiration. So if you have some or all of these factors, you can actually make a decision as to whether the patient should undergo an awake intubation. Of course, you need to take into account whether the patient is likely to be cooperative or not. And these sort of helps you in the decision making to consider awake tracheal intubation. Of course, awake tracheal intubation could be awake oral or nasal or tracheostomy, and it could be a fiber optic intubation, or it could even be a laryngoscopy that you do, a video laryngoscopy or a direct laryngoscopy. Now, how to go ahead and do an awake intubation? There's a beautiful set of guidelines which has been published in the Difficult Airway Society of UK, and it's present in the Anesthesia 2020 issue, and it tells you how to go ahead with a awake tracheal intubation. And they do emphasize that you should oxygenate throughout awake tracheal intubation, whether it's fiber optic or laryngoscopic. You must give oxygen, and they recommend high flow nasal oxygen, but you could even apply simple nasal prongs. Topical anesthesia is extremely important because that's the key to your success. Sedation is mentioned only if you require. Remember, if it's a really difficult airway, also with physiological problems, sedation might actually take away some of the advantages. Deep sedation might take away some of the advantages of an awake intubation. And they use remifentanil in the US, which we don't have. But, we could use dexmedetomidine or something like that. And then they tell you to perform it preferably with the patient sitting up, and either a fiber optic intubation or awake video laryngoscopy, right? So this is, they tell you how to do it, and perform, oxygenate, topicalize, sedate, and perform. And also some good hints on how to avoid and manage complications. So you must maintain a protect unobstructed airway at all times. And that's why the role of sedation is quite important. You don't want a patient obstructing because of deep sedation. So you should either reduce or reverse sedation, increase oxygen, of course. If the patient, remember, topicalization is the key to success. If your topical anesthesia is not good enough, then, you might have to give some more topical anesthesia, but always look out for local anesthetic toxicity and do not exceed a total dose of 9 milligram per kilo. Review sedation, consider reversal. And again, do not keep on trying to do, just because it's awake doesn't mean it's always safe. Don't keep on doing something all over again and again. Limit the number of attempts, abandon if required, use alternative devices, tubes, or even alternative person to do the awake intubation for you. Now, the whole problem of the difficult airway, or what we call as difficult, the consequences of difficult airway, hypoxia, hypotension, which lead to either brain damage or even death, arise because of the way we conduct anesthesia. We induce anesthesia, put the patient to sleep, and we create apnea by giving a muscle relaxant. And that is just to help facilitate laryngoscopy and intubation. And then we restore ventilation by face mask, and then, of course, by putting in a tube or a supraortic airway. Now, if we can't do any of these, then we call it as a difficult airway. And our focus has always been on this part here, which I call, or what we call, the anatomically difficult or the technically difficult airway. So the focus has been for many, many years on how to get better laryngoscopy, so better tools for laryngoscopy, better tubes for intubation, like stillets and bougies, supraortic airway devices, different types of supraortic airway devices to help overcome the technical difficulty in ventilating the lungs after apnea has been produced. But very often, patients desaturate even in a relatively simple airway because of the physiological condition or the pathophysiological condition of the patient, in which they desaturate very rapidly once you produce apnea, right? So, and that is what we call as a physiologically difficult airway. So these could be very obese patients, they pregnant patients, they could be critically ill patients undergoing emergency laparotomies or emergency surgery, could be small children. So they could all desaturate rapidly because of the physiological difficulty when they have a small functional residual capacity in their lung, or cardiovascular disease, or severe anemia, and the oxygen carrying capacity and oxygen consumption are much higher, and the oxygen carrying capacity in the lungs as well as blood is much lower, then they can desaturate extremely rapidly. And these are, so we have recognized the importance of the physiologically difficult airway as well. Now, our emphasis on overcoming this hypoxia is to increase the duration, the safe duration of apnea by pre-oxygenation. And this we've been doing for many, many years. But now more and more, we are now focusing on what we call as peri-intubation oxygenation, which means maintaining oxygenation throughout the duration, throughout the period of intubation. So that's pre-oxygenation, as well as after apnea has been produced while you're doing laryngoscopy and intubation. And this is what we call as apneic oxygenation. So you make sure you pre-oxygenate well. And even when the patient has become apneic and you're doing your procedures, you give apneic oxygenation. And the simplest way of giving apneic oxygenation is by a nasal cannula in the nose while you're doing your laryngoscopy and so on. And giving it at least 15 liters per minute. And this is called a no desat, so the nasal oxygen during attempts at intubation to prevent desaturation, right? So this is a simple technique which we can all use and we should use. A more refined and a more innovative technique has been described a few years back. And this is you insufflate nasal oxygen at a very high flow rate of 70 liters per minute, 100% oxygen, 70 liters per minute. And because it is going at such a high flow rate, right, it has to be an extremely efficient system for heating and humidification. And this apparatus is called this technique is called high flow nasal oxygen delivery. And this technique during paralyzed patient, for example, such as those undergoing anesthesia after neuromuscular paralysis, is called Thrive, right? So it has this humidifier, it's got a circuit which is also got a heating wire, so there's no loss of heat and humidity when the gas oxygen flows down this tube, the circuit. And there's this nice nasal cannula which is designed to fit nicely into the nose and deliver heated humidified oxygen at 70 liters per minute. And that is why this is called Thrive, that is transnasal humidified rapid insufflation ventilatory exchange. Now, it's not therefore just simple apneic oxygenation. Of course, there is apneic oxygenation, because you can see what happens here is when you give Thrive, the median duration of apnea is about 20 minutes. So you have 20 minutes of apnea where the saturation remains above 95%. So you are safe for 20 minutes of apnea. And the odd patient went to 30 minutes, 40 minutes, and even 60 minutes and higher, right? So you have a situation where you've produced apnea and you can maintain oxygen above 95% saturation for around 20 minutes on a median. Some are less, some are more, but on a sort of average, if you want to call it, about 20 minutes of apnea is produced, as opposed to the usual 8 to 9 minutes with pre-oxidation, right? Now, why is it called exchange? Because the rate of rise of CO2 is much less than what you get with standard apneic oxygen, which means that you see the rate of rise of PCO is only about 1 millimeter of mercury per minute. With our standard apneic oxygenation, it's 3 to 6 millimeters of mercury per minute. That means there is some CO2 exchange which is taking place because of this high flow rate. We won't go into all the mechanisms, but there is some ventilatory exchange happening. So the CO2 rises, but not as rapidly. And therefore, Thrive is an extremely good method of maintaining oxygenation saturation after apnea. And can you imagine if you had 15 to 20 minutes to comfortably have the oxygen saturation above 90% during attempts at intubation? You know, this whole terror and the panic of not being able to see the cords, of not being able to do a laryngoscopy, of having to put in a supraortic airway a couple of times, do a couple of intubations, worried that the oxygen saturation will drop and the patient will become hypoxic, all that is gone, right? Because you've got 15 to 20 minutes. So from a hurried stop-start, potentially traumatic undertaking, to a smooth event with an extended safe apneic window. So Thrive has the potential to change the nature of apneic oxygenation during intubation after induction of anesthesia and neuromuscular blockade. And therefore, our All India Difficult Airway guidelines insist on apneic oxygenation at least with high flow nasal oxygen, or if you have Thrive, then you should use Thrive, right? Whenever you do intubation, right? So you should make it a part of your routine to have peri-intubation oxygenation rather than pre-oxygenation alone. Now, what happens? Why do patients have complications and die during a failed airway? So what do we mean by a failed airway? You've paralyzed the patient, and then you are not able to do face mask ventilation. You're not able to get a tube into the trachea, and you are not able to ventilate via supraortic airway, right? So all your methods of potentially getting to ventilate the lungs have failed, and therefore there is failure to ventilate the lungs. And failure to oxygenate follows a failure to ventilate. So the first event that happens is you're unable to ventilate the lungs by any of these methods available to you. And then you get failure to ventilate the lungs, and then you fail to oxygenate, and that leads to hypoxia, which leads to death or brain damage. So the main thing is failure to ventilate the lungs. So now the question is, suppose all this has happened, when should you move to an emergency surgical airway? Should you do it as soon as you recognize it in a situation where the patient is likely to suffer hypoxia? That's when you're unable to ventilate the lungs by any of these. So when all these fail, at that point, should you consider emergency surgical airway access, or should you do it when oxygenation has failed? That means the saturation started falling. Now this, some people might say too early, but this is definitely probably too late, because once the saturation starts falling, it falls extremely rapidly, and then you have very little time to do it. And this is a sort of relatively earlier time point in which to do it. So in our guidelines, we do not define cannot intubate, cannot oxygenate, which is a very popular term coined with the difficult airway society. We do not say cannot intubate, cannot oxygenate, because we call it a complete ventilation failure. Why? Because it's ventilation failure, not just intubation, but failure to intubate or failure to oxygenate, failure to supraortic airway device, and failure by face mask ventilation. And ventilation failure occurs before oxygenation failure, and therefore do not wait for severe hypoxia before you move to a surgical technique, right? So once you have failed intubation, supraortic airway, and rescue face mask intubation, you call it complete ventilation failure, call for additional help. And complete ventilation failure, again, like I mentioned, is a situation where intubation, ventilation using supraortic airway device, and face mask have all failed, despite the best attempts, even though the oxygen may yet be maintained at that point in time. So we recommend proceeding to emergency cricothyrotomy when there is complete ventilation failure. When you identified complete ventilation failure, oxygenation is maintained, and not only when hypoxia sets in. So don't wait for hypoxia. Do it as soon as you recognize complete ventilation failure. Call for additional help, because that a new person will come and he'll be able to have a fresh mind, a fresh thought, and his hands are not shaking and trembling like yours when you are in a situation of complete ventilation failure. And we recommend that you use any of the following techniques of surgical cricothyrotomy: wide bore cannular cricothyrotomy or needle cricothyrotomy. Although the current guidelines of the Difficult Airway Society and others are moving towards a surgical cricothyrotomy using the knife, bougie, tube technique. Now let's talk about rapid sequence intubation. That's used in patients with a potentially full stomach with a risk of aspiration. And it's a technique that minimizes the time lost between loss of airway reflexes with induction of anesthesia and the introduction of a cuff tube into the trachea. And that minimizes the time period during which gastric aspiration of gastric contents can occur. So classically, pre-oxygenation in the past, a defascinating dose of a non-depolarizing relaxant. Then you give a rapid induction of thiopentone followed by scoline immediately, right? So that you get loss of consciousness and muscle relaxation coming in at the same time, right? And you give cricoid pressure once the patient loses consciousness, and then you don't give IPPV during the period of apnea. Quickly put in the tube once the jaw and the respiratory muscles are relaxed, and put the tube, inflate the cuff, and then release cricoid pressure. That's a very sort of dynamic technique, and rapid injections of drugs with very little time to assess. And cricoid pressure has been a very important part of this. And there has been a lot of controversy about cricoid pressure. People say, well, it's not very effective. People don't know how to use it. It makes intubation difficult. And there was this trial, a large randomized controlled trial, which compared cricoid pressure with a sham procedure, and they failed to demonstrate any difference between the two techniques, right? So, and cricoid pressure had inferior views. So therefore, there is again more doubt on the exact role of cricoid pressure. So in current practice of rapid sequence intubation, we don't make it a push in, zoom technique. We give relaxation, give induction agent, titrate to loss of consciousness, and then give a neuromuscular block, right? We don't use defasciculate. We straight away, by and large, use a rocuronium. Of course, we can use saxavetonium if we want to, right? Gentle IPPV during the period of apnea till relaxation is obtained is permitted, and in fact, sometimes encouraged. Cricoid pressure should be given, but if it's not, if it interferes with laryngoscopy, remove it, right? And so our guidelines, and for example, the obstetric guidelines of the All India Difficult Airway Association recommends mask ventilation with a pressure less than 20 centimeters of water during the period of apnea, so gentle IPPV. And if mask ventilation inadequate or the laryngoscopy is difficult, release the cricoid pressure. So that's what we are recommending in rapid sequence intubation. Finally, in 2022, we are still discussing the undiagnosed esophageal intubation. Now, capnography is a standard of care to confirm tracheal intubation. Even our guidelines recommend that you should use capnography to confirm tracheal intubation. Now, there have been a number of cases which have happened over the past few years, including recently in the last 1 or 2 years in the UK and Australia, where capnography was used, but in spite of that, the esophageal intubation went undiagnosed. People they saw a flat trace, they thought it was because of cardiac arrest. They saw a flat trace, they thought it's because of anaphylaxis leading to cardiac arrest. In other words, even though the capnograph was there were, in one of the cases, they did not look at the capnograph, and they sort of looked at the capnograph only when the patient had a cardiac arrest, which was clearly because of hypoxia, because of esophageal intubation. Therefore, there's this campaign to use capnography better and to prevent disasters in spite of using capnography. And this is called no trace, wrong place. So if you don't have a trace in the capnograph, it means the tube is not in the trachea, right? Unless proved otherwise. There are some rare exceptions where you could get a tube in the trachea, but you not have a trace. But that's a very exception. And one of the exceptions is cardiac arrest, right? Is thought to be cardiac arrest. So this is a normal trace, and very clearly this means, a nice big CO2 rectangular waveform suggests it's the right place. This is a flat trace. There is no trace. This is esophageal intubation. Many people argue that during cardiac arrest, because there is no cardiac output, you will also get a flat trace. But if you're giving chest compressions, you will get some CO2. Remember, end tidal CO2 of 12 is an indicator of effective chest compression. So you will get CO2 if you're giving chest compression and your tube is in the trachea. So even during cardiac arrest, you should see an attenuated, but there will be a trace, right? So a cardiac arrest, a flat trace, most often is because the tube is not in the trachea. And you can get an attenuated trace like this. And here you need to maybe have some way of checking again whether the tube is in the trachea or not. And if you don't think so, you could even take the tube out, especially intubation was easy. It happens, easy intubation, but you put it in the esophagus. Easy laryngoscopy, you put it in the esophagus. So it can happen. So you can then sort of do something to check the position of the tube. But please remember, when you don't see a trace on the capnograph, the first thing that should come to mind is it's in the esophagus. Make sure it's not in the esophagus, and then do whatever you have to do, right? There are, like I said, rare instances where it is in the trachea, but there is no trace, and that could be because of a problem with the capnograph. It could be cardiac arrest and you're not giving CPR, right? Or a massive leak where no CO2 is coming back, everything is going out of the leak, right? Whether it's bronchopull fistula or whatever it may be. Sometimes it could be in the wrong place, means say just above the larynx. So you're getting some CO2 coming in. So you'll get a trace even though it's in the wrong place. So, and a common situation, again, common means one of the situations you can get a tube which is outside the larynx, but during CPR, you're getting some CO2 coming out. So this is the commonest, the frequency, and these are all extremely rare sort of occurrences. So no trace, wrong place, unless proved otherwise. And why do all these disasters occur in spite of having such equipment and following protocol or whatever? It's cognitive errors, right? Human factors. Technical errors account for a small fraction of diagnosis, incorrect diagnosis and treatments. Mistakes in thinking. They just don't think that the tube could be in the esophagus. You think of all other causes like anaphylaxis, cardiac arrest, and so on. And the real problem is we have to understand the psychology of decision making and what causes these errors. And they have been shown to be present in a large proportion of cases where disasters have occurred. So human factors, right, and poor judgment and inadequate teamwork. These are things which sort of lead to airway disasters. So we have to improve. Of course, we have to improve our training, our skills, and know the guidelines, but teamwork. And that people say, oh, in a private nursing home, I'm the only person. What teamwork? No, you're a team because the surgeon is around, your nurses are around, there's a favorite ward boy who does all your stuff with you, isn't it? Gives you all the equipment and knows everything about the OT. So that's all part of your team. It could be some colleague who could come in from the next theater, right? So that's all teamwork, decision-making, communication, culture of safety. That's what we have to focus on, in spite of knowing everything and in spite of having all the tools that you would like to have. So thank you very much for listening. Take care and stay safe.
Thank you, sir, very much for this informative topic. Sir, there is one question from the chat box. Dr. Sinjini Agarwal has asked, what should we do in case of complete ventilation failure when there is no help, no facility for securing surgical airway like in a casualty intubation?
So I think that's a very important and a very good question. And I think the only answer is, and every anesthetist, every anesthesiologist must be able to perform a surgical airway. And so whether it's a needle cricothyrotomy or what is now being advocated is a knife, bougie, and tube. So technique. So you must be able to do it by yourself. And you're very right. Why casualty? Even in say OT, let's say you're in a gynec theater with a cesarean section. You only got gynecologists around you, right? They can do an episiotomy in half a minute, but they can't do a cricothyrotomy for you. So you have to be able to do this for yourself. And the only way to do it is by training, taking part in workshops. Unfortunately, in this sort of era, we've not been able to do physical hands-on workshops, but there have been many which were done before, and there will be many in the future, whether they're animal labs or whether they are dummies, mannequins. We have to get ourselves trained. And it is also unfortunate that cricothyrotomy is not a technique which you can just say, no, chal aaj ek cricothyrotomy kar dete hain, or something like that. You can do a video laryngoscopy that way or a fiber optic that way, but not a cricothyrotomy. So we have to train and we have to do it in all these workshops. And I would encourage everyone to take every opportunity when these workshops start. Because it's very glamorous to take part in other workshops, but please go to a workshop where there is a surgical airway on the menu. Right? So you must take part in these sort of things. And even if you don't know, there are kits which are available, but again, you have to be useful. You have to be used to these kits and you have to practice on them. So the only way out is practice at workshops and seminars and stuff like that.
Yeah. Thank you very much, sir. Dr. Hitendra Majan, would you like to add something to this session, sir?
Yeah, as sir has rightly pointed out, airway is something which we have so many things in our armament, and still many times we are not. 10% is a huge figure worldwide where we are not able to intubate in spite of having so much of algorithms, so much of weapons in our armament. So what I feel is most of the time when we are taken aback, like when it comes all of a sudden in front of us, and what I feel is every anesthesiologist before taking a case, he should play a chess. Like he should be 2 to 3 steps ahead in his thought process. If at all I'm not able to ventilate, what I'll be doing, my first thing, second thing, third thing, and if at all I'm not able to oxygenate, what should be my steps 1, 2, 3. So just give it a thought for 5 seconds before touching that patient, that if I'll end up in a situation, what I'll be doing, and it will make a tremendous difference. It will make you less shaking, it will make you less trembling, and it will make you act swiftly, if at all, though the chances is 1 in 1,000. But then it will make your movements soft and smooth, and you will be able to have a high success rate. That's what I feel like.
Dr. Divatia sir, there is also one more question, whether the Thrive or FHNO will work in a situation where there is a doubtful airway patency?
Excellent question. And so again, for the air to high flow oxygen to reach the alveoli, you have to have a
yes,
patent.
sir.
You have to have a patent airway. So when you're using it for pre-oxygenation or during intubation, you must keep the airway patent either by a jaw thrust or even a nasal airway or something. So the airway must be patent. So that's a great question. The other thing I'd also like to stress is that, let's say you started off a case in a usual way with nothing attached at all. You just do, and then you find you're not able to ventilate properly and you're not able to intubate. At that stage, to introduce Thrive, it's less effective. So the Thrive must be put in from the beginning, or at least in a nasal cannula, ordinary nasal cannula should be put in from the beginning when your lungs are at full capacity and are able to take up the oxygen. Once you start running into trouble, and there is partial airway obstruction because of laryngospasm or bleeding or something, and then the lungs are already desaturating, the FRC is reduced because you'll not be able to ventilate the lungs enough. At that point, introducing Thrive or any other technique is much, much less effective. So like Dr. Majan said, what does it cost you to put a small nasal cannula and give it 15 liters per minute right from the beginning? It doesn't. Thrive you can maybe reserve because it's expensive. It's still costs about 5,000 per circuit. Hopefully the company will bring the price down, but even if you reuse the circuits or something like that, it's still reasonably expensive. So you can still use it for obese patients and patients who have some difficult features and so on. And the third thing I'd like to say is, like Dr. Majan said, that we play that game of chess. And I think we don't do this, but we must do very often ask ourselves, is awake intubation safer for this patient? Very often we lose patients out of bravado. Arey kuch nahi yaar, theek hai, dal deta hai, aisa hi ho jayega, and sometimes wo ho jayega becomes nahi ho sakta hai, or nahi ho raha hai. And so we must just be prepared for all eventualities, including the possibility of whether a awake intubation might in fact be safer for this patient, right? So I don't think you should accept awake intubation as admission of defeat or admission of anything, but or awake tracheostomy in rare instances should not be taken as admission of as a feeling of incompetence or defeat, but in fact as something which is safer for the patient. So these are just various ways of sort of approaching this problem of the difficult airway, right from the beginning.
One thing which I would like to add regarding THAIU is in the beginning when it was projected in the conferences, like it was like a absolutely lifesaver and you should not worry, just put it and there will be a good oxygenation and good what sir has rightly pointed out is it is very important when you are going to use it, when you are going to put it to the patient. Once the lung is desaturated, deoxygenated and putting it that time we may not get like 20 minutes of apnea and you can do anything you can call. No, it doesn't work like that. So what I feel is regarding THAI also, what message is going to everyone, those who don't have specially or those who have not used it, like it is something which is the ultimate weapon, like you can have, it's not like that as sir has correctly pointed out.
So I entirely agree, and every weapon has to be used correctly. Otherwise, you can even shoot yourself. So I think you have to use it correctly. Make sure the airway is patent. Start it from the beginning. And when you're doing an induction or in other patients, especially obese patients, give a slight head up position. So your FRC is slightly increased. So all these things actually go on to getting a good amount of time out of thrive. Otherwise, sometimes the patient, you have a fat patient who is lying flat or a little head low, the airway is obstructed in induction, and then you thrive का कुछ फायदा नहीं होगा. So not pay attention to this.
Thank you very much, sir, for this excellent presentation. And the take-home messages is to have a peri-intubation oxygenation, diagnose complete mechanical ventilation failure before the hypoxia sets in, and always confirm with the capnograph about the proper intubation. I would take this opportunity to invite Dr. Hitendra Mahajan to thank Dr. Diwatiya with a floral bouquet.
Yeah, I'm thankful to Diwatiya sir.
And on behalf of Thane ISA, I would like to give a floral bouquet to Dr. Hitendra Mahajan. Thank you very much, sir.
Thank you.
Manisha, you can take over.
Yeah. Thank you, Dr. Diwatiya sir, Dr. Hitendra Mahajan, and Dr. Bhavesh for that very, very informative talk. I faced a situation yesterday and I remembered all this, and that was good. So moving ahead, on every highway in India, we will see the sign. Hospital ceilings are boring. Drive carefully. How true is that? Hence, the focus now is on early recovery and early discharge. ERAS. This trending topic is brought to you by Dr. Madhuri Kurdi. The moderator for this session was to be our young anesthetist, Dr. Vineet Jadhav, but he is down with COVID and not able to be here with us today. So our COLS coordinator, Dr. Shweta Patil, who's a freelance anesthesiologist, has agreed to very gracefully step in, and she will be moderating this session. Dr. Shweta Patil.
Thank you, Dr. Manisha, and I wish Dr. Vineet a speedy recovery. It is my privilege to invite Dr. Madhuri Kurdi ma'am. She is the professor and head of Department of Anesthesiology, Karnataka Institute of Medical Sciences, Hubli, Karnataka. She has many interesting articles under her name, national and international, and has had an article almost every month last year in IJA. She was awarded the ISA IJA Best Peer Reviewer Award for 2016-17. And she also has a book on Amazon by the title Peer Reviewing and Me. Welcome, madam. And to chair the session, may I respectfully invite Dr. H.K. Saleh sir. Sir is the President-elect Maharashtra State Chapter ISA. Sir is the Director of Department of Anesthesiology and Executive Director, Noble Hospital, Pune. He is the Vice President of Associate of Medical Consultants and past president of Pune Society of Anesthesiologists. Over to you, Madhuri ma'am.
Good afternoon, respected chairpersons and dear delegates. At the outset, I would like to thank the president of ISA Thane City branch, Dr. Meenal Gadgil, the secretary, Dr. Manisha Ghosh, the entire organizing committee of this CME, ISA National Sponsored CME, and all the office bearers and all the members of ISA Thane City branch and Maharashtra State branch for giving me a chance to present this talk on ERAS, myth or reality. I bring you warm greetings from my institute, Karnataka Institute of Medical Sciences, Hubli. Now, first of all, what is ERAS? ERAS is a multimodal, multidisciplinary, perioperative care designed to achieve early recovery of patients undergoing major surgery. Now, the concept of ERAS was initiated by Professor Henrik Kellet from Denmark in 1997 for major abdominal surgeries. And from then on, the concept of ERAS has progressed, and today we have well-established ERAS protocols in colorectal, vascular, thoracic, and urological and even cardiac surgeries. Now, there was something called as an ERAS society, and it evolved from the ERAS study group. And what was this ERAS study group? It comprised of leading surgical groups. And this was assembled by two professors from Sweden in 2001 to develop ideas related to ERAS. So the first ERAS symposium was held in 2003, and the first consensus guidelines for ERAS were published in 2005. And all these guidelines were based on evidence obtained from colorectal surgeries. So ERAS guidelines were first published for colorectal surgeries. So see this timeline starting from 1995, where there was the initial description of fast track surgery was made. So ERAS was initially known as fast track surgery. In 2000, the ERAS study group was formed. 2005, the first ERAS protocol for colorectal surgery was published. 2010, the ERAS Society was founded, and protocols for colorectal pancreaticoduodenectomy were released. 2015, gastric resection protocols were published, and protocol for cystectomy was published. And then from then on, several protocols have been released for breast reconstruction, bariatric surgery, liver surgery, head and neck cancer surgery, and so on. See this is a consensus review of optimal perioperative care in colorectal surgery, which was published in around 2009. The updated review was last published in 2019 by Gustafsson, and this was related to elective colorectal surgery. So the ERAS Society guidelines, they keep on getting published quite frequently, and newer and newer guidelines are getting published every year. Now, let us come to the basic thing, that is, why to use ERAS? What is the need for implementing ERAS? Can we not go ahead with whatever whatever routine guidelines we are following for surgery? Is that not enough? Why should you use ERAS? Well, numerous research reports have shown that if you employ ERAS, if you compare it with traditional care, there are marked effects on the recovery. So what are those marked effects? The first is recovery time is decreased and complication rate is reduced by 30% or more. So you can see over here, this is the enhanced recovery and this is the traditional recovery. Look at this. So the recovery time and complications are reduced by 30% or more. So ERAS is said to reduce the length of stay in hospital. It reduces medical complications following surgery, And because of all this, it reduces the mortality, perioperative mortality, and that means it improves the post-operative outcomes. So that is what we want, isn't it? We want good post-operative outcomes after surgery. That is our main goal always. So what are the main pillars of ERAS? There are 3 pillars. First is the evidence-based perioperative care processes. Second is the multimodal and multi-professional teamwork. And the third is continuous audit. So the aims of ERAS include avoid iatrogenic problems such as post-operative IVS, minimize the stress response to surgery, speed recovery and return to normal function, early recognition of abnormal recovery and intervention if necessary, and optimize preoperative patient for surgery. So these are all the various aims of ERAS, which you should know. Now, what are the key components of any ERAS protocol? We have something called as an ERAS pathway. And in this ERAS pathway, you have several steps which you have to follow. So the various components of an ERAS protocol include preoperative or pre-hospital component, the intraoperative component, post-operative part, post-discharge part, and the audit compliance. So if you see the pre-hospital phase, what is included in the ERAS protocol in the pre-hospital phase? One is the patient or family education. Pain management plans are important pre-op, patient optimization, and prehabilitation of some patients. Then comes the pre-operative phase where you have to take care of the fasting, where you have to limit the fasting light meal up to 6 hours preoperatively. Then you have to give carbohydrate beverage up to 2 hours preoperatively, initiate multimodal medications and or regional block placement, and discharge planning. Intraoperative phase, opioid sparing multimodal analgesia, normovolemia, normothermia, normoglycemia, avoid tubes and drains. Post-operative phase is again early nutrition, early mobilization, multimodal analgesia, nausea, vomiting management, patient and family education. And post-discharge phase is monitor for symptoms or changes in health to seek assistance, follow up with the surgeon or the primary care physician, and continue therapy and other interprofessional activities. So I just told you in brief about the various steps of the ERAS protocol. Now, you must have observed that all these steps, whatever steps I told you in the ERAS protocol, all this cannot be done by a single person. It is not that the anesthetist is involved in all these steps. Neither it is that the surgeon can do all these steps. Basically, the ERAS pathway has to be followed by a team. So it is nothing but teamwork. It is multi-professional teamwork. So in the ERAS protocol, who is involved? The anesthesia team, the surgeons, the nursing team, the medical team, that is physicians. All these people are involved. And this teamwork, it happens in the operating theater, during the surgical procedure, and during both pre and post-operative care. So if you see this flow chart of ERAS, I have already told you about the various steps. So the surgeon, the anesthesiologist, and the nursing staff are involved in the ERAS protocol. So now the anesthesiologist, where is he involved? Mainly in the he is involved in every major step of the ERAS pathway. Now in pre-admission phase, medical optimization, here again the anesthesiologist is involved. Then comes the preoperative phase. I'll be explaining it to you in detail shortly, but the anesthesiologist has to take care of the fasting, the postoperative nausea vomiting prophylaxis, and the preoperative administration of carbohydrates. Intraoperative phase, he has to manage the anesthesiologist, and of course the postoperative phase. So now we'll see in details. So that means the anesthesiologist is the cornerstone of fast track and ERAS program. I attended a multidisciplinary seminar on ERAS, and there the surgeons were saying that the surgeon is the cornerstone of fast track and the ERAS program. But I say that the anesthesiologist is the cornerstone of the ERAS program. So the anesthesiologist's role is important at almost every step of ERAS. I have already told you that. In the preoperative phase, it is involved, the anesthetist is involved in risk stratification, medical optimization, rehabilitation, determining the fasting guidelines, in giving postoperative nausea vomiting prophylaxis, deep vein thrombosis prophylaxis, and carbohydrate administration. Now, intraoperatively, the anesthetist has to give opioid-free anesthesia, regional anesthesia, glycemic control. He has to give goal-directed fluid therapy, and he has to reduce the stress response. Post-operatively, multimodal analgesia, early mobilization, and early oral intake. In all these steps, the anesthesiologist is involved. Now, coming to the preoperative risk stratification, which I told you has to be done in the ERAS protocol. Why is it important? If you grade the risk of the patient preoperatively, you know what are you can predict the post-operative outcome or the post-operative mortality and morbidity. So if you grade the risk of the patient preoperatively, you know your grade of care will vary accordingly. So if it is a high-risk patient, a senior anesthesiologist and a senior surgeon will operate, and you will keep the intensive care unit facilities ready post-operatively. And your plan will, you have to make your plans according to the degree of risk predicted by your risk stratification model. So for risk stat, and if you plan your anesthesia technique and surgery properly, then definitely your patient outcomes are going to improve and the patient is going to recover earlier. So to stratify the risk, you can use our our evergreen ASA, American Society of Anesthesiologists classification of physical status. Then for colorectal surgery, see, colorectal surgery, ERAS is implemented very commonly in colorectal surgeries. So there you can use this CR POSSUM, that is, it is physiological operative severity score for the enumeration of mortality and morbidity score. This can be used for colorectal surgery. Now, for emergency surgeries, you can do goal-directed preoperative optimization by targeted IV fluid resuscitation. Keep CVP between 8 to 12 centimeters of water, mean arterial pressure 65 millimeters, and urine output about 0.5 ml per kg per hour, and give appropriate antibiotics. Now, medical optimization of this patient who is to be taken up for ERAS. You have to correct the anemia. You know, anemia is very common in colorectal surgeries and in it's a very common thing in India. And even mild preoperative anemia enhances 30-day non-cardiac morbidity mortality risk index. So you should remember this. Anemia can lead to increased hospital-acquired infection, increased duration of hospitalization, renal impairment, higher risk of thrombosis. So anemia is definitely not good for ERAS, and you have to optimize the anemia. How you will do it? You can do it with preoperative supplements of vitamin B12, iron, erythropoietin, and if needed, blood transfusion can be given, but you should know what are the risks associated with blood transfusion. Then comes prehabilitation. After you have optimized the patient, now this concept of prehabilitation has come up, and several people have been delivering lectures on this prehabilitation. So what is prehabilitation? It is a process of enhancing individual functional capacity by corrective exercise programming meant to reduce the risk of indirect contact, musculoskeletal or overuse injury, and to provide strength, stability, balance, and mobility in preparation for a major surgery. So you can do in prehabilitation, the most important thing is you have to make the patient do exercises to improve his musculoskeletal strength. Then you have to educate the patient, both you have to give him a mental support, give him good advice regarding his perioperative course and boost him up, boost his morale. Then that's what psychological preparation, I already told you. Exercise training is very important. You teach him about spirometry exercises, and I told you, you make him do musculoskeletal stretch exercises. Stop smoking. Nutritional optimization. Then alcohol consumption has to be stopped because you know that alcohol consumption, it increases threefold the postoperative morbidity because of cardiopulmonary complications, bleeding, and wound infections. So the patient has to observe abstinence from alcohol for 1 month before surgery, and this will definitely reduce the postoperative morbidity after colorectal surgery. Smoking, this also has to be stopped because otherwise it will increase the postoperative morbidity because of cardiopulmonary complications and wound infections. So you have to stop smoking at least 4 weeks before surgery. Then in rehabilitation, you also have to improve the nutritional status of the patient. Nutrition is an independent risk factor for postoperative complications, suture dehiscence, respiratory infection, increased hospital stay and cost, and increased mortality. So what you have to do is you have to improve the nutrition of the patient. Otherwise, the mortality is going to increase. So the ESPEN, that is the European Society of Parenteral and Enteral Nutrition, defines severe nutritional risk patient as a patient who has lost weight more than 10% in the 6 months, if the body mass index is less than 18.5 kg per meter cube, and if the serum albumin is less than 3. So you have to give preoperative nutrition in all malnourished patients, cancer patients scheduled for gastrointestinal surgery, and to improve the outcome in thoracoabdominal surgeries. So nutrition you can give in the form of immunonutrition, which supplies high levels of arginine, glutamine, nucleotides, and omega-3 fatty acids. And a short course of nutrition can improve the physiological function also. And but they say that preoperative nutrition increases the pre-op hospitalization and cost. So that point also you have to remember. So they say that if the nutritional status is insufficient, and in such a state, if the patient is subjected to surgical trauma, then what happens? Insulin resistance develops, leading to hyperglycemia and increase in the morbidity and mortality. Surgical trauma in a poorly nourished patient again leads to increased oxidative stress, leading to organ dysfunction. And again, this leads to bacterial translocation from the gut because of the intestinal barrier being disrupted. And this leads again to morbidity and mortality and increased length of stay in hospital. The next important part in the preoperative ERAS protocol is the thromboprophylaxis. So you have to give thromboprophylaxis in those at risk of venous thromboembolism. They should be advised to consider stopping hormonal replacement therapy or consider alternative preparations before surgery. Now, the prophylaxis can be in the form of mechanical thromboprophylaxis, including compression stockings or intermittent pneumatic compression. Pharmacological includes low molecular weight heparin and unfractionated heparin. Low molecular weight heparin is a standard prophylactic agent based on multiple high-quality randomized control trials. And duration for prophylaxis should be around 28 to 35 days for patients undergoing major abdominal pelvic cancer surgeries, hip or knee arthroplasties. And the use of DVT prophylaxis has reduced incidence of perioperative DVT from 0.8% to 0% in ERAS patient population. There is evidence for this. Now, coming to the next step of ERAS preoperative, reduce preoperative fasting. Now, the standard practice of overnight fasting, nil by mouth since 10 p.m. Of course, now we no longer follow this because we have got the new ISA fasting guidelines. But if the patient fasts overnight, what happens is you feel that there will be a risk of pulmonary aspiration and stomach contents, the volume will reduce and all. But there are various drawbacks of this method. What happens is fasting leads to dehydration, hypotension, and then what happens? You give IV fluid infusion, that leads to overloading. And again, that is not good for the patient. Okay. So can we change this metabolism? Yes. You can do this by giving a carbohydrate load to the patient before surgery. You give him a carbohydrate drink 2 hours before surgery. What are the advantages of this? It reduces postoperative nitrogen and protein loss, decreases insulin resistance, reduces pre-op thirst, hunger, and anxiety, and helps to maintain lean body mass and muscle strength. So here is an evidence, that if you can modulate post-operative insulin resistance by pre-operative carbohydrate loading. But there are some drawbacks of this. Like in an RCT, including 94 patients undergoing laparoscopic cholecystectomy, carbohydrate loading did not have any benefits, and use in diabetics has not been well studied, and research is going on this particular topic. So a lot of studies are going on, and they are being published in various, these studies are being published in various journals. So the recommendation for carbohydrate is that you can give 400 ml of a clear carbohydrate drink 2 hours before anesthesia and 800 ml evening before. You can give IV 20% glucose also. So what is that clear carbohydrate drink? It is fruit juice without pulp, carbonated beverages, flavored coffee or iced tea. All these can be given. Even you can give oral rehydration solution. What is the safety of this? You must be thinking, is it safe? Now she's telling you give fluid 2 hours before, but is it safe? Well, it is said to reduce post-operative insulin resistance. And believe me, this carbohydrate fluid, if you give 2 hours before, it does not increase the gastric volume, and it is not going to increase the risk of aspiration. So in our institute, we have done studies where we have given this carbohydrate drink to the patient, 400 ml, 2 hours before, and then we have taken the patient for gastric ultrasound, and we have found that there is no residual, there is no increase in the gastric residual volume, and it is quite safe. Okay. So the next point is nausea vomiting prophylaxis. You have to take that also. You have to do it preoperatively. And because you know PONV is the biggest foe, and if the patient starts vomiting, then you definitely cannot say that the patient has recovered well, and it is going to delay his or her recovery. So you know that patients will have several risk factors for PONV, that female sex and history of motion sickness and long duration surgery, use of nitrous oxide and so on. So if any of these risk factors are there, you know, you can apply this APFIL score. It's a very popular score to predict post-operative nausea vomiting. So depending upon the APFIL score, you can devise your strategies to reduce risk of PONV. Try to avoid general anesthesia, use regional, use of propofol because it has got antiemetic action, avoid nitrous oxide, volatile anesthetics, minimize opioids, and adequate hydration. Now coming to the intraoperative anesthetic protocols, try to use short-acting anesthetic agents to allow rapid awakening. Ventilation strategy should be such as to avoid post-operative pulmonary complications. Use tidal volumes 5 to 7 ml per kg with PEEP of 4 to 6 centimeters of water. Intraoperative, use short-acting induction agents like propofol, short-acting opioids like fentanyl, alfentanil, short-acting muscle relaxants, use a neuromuscular monitor, titrate drug to effect, short-acting inhalational anesthetics, sevoflurane, use TCI pumps for TIVA, and try to use a BIS monitor so you can titrate your dose of anesthetics. Preemptive analgesia is very important, you can give it. And we should try to give opioid-free multimodal analgesia. So you know that opioids, they cause havoc with the patient. They're known to cause vomiting and ileus, and they cause constipation, sedation, delirium, and all these make the patient miserable, and they delay his or her recovery. So you have to avoid opioids. So you can use non-opioid pain agents like acetaminophen or paracetamol, intravenous infusion of local anesthesia, local wound infiltration anesthesia. You can use ketamine, magnesium sulfate, clonidine, dexmedetomidine, glucocorticoids, gabapentin, beta blockers, and so on. So I read this article, Achieving Opioid-Free Major Colorectal Surgery, the very recent article published in 2020. It says, achieving opioid-free major colorectal, achieving opioid-free major colorectal surgery. Is it possible? Well, the study concluded that it is possible. Opioid-free analgesia is possible in major colorectal surgery. And let me tell you that it is not only in major colorectal surgery, but there are several studies, even systematic reviews and meta-analysis published on this particular topic of opioid-free anesthesia, and especially in breast surgery, and it can be achieved. So the opioid-free pain management, it includes the preoperative period, paracetamol, NSAID, gabapentinoids, intraoperative regional anesthesia and analgesia. Postoperative period, continue the regional analgesia technique. Now, epidural anesthesia or analgesia can be used intraoperatively. If it is colorectal surgery, you're going for a thoracic epidural, but there should not be any other contraindications like coagulopathy and so on. So because of epidural, there will be reduced post-op insulin resistance, stress response will be reduced. See, stress response is a major culprit during surgery. During major surgery, it is the stress response which leads to problems. Because of this only the recovery of the patient is delayed. So if you can kill the stress response, if you can attenuate it, then the patient's recovery is definitely going to improve. Then epidural reduces chances of DVT, reduces blood loss, and reduces hospital stay. Then what is the role of nerve blocks? Well, nerve blocks play a major role in ERAS. Try to use as many nerve blocks as much as possible nerve blocks during ERAS protocol, because by using nerve blocks, you're avoiding opioids and your patient's recovery is going to be very, very fast. So this is a recent editorial in the Indian Journal of Anesthesia, which states, which talks about neural blocks at the hem of a paradigm shift in enhanced recovery after surgery. Then goal-directed fluid therapy is one more very important step in the intraoperative protocol, and it has been shown to reduce complications and length of stay using non-invasive or invasive monitoring of varying cardiac function parameters, depending on the monitoring platform. And evidence suggests that goal-directed fluid therapy results in better patient outcomes compared to the standard fluid management. A recent meta-analysis of 2,099 patients undergoing elective colorectal surgeries showed that goal-directed fluid therapy in ERAS was associated with significant reduction in length of ICU stay, but there was no difference in mortality. Then one more step of ERAS intraop is you have to maintain the patient's body temperature. Intraoperative normothermia is another important element of ERAS, because if the body temperature comes down and the patient starts shivering to meet the oxygen demand, then this is going to increase the oxygen demand, and the wound healing is going to be delayed, and there is going to be an increased risk of surgical site infection. And the core temperature has to be regularly monitored, that is why, and maintained about 35.5 degrees Celsius perioperatively. Glycemic management, perioperative hyperglycemia, is a very big villain, and is associated with increased risk of morbidity and mortality. So you have to control the blood sugar, okay? And obviously during surgery, the hypermetabolic stress response is going to lead to hyperglycemia. So studies have shown that if you give intensive insulin therapy and try to maintain glucose concentrations at 80 to 110 milligram, then there is a reduction in post-operative complications. But this is known as tight glucose control. But you know that there are very many problems associated with tight glucose control. There is an increased risk of complications. And so you can maintain the blood glucose concentrations between 140 to 180 milligram per deciliter. Post-discharge analgesia, you reinforce the pain expectations and goal. Consider scheduled non-opiates. I've already told you which non-opiates to use: acetaminophen, tramadol, gabapentin. And follow up the patients and family for feedback loop. And you can use various apps to follow the patient up after surgery. And you have to keep in contact with the patient. So in obstetrics, the steps are the same, but there are some 3 different steps I found. One is the delayed cord clamping. Next is the natural cesarean delivery, and regular oral multimodal analgesia. So I'll just tell you about delayed cord clamping. So they say that delay in clamping of the umbilical cord for at least 30 seconds is associated with higher hemoglobin concentration and iron reserves up to 6 months after birth compared to early clamping. And the current recommendation from the American College of Gynecologists is delayed cord clamping in vigorous term and preterm infants for at least 30 to 60 seconds after birth. Then the concept of natural cesarean delivery, that the woman can have a natural experience comparable to a vaginal birth. And these are reported benefits for both the newborn and the mother of early skin-to-skin contact. So they say that when there is early skin-to-skin contact, the mother and the baby, then there is the rates and duration of breastfeeding are increased, And there is a decrease in maternal anxiety and postpartum depression, and therefore the maternal recovery is enhanced. Then a transparent surgical drape allowing the mother and her husband to witness the birth, and initiating immediate skin-to-skin contact and breastfeeding after birth. All these can hasten the recovery. Then, of course, regular oral and multimodal analgesia with a combination of nerve blocks, neuraxial opioids, oral analgesia, neural morphine you can give for post-cesarean section analgesia, paracetamol, ketorolac, ibuprofen, oxycodone, IV narcotic. All these can help to provide analgesia, opioid-free analgesia. Nerve blocks, you can give local wound infiltration, TAP block, quadratus lumborum block. Now, what is this? This is the website of the IRAS Society, which I was talking to you about. So IRAS has progressed so much. You have this IRAS Society now. And the IRAS Society keeps on publishing various guidelines, I have already told you. And look at this. This is the IRAS guidelines for anesthesia. They are available free at the IRAS Society website. You can go to this website of the IRAS Society and you will get the guidelines for all the different kinds of surgeries. You'll get evidence for IRAS. So what is the evidence for the implementation of IRAS? All this time I was telling you about what is IRAS, what are the steps of IRAS. Now you will ask me, Are, what is the evidence for it? If we have to implement IRAS, you should, now is the era of evidence-based medicine. So what is the evidence for that? See, they say that IRAS elements are related to specific surgeries. Now, for a particular kind of surgery, one particular IRAS element may be more important than the other element. For example, for neurosurgical procedures, goal-directed fluid therapy is important. For abdominal surgery, selective bowel preparation, early feeding, use of chewing gum, post-operative multimodal analgesia, minimal use of drains is important. Pediatric surgery, carbohydrate drink is important, goal-directed fluid therapy is important, prevention of hypothermia is important. In obstetrics, early mobilization, early feeding is important. So it depends upon the type of surgery. But evidence states that for particular IRAS elements, the level of evidence and recommendation is different. For example, for carbohydrate testing, the level of evidence is low and the recommendation is strong. For preoperative fasting for liquids, the level of evidence is high, but the recommendation is strong. And for solids, it is low level of evidence. Again, for for the mechanical bowel preparation, the level of evidence is moderate. Then for multimodal analgesia, for regional blocks like epidural, the level of evidence is low to high, and the recommendation is again strong. For the PONV prophylaxis, the evidence is low, the recommendation is strong. Then goal-directed fluid therapy, moderate evidence, strong recommendation. Then early feeding in the post-operative period and perioperative glycemic control, there is weak to strong recommendation. So pre-operative, then again, the prevention of intraoperative hypothermia, high level of evidence and strong recommendation. Now the review of 6 RCTs showed that there is a IRAS reduced complication by 50% and reduced the length of stay by 2.5 days. So there is evidence that elderly patients undergoing elective colorectal surgery, according to IRAS protocol, are highly pleased with the care that they have received. Now, there are several limitations in this IRAS protocol. What are the difficulties? So in the Indian setup, they say that despite awareness amongst most anesthesiologists and proven benefits of IRAS, it is found that there is a huge variation in the pattern of clinical practice followed in the perioperative period. So the well-adopted practices include in India include pre-admission counseling, risk stratification, pre-op nutritional screening, PONV prophylaxis, titration of FiO2, maintenance of intraop normothermia, monitoring of depth of anesthesia, epidural use, goal-directed IV fluids, early post-op feeds, and early mobilization. Less adopted practices include pre-op carbohydrate-rich drink, TIVA, neuromuscular function monitoring, avoidance of nasogastric tube, intra-op opioid sparing, and tight peri-op hyperglycemia control. And a study has shown that the uptake of IRAS principles varies across hospitals, and some principles are exhibited a high level of acceptance, for example, prophylactic antibiotics and early mobilization. So this particular editorial from the Indian Journal of Anesthesia, it states that enhanced recovery after surgery. This is a prospective cross-sectional survey which was done on ERAS in India. And in this survey, out of the respondents, 89.4% were aware of ERAS, and 46.2% respondents, they said that the anesthesiology department in their institutes was responsible for making the perioperative care protocol. And 84.2% and 71.1%, they said that the benefits of ERAS included multimodal rehabilitation and reduction in the hospital stay. And TIVA, neuromuscular function monitoring and avoiding of nasogastric tube, was routinely practiced by less than 20% of anesthesiologists. Multimodal prophylaxis for PONV, around 72.5% respondents said that it was a useful element. And preoperative fasting protocol, 2 hours for clear fluids, 6 hours for solids, that was 58.2% respondents agreed to this. And goal-directed fluid management, around 80.6% respondents agreed to this. And the hindrances that they faced, the respondents, most common was a fear of complications if they used ERAS, and administrative issues were reported by 51.3%. So that means the challenges of ERAS implementation are many. Especially the biggest challenge is the acceptance of ERAS. So most of the available literature on ERAS is based on studies done in European and American institutions. In India, it is many institutions. Some institutions are following, but most of them are yet to implement it. And the lack of trained personnel in ERAS, poor telecommunication facilities, you are not able to follow up the patient after discharge. Many of our rural areas, they don't have the telephone, they don't have those apps where you can communicate with the patient after discharge. And therefore, we are scared to discharge the patient early because we may lose contact with the patient. So we don't want to implement ERAS. That is the fear in us. So there are various barriers in obstetrics, the ASHA workers don't know what is ERAS. Then, there is a lack of telecommunication and network in our rural areas, lack of trained staff, and most important in India, most of the many pregnant females will be anemic. So ERAS, implementation of ERAS becomes a problem. So this article is very nice, by Girish Joshi. It states that ERAS, too many recommendations, what should I do? Well, ERAS should, but the article authors conclude that ERAS should become the standard of care, but implementation has been slow and it has low compliance with various components. So the ERAS, is it only for high income countries? The ERAS revolution is now literally like the coronavirus. It is sweeping the high income countries and improving surgical anesthesia complication rates and outcomes. And it is saving the healthcare currency by decreased length of stay. But in low middle income countries, it is not so. In fact, the ERAS protocols here should focus on preoperative evaluation, use of cost-effective antibiotics, regional blocks, multimodal pain management, and early post-op mobilization. In emergencies, ERAS, there are very few RCTs of ERAS protocols in emergency surgeries. And they say that in emergencies, compliance with ERAS becomes lower than in elective surgeries. To overcome the challenges, you have to perform audits, training programs, increase awareness of ERAS among staff members of the hospital, do extensive teamwork, then more availability of ultrasound for nerve blocks, intraoperative EEG facilities, BIS, increase the number, more training of anesthesiologists in this ERAS concept. And, ERAS is no longer a novel concept, but its implementation is very challenging, and mainly because of barriers to its acceptance. Every member of the perioperative team is important in the implementation and success of the ERAS pathway. And the journey is very long, for us to have ERAS being implemented in every hospital in our country. And we will have to adopt a multidisciplinary approach if we have to be successful. Now, the ERAS protocol has been included in this strategy for perioperative quality improvement. This is an recent editorial from IJA, and there the perioperative quality improvement has been stressed upon, and ERAS is one of those strategies. So ERAS, this is a very nice editorial. Again, 2021, it states that ERAS, still a distant speck on the horizon, means you can see it, but are we ever going to reach it? Are we ever going to be successful in implementing the ERAS protocol or the ERAS pathway in routinely in our day-to-day surgeries? So I would like to conclude by stating that each element of the ERAS pathway is important to successful patient recovery, but you have to have a committed multidisciplinary approach, and implementation of some steps of the ERAS pathway is challenging. Research into specific principles of ERAS is required to improve implementation of ERAS. So now again, I had started at the beginning of my lecture saying that is ERAS a myth or a reality? So now I conclude by saying again, ERAS, is it a myth or a reality? So to make it, I feel that at present, it is a myth for us in India, especially in the peripheral hospitals. But to make it a reality, we have to really work hard. And how to do that, I think I've already explained to you. Thank you very much. Thank you very much and good day.
Thank you, madam. It was really an excellent and informative talk. And I'm sure ERAS will become a reality soon in the developing countries too. Yeah. So I request Dr. Saleh sir if he has any comments or questions to ask.
Yeah, good afternoon. Excellent presentation. Madhuri madam has cleared a lot of things about the ERAS. All said and done, she has raised at the end of the session one question, whether it's a myth or reality. It was a topic. As on today, it is a myth, but in coming future, that is going to be the reality. And each one of us has to rethink on this. Are we really practicing ERAS, whether it is in the institute or in the periphery? And in coming future, the continuous presentations, continuous discussion on this topic will inculcate the culture in all the anesthetists that we have to practice such things. And again, all said and done, we are not practicing. We are practicing partially, but protocol based, and it's a structure based. And once it has been clear, and the colleagues, they have to come forward, particularly surgeons in the team, that anesthetist plays, as you rightly said, he plays the crucial role or pivotal role in this ERAS protocols, whether it is a preoperative optimization of the patient, intraoperative, postoperative, all till the patient comes back to his normal work. Till that time, our involvement has to be there. And as she rightly said, multimodal approach and multidisciplinary approach. All the people, including surgeon, anesthetist, nutritionist, physiotherapist, nursing staff, all the people are involved in this. The coming future is the only answer, and I am not surprised. I'll not get surprised if the people come with the Google University and they ask the anesthetist, who is my anesthetist? Are they following the ERAS protocols? People will come and ask this. So we need to be careful. That's the answer. Thank you so much, Dr. Madhuri madam. You have done a wonderful session. This is a new chapter, and last few decades, a few years, we are discussing more and more, and people now are aware. Something ERAS guidelines are there. ERAS society is there now from 2018. Pediatric ERAS society is there, but people will slowly come into the picture. Thank you so much. Thank you, Thane ISA, giving me the opportunity to have this session. These are very good things are going. Thank you so much.
Thank you, Dr. Saleh sir, and thank you, Madhuri madam. Does anybody have questions? There are no questions in the chat box.
I think I like to add something, that in ERAS, like we in our hospital, which is a government hospital. Now I was talking about all the concepts about steps of ERAS. So prehabilitation is one very important step in that. So our patients, if we in many hospitals, if you ask the patient to that I want to prehabilitate, so you'll have to wait for surgery for 1 month. Many of them are not ready to wait for that. So this is even applicable to private hospitals and nursing homes. They say, okay, if you're not operating, I'll go to another nursing home. It's like that. And secondly, minimally invasive surgery is also one of the most important, is one important step in ERAS, which I didn't tell you because the anesthesiologist is not involved in that. So not all surgeons are expert in doing minimally invasive surgery. Depends upon the mentorship that they receive to do minimally invasive surgery. So these are also problems, practical problems which we face in ERAS implementation.
Ma'am, in coming future, everybody will come up with the minimal invasive surgery
Yes,
only
yes.
because that is
Yes.
going to be their survival.
Definitely. So all of them
they
have
have
to
to get
become
trained.
good in minimally invasive
They
surgery.
have to.
So if they do minimally invasive surgery, I think the ERAS concept will become a success, isn't it?
Yeah. Nowadays, everybody is, yeah.
Yeah, Shweta, please.
No, you carry on. You
Yeah,
asked.
I just wanted to tell one thing. When I contacted Dr. Madhuri and suggested this topic to her, I told her that we should actually change the name of ERAS as not enhanced recovery after surgery, but enhanced recovery after anesthesia and surgery. So make it more involved for us as perioperative physicians, and it reiterates the point that apna kaam is not just giving a spinal or putting in a tube and taking it out. It is much more than just that. We have lots of work to do outside the OT, before the surgery, and also after the surgery.
Manisha, madam, it will come. So it will come because now and then ERAS protocols are getting changed.
Yes, sir. Definitely.
Every now and then they are getting changed. So it will come.
ERAS is the future now.
Continue, Shweta.
Yeah, I would like to thank Dr. Saleh sir and Dr. Madhuri ma'am. I would request Dr. Saleh sir to hand over a floral bouquet to Madhuri ma'am. And as a token of appreciation, I would also request Dr. Vineet to hand over a floral bouquet.
Thank you so much, Thane ISA.
Thank you, sir. And over to you, Manisha. Manisha, you're on mute.
Mute us, Manisha. Manisha.
Yeah. So thank you, Dr. Saleh sir, Dr. Madhuri, and Dr. Shweta for stepping in so gracefully and making this talk really very, very interesting. It was really nice to learn about new things and the new trending topic, ERAS. Let us now move ahead with our next talk. When I was a resident about 25 years ago, there was a dictum. If the surgery is below umbilicus, give a spinal. If the surgery is above the umbilicus, give a GA. Our next speaker, Dr. Naresh Paliwal sir, has belied this dictum and made any surgery possible under segmental spinal. This session will be moderated by Dr. Ketki Patwardhan. Dr. Ketki is an associate professor in Rajiv Gandhi Medical College, Kalwa. She is also the author of many psychological thrillers and is very popular on social media. Dr. Ketki. Ketki, unmute yourself.
Okay. Am I audible? Okay. So thank you, Manisha madam. Today I will take the pleasure of introducing our speaker and chairperson for this session. The chairperson is Dr. Indrani Hemant Kumar, who actually does not need any introduction. She is the professor and head of a Department of Anesthesiology at St. GS Medical College and KEM Hospital, Mumbai, with more than 31 years of experience and more than 42 publications to her credit. She is the past governing council member of Association of Medical Consultants, and presently she is the president of RSACP National. Next, I would like to introduce our speaker for today for segmental spinal, Dr. Naresh Paliwal. Dr. Naresh Paliwal is an associate professor of anesthesiology at Dr. PDMM College, Amravati. He has been a faculty at various conferences, and he has special interest as well as done special work and publications on segmental spinal. I request Dr. Paliwal to proceed with his talk.
Hello, good afternoon, everyone. At the outset, let me thank ISA Thane for providing me this opportunity to present my topic on segmental spinal. Something about the history and current status. In 1909, Thomas Genesco proposed the term general spinal anesthesia for surgeries of head, neck, and thorax by giving spinal at T1, T2 levels. It was in 2006 the new era on segment spinal began when Evan Zundert gave spinal at T10 for laparoscopic cholecystectomy in a patient with severe COPD. I am using this technique and presenting this since last 10 years, but the real acceptance and popularity has been found during this pandemic of COVID-19. It's now being used in every corner, and even many postgraduates have taken it as a thesis topic. It has become the most trending regional anesthesia technique recently. Now, what is segmental spinal? The term often used synonymously with thoracic spinal, but even the low doses of drugs used at the higher lumbar levels can produce a segmental effect with sacral sparing. So the ideal definition should be blocking of the required dermatomes essential for the proposed surgical procedure with very low volume of local anesthetic drugs by giving spinal near the targeted nerve roots. This often necessitates dural puncture at high lumbar or thoracic levels. Lower the volume or the dose of the drugs used, more likely to produce a true segmental block. There are some factors which make segmental spinal feasible. In thoracic segments, the spinal cord is positioned anteriorly, leaving a significant space between the posterior and the spinal cord. The thoracic nerve roots are slight and thin, covering its efficient blockade with low dose of the drugs used. Amount of CSF at thoracic levels is comparatively very less. No difference in the onset time for isobaric and hyperbaric drugs at thoracic levels, while the isobaric drugs may take a little time to onset at lumbar levels. There is natural thoracic kyphosis at thoracic levels 765. There are some safety concerns whenever we talk about segmental spinal. The first and the foremost is neurological injury with dural puncture at mid to low thoracic levels or high lumbar levels. The second issue is ventilatory impairment due to extensive thoracic nerve blocks, bradycardia and hypotension due to blocking of the cardiac fibers and higher spinal. And last but not the least, the medical legal issues, as it is still to appear in the standard textbooks. The major concern with segmental spinal is damage to spinal cord. This is a midline MRI of the spinal column. The cervical enlargement fills the entire spinal canal at the level. In the thoracic segments, the spinal cord is positioned anteriorly, leaving a significant space between the posterior dura and the spinal cord. At the lumbar levels, the lateral space disappears almost completely. Here you can see clearly there is a significant space between the posterior and the spinal cord at thoracic levels. This is the position of spinal cord at various levels: thoracic, thoracolumbar, and cauda inguinal levels. Embelloni and Guia did a study about the low incidence of neurological complications during thoracic epidurals, and they provided an anatomic explanation for this. They measured the exact distance at various levels, and they found the distance to be around 5.19 millimeters at T2 levels, 7.75 millimeters at T5 level, 5.88 millimeters at T10 levels. Lee R.A. did study of anatomy of spinal canal in various positions, supine, lateral, and sitting positions, and they found the distance to be more in all positions at mid-thoracic levels, especially the lateral and sitting positions. These are the positions we usually use for giving spinal anesthesia. The left-hand side figure shows the distance from anterior dura to the spinal cord, and the right-hand side figure shows the distance between the posterior dura and the spinal cord at mid-thoracic levels. This is again a midline MRI because of the angulation required to perform spinal anesthesia at mid-thoracic levels. The distance is further increased. At least 40 to 45 degrees angulation is required to perform spinal anesthesia at mid-thoracic levels. Here you can see the distance is almost 8 millimeters as compared to 4.5 millimeters at low thoracic or lumbar levels. There are some additional points which favor the safety of segmental spinal. The incidence of neurological injuries after accidental duropuncture during thoracic epidural is found to be very less, favoring the safety of intentional duropuncture during segmental spinal. And many anesthesiologists unknowingly use higher lumbar or thoracic spaces, especially in the obese and parturients. In one study, only 29% were found to be correctly identifying the required intervertebral space for giving spinal anesthesia. And the level at which the spinal cord terminates is also variable. Second issue is ventilatory impairment. The main inspiratory muscle of respiration is diaphragm, which is usually unaffected. Expiration at rest is a passive process. Forceful expiration and coughing may get affected due to paralysis of anterior abdominal wall muscles. But because of the low doses of the drugs used, that usually preserves the coughing ability due to minimal motor weakness of abdominal muscles. Bradycardia hypotension, heart rate may decrease if block extends T1, T4, but due to lumbosacral sparing and less venodilatation in lower limbs, the right atrial filling is maintained. That sustains the outflow from intrinsic chronotropic receptors, maintaining the heart rate. Less hypotension is due to less sympathetic blockade and lumbosacral sparing. About the medical issues and litigations, now there is enough evidence to prove its utility in cases where it is most indicated. The most cases of litigation are against regional anesthesia, but still thoracic epidural is being performed day in and day out. And even accidental duropuncture is also done even by trainees, but still the incidence of neurological injuries is found to be very less. A proper explanation and consent is must. It has started to appear in some textbooks, but till that time, we can keep our fingers crossed. About the feasibility of segmental spinal and utility, technically, it's not much difficult with due precautions. Economic, it's very, very economic. And legal feasibility, still a question mark, but can be defended with strong indications. Operational feasibility, for experienced clinicians with a good learning curve, it's not very difficult. It can be used for practically all intra-abdominal surgeries, upper, lower, open, laparoscopic, major, minor, etc. Even for breast and superficial thoracic surgeries, and even for thoracoscopic surgeries like bullectomy, thymectomy, lung volume reductions, and some prone and lateral position, spine and musculoskeletal surgeries. Some advantages over routine spinal or at times over general anesthesia. Surgeries thought to be out of domain of spinal anesthesia are possible with segmental spinal, like upper abdominal, thoracic, and breast surgeries. Higher levels of the blocks can be achieved with just half the dose that is required at the lumbar levels. There is minimal hemodynamic fluctuations, early recovery, and voiding. Special advantages over general anesthesia in patients with the respiratory comorbidities, can avoid post-op-pulmonary complications and ventilatory support. There is also lower incidence of post-op nausea and vomiting. There are three different modes in which we can use segmental spinal, either as a single shot spinal for short to mid-duration surgeries up to 120 minutes, or it can be combined with epidurals, either for long duration surgeries or as a backup in a very morbid ill patients when we are not able to use enough doses for giving spinal during segmental spinal. In that case, you can use epidural as a backup. Epidurals can be handy not only as a backup, but by epidural volume extension technique. It can spread the low doses of intrathecal drugs to wider segments and can also be useful for post-op analgesia. And the third option is continuous segmental spinal anesthesia, just like continuous spinal anesthesia, using spinocats by giving titrated and sequential boluses in morbid cases for long duration surgeries. This option can be utilized when you get accidental duropuncture during thoracic epidurals. Drug options, isobaric or hyperbaric, either of drugs can be used. Even a combination of hyperbaric and isobaric drugs can be used in some abdominopelvic surgeries. In general, isobaric drugs are preferred for laparoscopic thoracoscopies, breast, and superficial abdomen, or major intra-abdominal procedures in a very morbidly frail patients. Hyperbaric drugs can be a choice in some male muscular and open surgeries. Some advantages of isobaric drugs. These are preferred drugs as they are less sensitive to position issues. In low doses, they have a propensity to block sensory nerves in preference to motor ones. It is labeled as a selective anesthesia. Onset is gradual. There is hemodynamic stability even with high levels of the block. Motor block time is usually shorter, leading to early ambulation and voiding. Spinal can be given directly in the operative positions, like for lateral position surgeries, or patient can turn on his own immediately after spinal to desired positions for lateral or prone positions. Spinal can be given before epidural and a space higher than epidural without worrying for unilateral effects, as can happen with hyperbaric drugs. There are a few disadvantages of using isobaric drugs. The levels of block cannot be modified by any change of positions. The drugs need to be placed at the precise dermatomes. Like in epidurals, sacral sparing is common when low doses at higher spaces are used. It takes some more time for onset at lumbar levels. Slightly less muscle relaxations, so you may need higher doses in male muscular patients. They are also sensitive to some temperature variations at times and can have unpredictable results when there are wide variations in the drug body and atmospheric temperature. Amongst the available drug options, isobaric drugs like chlorprocaine 1%, bupivacaine 0.5, ropivacaine 0.5 and 0.75%, and hyperbaric drug bupivacaine 0.5%, and now ropivacaine 0.75% heavy. All that can be used. Chlorprocaine being 1%, the volume required is usually more. Dose of 2.5 to 4 ml at high lumbar levels can provide adequate levels for short duration lap and bone abdominal surgeries up to 40 to 60 minutes. Bupivacaine and ropivacaine 0.5%, bupivacaine and ropivacaine 0.75% are comparable. Ropivacaine, being less lipid soluble, is nearly half as potent as bupivacaine intrathecally, and there is stronger differentiation between sensory and motor blocks with ropivacaine. Addition of small doses of additives like fentanyl, dexmedetomidine, ketamine, or clonidine can intensify the sensory blocks. Dexmedetomidine providing a longer duration than others in a dose-dependent manner, and ketamine, though potentiating sensory block, is known to shorten the motor block time. Bupivacaine heavy 0.5% can well be used in the same dose range as isobaric drugs. Thoracic segmental anesthesia can be produced with just half the dose that is used at lumbar levels. The onset time is reduced to reach the T3 levels, duration of motor and sensory blocks, plus the high potency events are significantly reduced with low doses used. Gravity dependent spread has to be kept in mind. Can be a better choice for open surgeries in some male muscular patients. Now, how to decide about the dose and the site of injection in a particular surgery? For abdominal surgeries, it depends on the type of surgery, whether it is open or laparoscopic, site of surgeries, upper, lower, average duration of the surgeries, comorbidities of the patient, and whether combined with epidural or not. Dose of local anesthetic and the site of injection along the near axis can be varied. In general, 1 ml of the isobaric drug spreads 2 to 3 segments above and below the site of injection. If you keep this in mind, you can calculate the doses required for any surgery and the site of injection for that particular surgery. What that means is 2 to 2.5 ml of the drug is sufficient to block segments from T2 to L5 S1 if spinal is given at T10, 10 thoracic space, lying in the center of the surgical field for upper abdominal surgeries. With adequate dose, space above T10 is usually not required for abdominal surgeries. Space between T10 L1 and a dose of 2 to 2.5 ml with some additives works nicely for 90 to 120 minutes. And the recreation of effects from lumbosacral roots can start wearing after 70 to 80 minutes. And for surgeries involving pelvic manipulations going beyond this time, you can combine the hyperbaric and isobaric drugs for prolongation of effects at lumbosacral roots. For breast and superficial thoracic surgeries, spinal needs to be given at mid-thoracic levels, T456, with 1.2 to 1.5 ml and some additive. But even up to 2 ml can be used if lower spaces are used for spinal. With this much dose, it can provide a duration of 60 to 90 minutes or little more if Dexmed is used as additive. For prolonged procedures, it is always better to combine with epidural or some blocks rather than increasing the intrathecal dose to avoid the adverse respiratory and cardiac events. These are the levels required for different types of breast surgeries and assessment of the levels during thoracic epidurals for breast surgeries. For MRM, we need the levels from C5 to T7. For mastectomy with transverse rectus abdominis flap, we need levels from C5 to L1. And for partial mastectomy, just T1 to T7 is needed. The epidural scoring scale for arm movements can be well used for assessing the effects of thoracic segmental spinal. The 4 grades, the hand grips C8 T1, wrist flexion C8 C7, elbow flexion C5 C6. Position of the patient for giving spinal using isobaric drug does not matter. You can use any position. Plain bupivacaine 0.5% with specific gravity of 0.9990 is slightly hypovaric given in sitting position, and patient kept seated for some times can lead to high levels of block. Temperature of the drug has inverse relation with baricity. Cooled at 24 degrees, it can become slightly hyperbaric, and warmed at 37 degrees, it can become slightly hypovaric. Wide variations in temperature can have some impact on gravity on spread of the drugs. Using combination of hyperbaric and isobaric drug, sitting position is mandatory for giving spinal initially. Type of the spinal needle, either Quincke or pencil point, anyone can be used. Combined with epidurals, CSE kit is the easiest and safest option. In a study of 300 patients using cutting or pencil point needle, they found the paresthesia in 20 patients, 7 with cutting and 13 with pencil point needles. It was more with pencil point as you have to enter more with pencil point needles to have a free flow of CSF. Landmarks to give thoracic spinal can be done by palpation method or by taking the use of ultrasound. By palpation, the C7 has a prominent spinous process. Root of the spine of the scapula corresponds with T3. Inferior angle of the scapula corresponds with T7. And the lower rib margin is around 10 centimeters from midline of L1. By taking advantage of ultrasound, you can count upwards from L5S1 in parasagittal oblique view, or you can identify 12th rib and count upwards, or identify the first rib and count downwards. There are some anatomical hurdles for thoracic spinal. The thoracic spinous processes are sharply angled and point caudally between T4 to T9. Beyond T10, they resemble those in the lumbar region. So beyond T9, it is usually as similar to your lumbar spines. Interlaminar spaces in thoracic spine are narrow and more challenging to access with a midline approach. So a paramedian approach can be a better choice at mid-thoracic levels. These are some tips and tricks to follow for giving spinal at mid-thoracic levels by a paramedian approach. Ultrasound, those have the facilities, can be used for giving spinal at mid-thoracic level. You can do a pre-procedural scan, but there is a very small window in parasagittal oblique view, and there is no window in transverse view. What ultrasound tells us is the location and depth of interlaminar spaces, the midline, and the location of LFD complex, ligamentum flavum dorsodura complex. In scoliosis, the convex side is usually more open, that you can find out with ultrasound. The parasagittal oblique view at mid-thoracic spine can be utilized to localize the LFD complex, as I have already told you. But ultrasound at mid-thoracic levels, it's not as easy as it is at the lumbar levels. Transverse interspinous view at the mid-thoracic levels. Subseptum measures for successful use of segmental spinal. You have to do a preoperative assessment as to the type and site of surgery, approximate duration of the surgery, dermatomes involved in the proposed surgery. If ultrasound facilities are available, you can do a pre-procedure scan. Identification of the landmarks to locate the intervertebral space for giving spine. Selection of the proper drug and mode of segmental spinal, whether you want to combine it with epidurals or you want to have a single shot spinal. Decision on the site of injection and doses of the drugs required. After giving spinal, you have to do the assessments of the level achieved, monitoring and use of appropriate sedation as per need. In the preoperative assessment, as I already told you, the site of surgery, type of surgery, duration of surgery, whether it is short duration, mid duration or long duration surgeries, and the comorbidities of the patient as to the feasibility of segmental spinal with a very lowest possible dose and combining with epidurals or as a continuous segmental spinal anesthesia using spinocats. These are the diagram to show the dermatomes involved in the proposed surgery. Like I already told you, for MRM, you need levels from C5 to T7 at least. And accordingly, you can choose your site and dose of drug. Now coming to my segmental spinal profile, more than 3,000 surgeries in last 8 to 10 years. Initially used only for high-risk cases, now occupies nearly 50% of my SAV profile. Till date, very few partial failures, but fortunately, no mishaps. Complete pre-anesthetic evaluation is done when a success, minimum mandatory monitoring, no sedative pre-medications. Lateral decubitus is what I use for giving spinal. 27 gauge quick needle. Speed of injection is usually average, 1 ml per 15 seconds. Depending on the patient's parameters, the dose of local anesthetic and site of injection is selected. For short duration surgeries, I usually prefer chlorprocaine, 2.5 to 3.5 ml at high lumbar spaces or T12 to L2 space. For mid-duration surgeries, either leave bupivacaine 0.5, ropivacaine 0.75 or bupivacaine heavy 0.5% according to need, with some additive like fentanyl, ketamine or dexamethasone around 5 to 10 mcg if longer duration is desired. For average female patient ASA12, I usually use 2 ml plus additive. For average male patient ASA12, I use 2.5 ml plus additive. And T10 to L1 interspace is what is used. Combined with epidurals, the initial dose can be kept to a minimum around 1 to 1.5 ml. I usually combine these segmental spinals with various blocks like transverse septum plane block, rectus sheath block, or erector spiny plane block for open surgery, or local anesthesia at the port site for laparoscopic surgeries. For breast surgeries, I prefer isobaric drugs, bupivacaine 0.5 or ropivacaine 0.75%, 1.5 to 2 ml with additives like fentanyl, ketamine, or dexamethasone at mid-thoracic levels, and usually combined with epidurals or some blocks like PEC1, PEC2, serratus anterior plane block, or erector spiny plane block for post-op analgesia. About the two drug techniques for surgeries like TLH, PCNL, colorectal, or other surgeries where dense and azure effects at lumbosacral roots is needed and which cannot be achieved with using low doses of isobaric drugs alone at thoracic levels. This two drug technique can even be used for some high-risk LSDS gynec surgeries or some ortho surgeries also. For this, you need to give spinal in sitting position around T10 to L1 space, 0.5 to 1 ml of hyperbaric drug initially, followed by 1.5 to 2 ml of isobaric drug according to the procedure in different syringes. After giving spinal, the patient usually turns supine after spinal and kept in lateral position for lateral position surgeries. Sensory block tested by pinprick usually sets in 3 to 4 minutes and complete block usually 8 to 10 minutes. Some hemodynamic fluctuations can occur within first 10 minutes, but these are usually minimal and very gradual. No respiratory embarrassment is seen even with high thoracic cervical root involvements, as it is mostly a sensory block. Initial partial involvement of lumbosacral roots can occur when large doses are used, but that usually recurs at the end of surgery. No additional supplements in most cases, barring few lab surgeries, as it is under all regionals. Patients can be completely mobilized in 4 to 6 hours. To sum up, it is a very useful technique with many advantages and minimal risk with due precautions. No need to panic even if the block level is found to be higher than desired. It's mostly a sensory block. Lab surgeries may need little sedation, as it is under all regionals. When facilities are available, USG can be helpful for more safety, and the technique is reserved for experienced clinicians with good learning curve. Now I'll show some videos. This first one is probably for some epigastric hernia. This is just to show how straightforward it is at lower lumbar, high lumbar or lower thoracic spaces. This is a 27 gauge needle. It is as straight as your lumbar spinal. Just 2 ml of the drug. This is a morbid obese patient. Sitting position was used for giving spine. For hysteroscopic removal of the polyp, surgery was about to take some 60 to 70 minutes. Teeter L1 space was used for giving spinal. And draping is avoided to have a clear view. This was the patient after 1.5 hours. And this is after 3.5 hours. Patient completely mobilized. She went home in the evening. This is MRM being done under combined spinal and epidural. And this was T5, T6 was the epidural, and T6, T7 was spinal. You can see how comfortable the patient is, even with such high levels of the block, levels being tested. She had no sensation at C8, but her grip strength was good, indicating only sensory block. This is MRM being done, the same patient. This is when you are not using epidurals for post-op analgesia in cases of MRM. You can ask the surgeon to give PEC1, PEC2 blocks under vision after completion of surgery. Many surgeons don't prefer it before surgery, so you can ask them to give after surgery. This was a unique case of traumatic diaphragmatic hernia done under combined segmental spinal and epidural. You can see whole of the intestinal contents in the left hemithorax. This is diaphragmatic mesh repair being done in the same patient. Same patient at the end of surgery is comfortable and ready to shift himself. This is the next day X-ray of the same patient. This is an obstructed umbilical hernia. You can see his respiration. It was done under combined segmental spinal and epidural. There's a big transverse incision. This is laparoscopic cholecystectomy with ETCO2 monitoring in a morbid lady, diabetes, hypertension. This was a huge ovarian cyst, query malignant. It was compressing all the intra-abdominal structures, even the inferior vena cava and aorta. It was done under 2-drug technique. Spinal was given in sitting position, T12L1 level, 0.5 ml of the hyperbaric initially, then 2 ml of the isobaric drug. This is the same patient during surgery. Before surgery, her cyst had to be ruptured because it was such a huge cyst, even with a big incision, not able to remove it. Her cystectomy, omentectomy, hysterectomy was done. This is again a modified radical mastectomy, combined spinal epidural. The epidural was put at T45. The spinal was given by a paramedian approach as it was not possible with midline approach. Let's see during surgery, during axillary dissection. The same patient at the end of surgery, shifting herself. This is total laparoscopic hysterectomy. This is at the end of surgery. This was done under 2-drug technique. This was a patient with CA vocal cord. Upper GI showed signs of near total occlusion at post-recurrent region, and feeding gastrostomy was advised. Tracheostomy was already done. It was done with just 1.5 ml drug at T7 levels. This is PCNL, done under 2-drug technique. This is a ruptured ectopy. The patient being interviewed during surgery. The whole of the abdomen was filled with blood. This was a patient with atlantoaxial dislocation and bacillary invagination. Her C1, C2 fixation was done and she was wearing cervical collar. The recent MRI showed some disc bulge in C4, 5, 6, and she had tingling numbness in the hands, and her mouth opening was very less, but she was very much worried about her neck movements. And given the option, she preferred the segmental spinal for a total laparoscopic hysterectomy. She was a relative of a doctor. Everything was explained to her, and it was done with 2-drug technique. We did not touch her neck at all during the procedure, except for putting a ETCO2 probe. This was CA rectum. Colorectal anastomosis was done few days back, and the patient developed dehiscence of the anastomosis, and developed bilateral pneumonia and pus in all of the abdomen. It was done with segmental spinal. You can see his parameters. This was a huge liver abscess burst in a young lady with a hemoglobin of just 4.9. Her CRP was raised. You can see the whole of the abdomen was filled with pus. And just under sole segmental spinal. As she was in sepsis, epidural was avoided. This is the pus liver. This is laparoscopic appendicectomy. Then the way I use catheter to monitor the ETCO2 in such patients. This is laparoscopic appendicectomy. Patient shifting herself from table to stretcher at the end of surgery. This was recently done. Volvulus of the small intestine about to become gangrenous. This was done with a hyperbaric drug, 2.5 ml of the hyperbaric drug. This was a Michel's diverticulum, which was the culprit. The intestines were rolled around it and it was getting blackish, but it was on-time surgery. The patient could be saved. The intestines were saved. These are two patients being interviewed, one at the end of surgery. This was a simple laparoscopic appendicectomy. Complete regression of effect. This is the second patient being interviewed during surgery. These are my two publications. And thank you very much for listening patiently to my presentation. Thank you very much.
Thank you, Paliwal sir, for the very nice, amazing presentation and lots of interesting cases. There is one question from the audience. How to make isobaric local anesthetic hypobaric? What diluent has to be used?
Hello.
Hello.
For making the drug hypobaric, you need to add distilled water to it, at least in 1:3 proportion. What we do is we take 1.5 ml of the drug isobaric, that is 7.5 milligrams, 1.5 ml, and to it add 3.5 ml of the distilled water. That makes 5 ml, and the concentration becomes 0.15%. That means 1.5 milligram per ml. That is hypobaric.
Okay, now I would request Dr. Indrani madam to share her thoughts about this topic.
Madam, you have to unmute yourself, I think. Indrani madam, you have to unmute yourself.
Can you hear me now?
Yes, ma'am.
Spinal is an uncharted territory for most of us. And I think Dr. Paliwal, gave such an excellent presentation, and he dared to move into that uncharted territory. And the plum of the cake was the videos and the photographs which he showed, and the enormous body of work which he has done on segmental spinal. Congratulations, Dr. Paliwal. It was
Thank you,
excellent.
madam. Thank you for nice.
And the other thing is about, what I want to ask you is, will you still prefer segmental spinal even in cases where general anesthesia or epidural can be given safely?
For me, it has become a routine nowadays. But what I advise to the people who are doing it for the first time, to do it in a cases where it is most indicated.
Where there is high risk.
No,
Whenever you
not
find a
because
risk for general anesthesia.
Not just because it is not mentioned in the books or till the time it appears in some textbooks. You can use it for the cases where it is most indicated. That time you can justify the patients with some respiratory comorbidities. And now during this COVID times, there are so many people who have started doing this. Actually, this topic has boomed just because of COVID.
Yes. Otherwise, I'm using this topic since 8 to 10 years, but since last 2 years only, it has taken a, spurt. There are many people who have started using it. And once they start using it and they find it easy, they are using it for routine cases also. No injury to the spinal cord ever?
No, madam. At times you get some paresthesia, but even there are reports. I have shown that that publication by Imbeloni and Guvia about the incidences of neurological injuries. And you see the people are doing thoracic epidurals day in and day out. And they are, accidental dural puncture with a white bore needle, but still the incidence is very less. I mean, that evidence is sufficient to clarify. Hello.
Madam, I think you muted yourself again, madam. Please check.
Not able to hear. There were a few incidences of paresthesia, but nothing afterwards. I mean, even the people who had done, they have reported very few incidences of paresthesia, but I just advised them to follow up the patient, and they said nothing happened.
Indrani madam, I think you are on mute. Can you just check if you are on mute? No, we can't hear you, madam.
Host can unmute.
Can you hear me now?
Yeah.
It's okay.
Go ahead. Yeah.
Okay.
Not getting your voice, madam.
You want to use or you want to use when do you select?
Not able to hear.
I think there's some no.
You are on mute. Indrani madam, you are on mute. Manisha, she is muted.
Yes, I know, sir. I'll speak to the webmaster.
Probably using a headphone will do, probably.
Her mic is muted.
Indrani madam, you have muted yourself. Can you unmute her? Can you unmute?
Can you hear me now?
Yes, ma'am.
Yes.
Thank you.
Yes.
What is your personal choice?
Again, yes.
When would you use isobarine and when would you use isobarine?
Not able to.
I think madam is asking the choice between isobaric and hyperbaric. Which one you use?
Yes. As I have already told you, isobaric drugs are usually preferred for laparoscopic and morbidly frail patients. When for open surgeries in male muscular patients, I usually prefer hyperbaric drugs, like the video I have shown for that intestinal obstruction patient. He was a male patient, and there was distension of abdomen, marked rigidity, and this thing. So relaxation might have been an issue with isobaric drugs. I preferred hyperbaric drug. So according to patient, you can choose your drugs.
Any other questions?
Sir, I want to ask one question. The additives that you are using in this segmental spinal, do you use one additive for spinal or do you use some combination of additives? Because I've read about people using
many people are
one
using
spinal,
but at present I am using only one at a time. I'm not very much comfortable with two additives because most of my cases are daycare surgeries and don't want to have mess around with post-op recovery. So I use only one according to need. I mean, if I want a longer duration of action, I prefer Dexmit in varying doses. With 10 micrograms, you can get duration up to more than 3 hours with just 2 to 2.5 ml of the drug.
I think there are no more questions.
There is one question. What is the commonest problem that you have faced with segmental spinal?
At mid-thoracic level, it is a bit difficult to find thecal space. So pyramidine approach is usually an easier thing to do. Otherwise, not much of an issue.
Thank you so much, Dr. Paliwal. That was a wonderful, practical way of giving anesthesia.
Thank you very much.
Especially as
I'm
you
very
rightly
much
said,
thankful to ISA Thane.
To the youngsters, it is an eye opener, definitely. And I would like to thank ISA Thane for inviting me, and thanks for the Pilgood and the beautiful lamp. Thank you very much.
Thank you, Indrani madam. On behalf of ISA Thane, I request Indrani madam to felicitate Dr. Paliwal with our e-bouquet. On behalf of ISA Thane, I would like to felicitate Indrani Madam. Thank you, Madam.
Thank you, Dr. Indrani Madam, Dr. Paliwar Sir, and Dr. Ketki for that really thrilling topic. I have done a few cases of segmental spinal with Dr. Paliwar's guidance, and it gives you a high which really lasts for a few days. So in indicated cases, I'm sure we've added one more kitty into our anesthesia armamentarium. So the next, maternal mortality is always distressing for the entire community. Why does it occur and how to prevent it? Let us find out from the expert, Dr. Sunil Pandya. To moderate this session, I called Dr. Shamini Iyer. Dr. Shamini Iyer is a very sought after anesthesiologist in Thane. She is attached to Bethany Hospital and is a very dependable anesthesiologist and friend. Dr. Shamini Iyer. Yes, Shamini, good evening.
Thank you. Now for the grand finale of I welcome Dr. Sunil, past president and senior anesthesiologist from Thane. Sir, for your talk.
Good evening, all. My screen and my audio is audible and visible.
Yeah.
Yes, sir.
Yes, sir.
Yeah, I thank the dignitaries of ISA Thane and dignitaries of ISA National for giving me the opportunity to be here in front of you on this August topic. Yes, I'm standing in between the conclusion and the last part of the day so that you can have a pleasant evening. I'll try to complete before the stipulated time. So coming to the topic of today's discussion, why mothers die, I have just modified a little one in the perioperative, which makes it more relevant for anesthesiologists. And how do we manage and how do we prevent this mortality? Nil conflict of interest. All the cases that I have presented in this presentation is our institute cases, and they have been obtained with permission, and so also are the photographs. If just reviewing the maternal mortality rate of our country, we are still staggering high at around 113 per 1 lakh live births. But fortunately, some states are doing excellent, especially the South, where we have come to the sustainable goal of less than 40 per by 2025. But still, if you look at certain states like Assam, Northeast, and Bihar, we are still at staggering 200 plus maternal mortality. And if you look at the common cause of maternal mortality in our country are still hemorrhage, sepsis, and hypertensive disorders. So if we can contain these three entities, which are very much possible by our skills and our knowledge sets, we can bring down the maternal mortality rate in the perioperative period to less than 30 per 1 lakh maternities. Unfortunately, all this happen in otherwise fit individuals who have no other comorbidities other than pregnancy. If you look at the summary of WHO in 2021, well, every almost 33 women die every minute globally, which is very, very high. And 94% of all maternal deaths occur in low and middle income countries like ours. And importantly, skilled care before, during, and after childbirth are the issues that are responsible. So if we can provide these issues, which most of our, at least 80% of obstetric care happens in small nursing homes and public hospitals. Most of the private hospitals, and yes, remaining happen in the public hospital. But if we can take care, we can bring down the MMR. Even if you look at the maternal mortality rate in the United Kingdom, which is the developed nation, this is the MMR UK Embrace audit, where is the mothers and babies risk reducing through audits and confidential inquiries. Fortunately, and even if you look at anesthesia is the lowest amongst the cause of maternal mortality, which we have done by continuous excellent perioperative safety, which Dr. Paliwal addressed earlier, and we have been addressing this since morning today by our various safety mechanism. Being an anesthesiology is equivalent to safety, I would say. And we always think about patient safety, hospital safety, and our individual safety as well. So anesthesia, fortunately, is the lowest amongst the cause of metal mortality. Like in the UK, cardiac diseases, neurological disorders, and embolic disorders are the leading cause of metal mortality. And if you see over the years from 1985 till 2015, there's only one maternal death per 1 lakh live maternities. How about mortality data from our own country? Confidential review of maternal death inquiries was started in Kerala in the year 2007, if I remember, by Dr. Paili, the Kerala Federation of Obstetrics Society president. And I was reviewing the data in the recent past. These are the trends of maternal mortality in a tertiary care hospital in Kerala. If you look at the cause of maternal death in India, that this is the only authentic source which I could get it from Dr. Paili. And if you see, there are no anesthetic causes of maternal death, fortunately. And this is what I want to emphasize, that anesthesia has become of great excellent, has an excellent safety record. And most of the patients, if at all they die perioperatively, it is because of other comorbid condition. But with the additional skills of resuscitation and little critical care, we can navigate safely and transfer them to a safe center. So if you look at the major cause of maternal mortality today in the perioperative period or peripartum period, I would say, are still major obstetric hemorrhage, hypertensive disorders, unrecognized sepsis coming in for surgery like emergency or cesarean or elective cesarean section, occult cardiac causes, anaphylaxis, which is not in our hands, and anesthesia in this order actually. So let us discuss one by one. And as I said, each of this entity have taken my institute cases so that to make it a little more elaborate. And these are the data of our ICU admissions at Fernandez Hospital. If you recall, some of you, we started the first obstetric critical care way back in 1998, and we do every year stringent clinical audits. And there's a 2020 data where the commonest cause of ICU admission at Fernandez is hypertensive disorders followed by hemorrhage and subsequently other causes. So when we reviewed the maternal mortality in the country, we compare in major obstetric hemorrhage. More importantly, the commonest cause or the cause of maternal mortality was unrecognized placenta percutata spectrum, or recognized cases operated boldly in a small nursing home ending up with problem, or when hemorrhage was complicated with help or underlying medical comorbidities. And importantly, most of us are aware of 4 T's like tone, trauma, tissue, and thrombus. But what we have done is we have added with the 5th T. 5th T is transfer the patient to theater early so that you can give better resuscitation, you have better skills, you have better infrastructure in the OT, and you can call for help early, because most of the time when the patient is in the labor room, the light is inadequate, there is only one helper and the one nurse, and the humongous. And importantly, lack of massive transfusion protocol and availability of blood. I must tell you that at Fernandez Hospital, last 25 years, we don't have a blood bank. But we tackle at least about 27 to 30 placenta percutata cases every year, and almost on an average about 7 to 8 massive hemorrhage every month. And so far, touch wood, 0 mortality so far. But what I mean to say is, we don't have a blood bank, but we have a transfusion protocol. We have liaison with adjacent blood banks, where as a hospital, they have deposited money in some of the blood banks so that in terms of crisis, they don't ask for donors, they don't ask for money, they just issue the blood, how much ever we want. And that is what we have done from our side in order to salvage the patient. So the massive hemorrhage protocol is wide bore venous access, call for expert early crystal resuscitation, do not delay, keep the patient warm. We need to know when to stop crystal resuscitation, do not allow hemoglobin to fall to critical levels. In obstetrics, the critical level of HB is about 5.8 grams per deciliter. That means the critical point is the point wherein the anaerobic metabolism starts, aerobic metabolism shuts down. That means the lactate production increases, metabolic acidosis ensues. So crystal resuscitation should be limited to not more than 3 to 4 liters in a patient with hemoglobin of more than 10 grams. If the hemoglobin is less than 10 grams, then the crystal resuscitation, the target should be less than 2 liters, and you need to have blood and blood components early. When the patient ends up with massive obstetric hemorrhage, that is, a patient has lost more than 40% of blood volume, the ratio or the component therapy that we recommend and most of the literature recommend is 1:1:1:1. That is, packed cells, FFPs, cryos, and platelets have to be given in that ratio so that we can minimize coagulopathy. Because when the patient bleeds, coagulopathy happens very early. And this coagulopathy happens because of hypothermia, because of hemodilution, because of dilution, major hypocalcemia, and several other underlying comorbid, underlying pathology like HELLP syndrome or AFLP or any of those bleeding diathesis. So there are multiple causes of coagulopathy, and we need to prevent it. And unless we give coagulation factors early, we end up with, or if you give only packed cells, we end up with losing more blood. And whenever the patient loses more than 30% of blood volume, do not delay in giving tranexamic acid, because in order to ensure microvascular hemostasis, tranexamic acid, a dose of 15 milligrams per kg and repeat dose of within 30 minutes, 2 doses suffices. You don't have to give the third dose. And fibrinogen. This is one entity which needs frequent monitoring during major obstetric hemorrhage, because we know that for a good and stable clot formation, a fibrinogen level of at least 250 milligrams is what is required. We know that pregnancy is a hyperfibrinogenemic state, and in a non-pregnant woman, you can accept fibrinogen levels up to 120 to 130 milligrams percent. But in pregnancy, 220 to 250 milligrams is what we desire for a stable clot. If the fibrinogen levels are less than 100, clot formation will not be there, and you end up with microvascular, suboptimal microvascular hemostasis and more oozing and more blood loss. One monitoring, if you ask me, RTLN monitoring. If patient does not require central venous pressure, you just need wide bore venous access, 16 gauge, 14 gauge, or 216, or 218 and 116, or whatever combination you want. But you need to see that you can push at least 1 liter every 3 to 4 minutes. That should be the rapidity, because we know that a gravid uterus, a term gravid uterus, receives almost about 25% of blood volume towards the term, and it just requires 5 to 7 minutes of atonicity for the mother to get exsanguinated. So in 5 to 7 minutes, the mother can get exsanguinated, and if you want to monitor her closely, arterial blood pressure monitoring is what is required. So in high risk cases, put an arterial line, do not transduce it. But if the patient starts bleeding, connect a transducer so that you can have beat-to-beat monitoring. Because when the patient bleeds, when the patient goes into shock, it is difficult to secure arterial line as well. So when you have a patient like a placenta previa or a Creta spectrum or a major obstacle like polyhydramnios or multifatal pregnancies or HELLP syndrome, put an arterial line. You need not transduce it, but transduce once the patient starts bleeding. And our experience is placenta eccrita spectrum requires a multidisciplinary team and specialized centers. Like you may require oncosurgeon, vascular surgeon, urologist, availability of massive transfusion, and sometimes they end up with interventional radiology like embolization and other things. So if you have to encounter this case and if you don't have these facilities, you may have a competent hand. You may have an expert anesthesiologist or an expert obstetrician who can tackle these things. But if the infrastructure does not support, better to transfer to a higher center and ensure the patient safety. You can operate the patient there with the multidisciplinary team. And this is what the thing. And I believe me, when the patient bleeds, they bleed like hell. This was the blood loss in just about 12 minutes. Almost patient lost almost about 12 liters of blood in 12 minutes. And we need to have that capacity to transfuse. And that is where the major obstetric hemorrhage protocol helps. I have seen a ruptured aortic aneurysm and atonic PPH. And believe me, atonic PPH requires much more skills than ruptured aortic aneurysm, because for you to tackle ruptured aortic aneurysm, you just have to put a tube and line. Whereas here you need to put the tube, the lines, and the lights, and the blood, and everything, because there you have a cardiac center, you have a cardiologist, you can put a clamp on the aorta boldly. Here we don't have a vascular clamp in the theater, and all this inadequacies will be there, and we need to keep this in mind. So as I said, do not allow hemoglobin to fall to critical levels, that is less than 5.8 grams in a pregnant patient. Liaison with the blood bank service, as I said, And this is what I said. This is a point of care hemoglobin check. In this patient, the blood had hemoglobin had fallen to 2.6 grams, but we could rapidly give and bring it up to 8 grams. When you are giving massive transfusion, one of the important step is prevent lethal quad. Lethal quad, earlier we used to say lethal triad, hypothermia, coagulopathy, and metabolic acidosis, but we now call it as, we have also included hypocalcemia, because whenever you're giving massive transfusion, like when I say massive transfusion, more than 4 units in less than 2 hours, or when the patient requires more than 200 ml of blood for 4 hours, or when the patient requires complete blood volume in 24 hours. Multiple definitions are there. So hypocalcemia is common. So we need to see that we need to prevent lethal quad. The fourth quad is hypocalcemia. So prevention of acidemia, that is prompt crystalline resuscitation, endpoints of crystalline resuscitation, beginning of blood and blood sanguineous blood and blood component therapy, prevention of hypothermia using blood warmers, fluid warmers, body warmers, convection warmers, prevention of coagulopathy, and prevention of hypocalcemia. So all these things are very important, and this can happen only when you have regular drills, so that there is a coordination. Because when you want to give, when I say when the patient bleeds 12 liters to 13 liters, or sometimes 20-25 liters in less than 2 to 3 hours, you end up giving 40 to 50 units of blood and blood component therapy. And in order to produce 40 to 50 units of blood in 4 to 6 hours, you need to have a proper protocol. So to summarize, I would say that blood is a fluid organ. Use it judiciously and appropriately. Beware that too much of transfusion, too little of transfusion, too late transfusions are the eternal perils, and we need to minimize them. And hemovigilance policy is the need of the hour. Hemovigilance policy is nothing but tracking for the adverse events right from the point of donation till the point of transfusion. So this is one of the major things that is coming up in even the developed nations, and hemovigilance policy should be adopted universally in all the blood banks. And as I said, minimize transfusion-related complications like transfusion transmitted sepsis, so on and so forth. So when you're using judiciously, most of the things can be minimized. And post massive transfusion, we have a protocol of following these patients for at least up to 6 months, so that if at all any long-term like viral diseases or any of those things, we can track them and treat them appropriately. So that was in brief about the commonest causes and prevention of major obstetric, tackling major obstetric hemorrhage. The next amongst the dreaded disorders, which is one of the commonest medical disorders affecting pregnancy, is hypertensive disorder spectrum. And in this hypertensive disorder spectrum, you have preeclampsia without complication to severe preeclampsia with thrombocytopenia or acute kidney injury or hypertensive crisis of pulmonary edema to patient with HELLP syndrome. We also have included acute fatty liver of pregnancy in this hypertensive disorder spectrum. Some of the gastroenterologists have included AFLP as a part of hypertensive disorders because of the overlap syndrome. And importantly, hypertensive cardiomyopathy also is there. So there's a wide range of spectrum where we have asymptomatic patient to major symptoms with almost life-threatening complications. And as I said, again, our own audit, these are the leading cause of maternal death and even the ICU admissions. And when we talk about hypertensive spectrum, as I said, we have to tackle all this entity effectively, and we need to know the knowledge sets and the skill sets to handle them carefully. Because if you look at simple entity like HELLP syndrome, there are so many mimickers. Sepsis can mimic HELLP syndrome. Thrombotic thrombocytopenic purpura can mimic HELLP syndrome. HUS can mimic HELLP syndrome. AFLP can mimic HELLP syndrome. So you need to be a good physician, a good clinician to differentiate, okay, this is HELLP syndrome, this is AFLP, this looks like HUS, this looks like thrombotic thrombocytopenic purpura. I don't want to go into the details, but I can take questions, but we need to have a good physician. And similarly, not all seizures that happen in the peripartum period eclampsia, but unless and until otherwise, any seizure happening in pregnancy should be considered and treated as eclampsia. So if you look at, there is a subtle difference. Not all seizures are eclampsia. That means we need to always work out, if it is a typical seizure, then always have a low threshold for radio imaging so that you don't miss out any asymptomatic space occupying lesions or intracranial bleeds or press syndromes which can happen, or subduct hemorrhage is the commonest cause of maternal mortality and hypertensive disorders. So you need to be a good perioperative physician to tackle this. Again, if you look at the common cause of maternal mortality, suboptimal workup. As I said, 70% of HELLP syndrome are biochemical derangements. They don't have hematuria, they don't have bleeding gums, they don't have any of those petechial rashes or purpuric spots, but they have deranged LDH, deranged SGOT, deranged SGPT, deranged low platelets. So unless you do a preeclampsia profile, you may not pick up 70% of low-grade HELLP syndrome, where the spontaneous termination of pregnancy if you do. Otherwise, if you just wait and sit on the patient, then they can go for full-blown multi-organ dysfunction syndrome. Importantly, lack of insight into the gravity of clinical problems. As I said, thrombocytopenia of 90,000, 94,000 sometimes may underplay, but sometimes they can have a fulminant progress. And there is often delay in calling for help, because most of these patients with HELLP syndrome, if at all they progress to drastic fulminant multi-organ dysfunction syndrome, they require expert hand, because a small chunk of movement, they end up with atonic PPH and peripartum hysterectomy also. And in inappropriate anesthesia technique, and I say inappropriate anesthesia technique, hypertensive crisis, BP of 220 by 120, conventionally we are taught that regional is not safe, and we go for GA, and giving GA in parturiente with uncontrolled blood pressure can cause exacerbation of cerebral edema and delayed recoveries, and you try to give premature reversal, and patient ends up with pulmonary edema and multiple problems. So as regional anesthesia technique is safe, provided you know how to navigate in a territory which is in the gray area. Like Dr. Indrani Hemant Kumar mentioned, that it's giving thoracic segmental spinal is unsafe technique, considering that you may injure spinal cord. Similarly, giving spinal anesthesia, even lumbar spinal anesthesia in a parturiente with fallen platelets or borderline coagulopathy is not a safe technique. But we know, if you know when it is safe, when it is unsafe, then you can be really, you provide a good safe anesthesia technique. And for the cutoff in our hospital is about, I would say 50,000 to 70,000, but in the hands of junior it's 70,000. But if the person is senior and the experienced person, we go up to 50, 55,000 also, if the airway is going to be difficult, which in parturiente with hypertension, most of them, they have mucosal edema and they have difficult airway as well. And so optimal airway management skills, because most of these patients, if at all spinal fails, or if you have to give GI with fulminant HELLP syndrome, it's going to be a difficult airway. So coming to this small case, I thought I will intersperse my discussion with cases. This was a very interesting case. Second gravid at 34 weeks gestational age with high blood pressure, gets admitted to HDU at around 4 p.m. We sent preeclampsia profile, which is normal, and steroid cover for fetal lung measure is initiated, and she was put on minimal dose of labetalol and shifted to ward. At 8 p.m., she was reviewed by the consultant before end of the day, and she was advised repeat preeclampsia profile at 6 a.m., which we generally have whenever we get a fresh case, we trend the parameters every 12th hourly, and once we establish stability, then we monitor them every 48 to 72 hours, so that we know the trend and subsequently take a call for terminating the pregnancy. Unfortunately, at 11 p.m., she complained of severe epigastric pain, tossing in the bed, was shifted to ICU because of severe pain, could not be managed in the ward. Fentanyl was given. She is not in labor. CTG, she was not allowing for the CTG to be kept. Preeclampsia profile was sent. And if you see, within just 6 hours, like 4 p.m. to 11 p.m., hemoglobin, the platelet fell to 82,000. And AST, ALTs, which are normal, rose to thousands, like it was in 70s earlier. And within 8 hours, it has gone up to thousands. Creatinine has raised, potassium is raised. Basically, it's nothing but fulminant hemolysis with hyperkalemia and multi-organ dysfunction syndrome. And severe epigastric pain, we have a protocol of sending lipase is in thousands. That means she has an element of affecting pancreas. Whenever the pancreas got affected as a part of multi-organ dysfunction syndrome in HELP or AFLP, it just indicates the organ damage is very severe, and they require long-term organ supports, sometimes days and sometimes weeks, and sometimes they may have a bilateral cortical necrosis ending up with renal transplantation. So we have a protocol. Whenever the patient has fulminant presentation, we get a basal lipase, so that involvement of pancreas is a good prognostic marker in terms of organ support. And APG showed me severe metabolic acidosis. The point which I want to emphasize is, within 8 hours, this patient went into severe preeclamptic angina. And if you see, the color which was normal became hematuria and became black within 6 to 8 hours. So this is what a HELP syndrome can turn into. And unless you have a trending parameters, like generally, as I said, initially, we depending on the present, because this present only with 160 to 110, had she had any additional symptoms, we would have made it 6th hourly para monitoring. We thought 12th hourly will monitor, but within 6 hours, she deteriorated rapidly with petechiae all around. Bottom line, we did a cesarean section, but she ended up with multi-organ dysfunction syndrome, requiring multi-organ supports, renal replacement therapy, tracheostomy, ICU stay for almost 22 days. She was requiring mechanical ventilation for almost 20 days. Fortunately, she recovered completely. So this case just illustrates that how fulminant hypertensive disorders, which is 160, 110, can become. And this is where, if we don't manage appropriately, we may lose this patient and with metal mortality. Other thing which I want to emphasize is blood gases role. Role of ABG is of paramount importance in patients with severe hypertensive disorders or hypertensive disorders. So whenever a hypertensive participant has metabolic acidosis, it is one of the earliest indicator to terminate the pregnancy, before the platelet falls, before the enzymes rise, before the LDH rises. And believe me, this is one of the best marker I have found. And being an anesthesiologist taking care of ICUs, we found it a very easy arterial punch to do arterial puncture and do this analysis. If the ABG is normal, you can always wait. We can always wait, unless, of course, other parameters are deranged. But what we have noticed is when the kidneys are getting affected, when the patient going into renal shutdown, acidosis appears very, very early. This was a case who came with BP of 170, 110, and with breathlessness and with pulmonary edema. And if you look at ABG, she was having mild hypoxemia, like moderate hypoxemia, with severe metabolic acidosis, pH of 7.0. This patient comes on the 5th December at 22:05, that is like 5 on the 4th December. And these are the parameters. We optimize her and we terminate the pregnancy in the night at around 11:30 p.m. We did a cesarean section. And next day morning, if you see at 6:20 a.m. on 5th December, 4th December, 5th December, pH becomes 7.3, PCO2 is normal, PO2 is normalizes, base deficit is corrected, like base deficit from -20 has come to -7. The point I want to emphasize is how the utility of blood gas, and believe me, this is just one, we have several hundreds of such cases where blood gases have been a boon for us, which have helped us in taking a decision to terminate the pregnancy. Had we waited till next day morning, ended up with acute kidney injury, and she recovered very promptly. So blood gases are of tremendous help in patients with hypertensive disorders. If they are normal, we can wait. If they are acidotic, then the base deficit is more than -10, it's indication that we take a call to terminate the pregnancy, unless you are giving steroids for fetal lung maturity and you keep doing ABGs every 4 to 6 hours. It's a progressive acidosis. Take a call to terminate the pregnancy. This was one of case which I don't forget even to this date. This happened in the year 2013. This patient was a case of medical tourism, came from Middle East for safe confinement, hypertensive, obese with high BMI, started on labetalol, steroids were initiated. BP was stable, and she was shifted to ward on day 2 and day 3 was fantastic. She was absolutely normal. ABG was within normal limits. CTGs are fine. Attendance are requested cesarean section. But because CTG is fine, steroids were giving for fetal maturity. We said we'll just wait for a week because she was just about 33 weeks. We'll wait for one more week if possible, and reassured. And we thought we'll plan induction of labor after steroid cover. And this was initially like she came on Thursday, Friday, Saturday, Sunday evening was the induction of labor, so that by Monday we could deliver. Unfortunately, on Sunday morning, BP went up to 190, 110. She was kept NBM. PAC review was done. Acid aspiration prophylaxis was given. And we thought we'll give her spinal if the platelet count is more than 75,000. Airway was fairly okay, except Malampati grade 3. Preeclampsia profile was normal. ABG was mild metabolic acidosis, like -8. Otherwise, nothing much. And category 2 section was planned. She was transferred to theater at 8:30. BP was 160, 110. Platelet came as 1.2. AST, ALTs were borderline. Cockpit check of machine and monitor were connected. SPO was 96. Patient was made to sit and back was being painted by the anesthesiologist, which already has explained about spinal. Unfortunately, while the back was being painted, she complained of tightness in the chest. arched her back and became severely breathless. She went into florid pulmonary edema, not able to lie down on the table. SpO2 ECG, she just threw away the pulse oximeter probe, then pulled out the ECG because of restlessness, and she became like ECG showed asystole. Initially, we thought it was leads had come out, but because the anesthesiologist was there, obstetrician was there, ACLS was immediately initiated, intubated, adrenaline was injected, and CPR was done, and perimortem cesarean delivery was done. Baby was delivered, good UPCAR score. ROSC was achieved immediately after delivery. But unfortunately, post-delivery, she rearrested twice because of atonic PPH, but revived within 2 to 3 minutes. Unfortunately, went into severe ARDS, recovered from that, but landed with permanent vegetative state. And she succumbed after 3 months. Again, the point which I want to convey is severe preeclampsia, hypertensive crisis, like she subsequently borderline HELP syndrome, maternal cardiac arrest, ROSC was achieved, rearrest, and she ended up with permanent vegetative state. What if all this would have been happened just a minute later? That means had we given spinal and had this episode happen, anesthesia would have been attributed. Again, the point which I want to emphasize is we are not gods, we are humans. Despite best of the efforts, sometimes we'll end up with these issues. But yes, because anesthesiologist was quick in responses, we could at least get. But the cause of rearrest situation, I may discuss in a later other forum. It was because of oxytocin infusion you given for atonic PPH in a depressed heart, which was just recovered from ROSC, and that led to repeat cardiac arrest, which we'll discuss later on. But the point which I want to emphasize is mild preeclampsia or preeclampsia without complications ending up with severe cardiac arrest and metal hyper this thing. So hypertensive disorders is a eternal puzzle, and it is important as a clinician we need to solve, because we can end up with any of these entities, and we need to have the wherewithal to tackle without any issues with a safe navigation. So that was in brief about the commonest cause, the second commonest cause of metal mortality, that is hypertensive spectrum, and how we should have the wherewithal to minimize mortality because that might occur in the perioperative period. The next common thing that we encounter in practice is unrecognized sepsis. And when we talk of sepsis in obstetrics, it is mostly the pelvic sepsis, either urinary tract infection, urosepsis, or chorioamnionitis, or gram-negative sepsis, group B streptococcal sepsis, pneumonia, or any surgical cause or other non-pregnant causes, which are commonest causes. Again, when it comes to unrecognized sepsis, lack of insight, lack of protocols, poor antibiotic policies. As an anesthesiologist, I must admit that most of our colleagues, initially when they complete fresh MDs and DNBs, the antibiotic policies, they are very much aware about the high-end antibiotics, but proper antibiotic protocol and policies, they are not very wise, and we need to educate them. And importantly, don't anticipate and you end up with morbidity and mortality. And third delays. Third delays is once the patient goes to tertiary referral center where you have all facilities, still there is a delay in seeing patient being seen by specialists, because most of the tertiary care hospitals, obstetric ICU is not a busy ICU, or they get admitted to a multidisciplinary medical ICU, and you may not have obstetric intensivist there who knows the gravity of situation or who can sense the urgency or the emergency. This was one of the case that we have had again in probably 2014 or 2015. 26-year-old third gravida P2L2 pre-S1 cesarean section comes in labor, 37 weeks with prompt premature rupture of membrane of more than 12 hours duration. As a protocol, we sent high vaginal swab and TLCs, which are normal. PAC is unremarkable, and we counsel for spinal as a plan A, and plan B was general anesthesia. And fortunately, we don't use Quinky needles in our center. We use Vitacare at the 25, 27, or 29. I have a habit of using 29 most of the occasions. Because I know in full spinal, we generally use hyperbaric bupivacaine with fentanyl combination. Prophylactic phenylephrine is the procedure of choice to prevent hypertension rather than treating hypertension, and colored patient was detected. She needed 400 micrograms of phenylephrine and 30 milligrams of ephedrine. Generally, a patient who has received spinal, hardly when you give 10 milligrams of bupivacaine, they may just end up with 6 milligrams of ephedrine, or about 50 mics or 100 mics of phenylephrine. So when the patient needs more than 400 mics or more than 200 mics of phenylephrine and more than 15 milligrams of ephedrine, we need to suspect additional cause of hypotension. Is it just the spinal related thing, or something else. Surgery was just started, oxytocin was still not on, so to have another factor. So we just kept our antennas open. But subsequently we realized that patient was requiring a lot of fluid and she was a little warm. So hypotension and anesthesia, we activated our algorithm. I'll touch upon this algorithm a little later. And subsequently, we did procalcitonin, we sent blood cultures and everything. And we initiated the survival sepsis protocol guideline. And cultures grew, E. coli, which came 48 hours later, but PCT was very high, which came in 6 hours. We sent as a routine neonatal blood cultures also. And generally, when we suspect sepsis, chorioamnionitis is the commonest cause, so we sent cultures from the placental bed also, cotyledon from the placenta, and everything grew E. coli. So it was a pure case of E. coli. And the point again, which I want to emphasize is just proactive approach. We just realized we got a patient stabilized after this, after giving so much of vasopressor, she stabilized. We got just ignored her, but she would have deteriorated in the postoperative period and ended up with multi-organ dysfunction syndrome. So by proactive approach, we proactively treated, escalated the antibiotics, escalated the fluid management, and just with a high index of suspicion, we prevented morbidity and mortality, probable mortality. So the point which I want to emphasize is sepsis is innocuous. It has a subtle presentation. A warm patient with hypotension is a sepsis patient. A warm, cold patient with hypertension is a case of hemorrhage, thumb rules. So basically have a low threshold for workup, especially the procalcitonin cultures. Cultures may take time, but procalcitonin other things may come up a little early. Other common cause of metal mortality is unrecognized cardiac cases. You must have often heard that spinal diya, patient developed hypertension, cardiac arrest हुआ नहीं, बाद में पता चला PPCM था. Well, these things are very common, and many times we ask, is echo is mandatory before all cesarean section, elective cesarean section? So these questions, they crop up in every forums that we present this case. But yes, occult cardiac diseases are the common one of the common entity that we that goes undetected. And patients who have moderate underlying moderate disease like moderate to severe MS. If the patient has critical MS or very severe MS or severe aortic stenosis or any of the structural heart diseases, they present in the first trimester. We need to know the underlying physiological changes in pregnancy. If you look at, we know that pregnancy is a stage of hypervolemia. The plasma blood volume increases, the RBC volume increases, and there is a fall in hemoglobin, there is a fall in systemic vascular resistance. And we have seen that there are 3 peaks that happen in reduction, increase in cardiac output. The first peak happens in around 16 weeks, where the quickening occurs. That means the mother perceives the fetal movement first around 16 weeks of gestation, and that's when the first peak of cardiac output occurs. The second peak occurs around 28 to 32 weeks of gestation, where the cardiac output almost doubles. It goes up to 10 liters. And the third peak of cardiac output increase happens immediate postpartum, where the uterus retracts and contracts, and there is the autotransfusion, and sudden 2 liters volume is added to the metal compartment. So these are the 3 peaks. The mother can become symptomatic. So if the mother is already having a pre-existing severe cardiac diseases, and if she conceives, she is likely to become symptomatic in the around 16 weeks of gestation. And if the patient complains of wheezing or respiratory tract infection around 14 to 16 weeks, it's always put a stethoscope on the chest. You may discover a murmur or hear a murmur, or at least get an echo done. Or if you miss out this period, the second peak of cardiac output around 20 to 32 weeks. And that's where the second peak occurs. And you still have optimization till around another 4 to 6 weeks of medical optimization. And first peak ke baad, you can have a time to do any intervention. If at all the mother has any critical AS or MS, you can do any balloon commissurotomies or any of those things. So the bottom line is peripartum cardiomyopathies are undetected. They may have like mild breathlessness, mild pedal edema, which are symptoms. So as I don't want to elaborate much, but as a obstetric physician or obstetric intensivist, we need to know what is physiological symptom, what is pathological symptom, and what is pathognomonic symptom. PND is not physiological. PND is always, like paroxysmal nocturnal dystonia, is always pathological, and you cannot. You need to have a very clarity on this thing. So we need to know what is vague symptom, what is a classical heart symptom, and if you have this subtle sense of physician acumen, you can often detect most of the cardiac diseases. This was again a beautiful case which we had in our practice. 27-year-old booked early. She was for elective cesarean section. PAC was done by my senior colleague. unremarkable, except previous pregnancy. She had early onset severe preeclampsia with intermittent fetal demise. She was induced and delivered vaginally at Fernandez Hospital. Otherwise, no other issues. Second pregnancy was absolutely normal, regular ANCs, no issues. We planned LSAs under combined spinal epidural anesthesia. It was uneventful, single pass procedure. I was the person who has anesthetized. And if you see post anesthesia, she started having bigeminy. I thought probably sometimes ventricular bigeminy is not uncommon in pregnancy, but within just 30 seconds, she had a run of ventricular tachycardia. Or initially we thought it was SVT, but I got a defib in the hospital. I mean, in the theater. I told surgeon to start surgery quickly. Um, uh, Basically, we stabilized the patient with amiodarone bolus and subsequently maintenance dose, started noradrenaline and dobutamine infusion, reviewed PAC, again review PAC and antenatal chart again just to see whether we have missed anything. It was unremarkable. Escalated the heart, there were no murmurs. But however, we know that spinal anesthesia does not cause VT. That is one basic thing. So we managed this as a cardiac case. We delivered the child with good Apgar, and we managed as a cardiac case. When I say we managed a case as a cardiac case, we need to ensure that heart rate, rhythm, contractility, period of float are optimized. So these are the 5 parameters, the pentad or the Pancharatna to manage cardiac parturient. Maintain stable heart rate, maintain stable rhythm, maintain good contractility. So dobutamine was given for contractility, period optimization by reducing unnecessary fluids. And we put this patient in Iraq, and as expected, we did an echo post-operatively, turned out to be peripartum cardiomyopathy with EF of 30%. Till we got the echo done, obstetrician was convinced that this case is all these incidents have happened because of spinal. After that, I said spinal will not cause BTAC or Bigemines unless there's a profound hypertension. Again, there is a cause for profound hypertension, something else which are missing. So unless until put otherwise, always think that whenever the patient has major hemodynamic perturbation intraoperatively, it is not because of anesthetic, it is because of underlying occult pathology, either sepsis or hemorrhage or cardiac disease or any other cause. So had it been after delivery, hemorrhage would have been one of the differential diagnoses. Or had it been, it could have been anaphylaxis presenting as hypotension. So there are multiple causes. We need to have an algorithmic approach. So basically, what I want to say is whenever we need to have any of those things, we need to have a high index of suspicion. And we need to have a subtle clinician angle of differentiating between what is physiological and pathological and pathognomonic, and heart sounds and low threshold for echo. And DVD prophylaxis, they require for a little longer duration. Anaphylaxis, again, is relatively uncommon cause, but we do encounter anaphylaxis. And they say neuromuscular blocking agents are the commonest cause of anaphylaxis in the perioperative period and peripartum period. I must tell you that antibiotics are the most common culprit. And I have seen last 25 years, only one case of atrocurium causing anaphylaxis of at least more than 25, 30 cases of anaphylaxis, which I've encountered. Only one case of attributed to muscle relaxation, a muscle relaxant, but majority of them were because of antibiotic or some other cases. So that is one thing that you have to keep in common. Anaphylaxis can happen anywhere, any patient, anytime, even though they don't have any known allergies. And we all know the anaphylaxis protocol: adrenaline is the drug of choice. AVIL has no role in the acute period, but hydrocortisone, yes, up to 100 to 500 milligrams of hydrocortisone can help. And ABC's early intubation is the key, because sometimes they end up with massive edema and you may not be able to intubate these patients. Early intubation is the key. Early adrenaline is the key. And protocolized management, you can prevent mortality. Coming to the most important cause of perioperative period, fortunately, it is on the vein, anesthesia-related causes. They are the least common cause of developed nation. In our cases, when I discuss and when I discuss with our colleagues in federal program, yes, it does occur in some cases. Just about 2 months back, one of our fraternity colleague happened to give anesthesia to a lady for cesarean section in Old City. After spinal, she developed bradycardia, hypotension, and he gave ephedrine and mefentermine, and patient couldn't make it, intubated, resuscitated, couldn't make it, and shifted the patient to our hospital. Patient was brought dead. The point I want to emphasize is algorithm was not activated. Why this patient developed hypotension? Why this patient developed bradycardia? And just putting intubation and CPR doesn't suffice. We need to go beyond that. and that is where we lack. And we know that these are the common causes of perioperative major hemodynamic perturbations, hemorrhage, embolism, PIH, infections, cardiomyopathy, and anesthesia, which we have discussed most of the time. And worldwide, if you look at the ESA closed claim analysis, the commonest cause of maternal death is because of the litigation is again brain death because of esophageal intubation or delay in intubation or delay in securing a proper airway. So airway mishaps because of improper technique of intubation, and this was very well elucidated by Dr. Divatia earlier in the day. So we need to have this algorithm ingrained in our brain imprinted. So it is very difficult to remember most of the things, but it is always better to have cognitive aids in our theaters. As I think one of the speaker, I remember, I think Dr. Bhalabhaskar, on the perioperative fasting guidelines, the moderator advised to put the charts in the theater, in the surgeon's rooms. So similarly, we can put these cognitive aids of difficult airway algorithm, step 1, step 2, step 3, so that you keep revising daily basis, so there is no ambiguity, and you can minimize this airway mishaps, minimize delayed recognition of misplaced GTT and aspiration. So if you look at the cause of anesthetic cause of maternal deaths, 3.5% in lower and middle income countries, almost 1.2 per thousand obstetric anesthetics, which are very, very high. These are in lower and middle income countries, 1.2 per thousand obstetric anesthetic, OB anesthetics that the mother receive. And cesarean section is, most of them are because of cesarean section, that is you end up giving a general anesthesia or spinal anesthesia with high spinals. And general anesthesia is 3 times more common than RA. And this is the most important, 10-fold higher in rural versus urban setting. That means suboptimal setup, suboptimal infrastructure, suboptimal skills, suboptimal knowledge sets are all responsible. And if you look at the case fatality rate, this was in the US, 6.5 million per OB anesthetics and 3.8 million. So general anesthesia is much more dangerous for mishaps compared to regional anesthesia. And of the 124 patients studied, 45% of airway complications because of failed intubation, 31% of aspiration, 27% of staff incompetency, monitoring issues, equipment failure, and 6% were high spinal. So high spinals should be tackled. There should be zero mortality. Competency level should be on a continuous rise. Even at the age of I'm 55, we need to upgrade our skill sets continuously, because I don't do that many procedures today that I was doing in my younger years. So if I do, I end up with a problem case. And when you are handling a problem case, your skill levels are required are still very high. So you need to maintain your skill sets appropriately. And if you look at this, anesthetic complications, fortunately, are on the wane. And this is what the CRMD, like Kerala, I'll come back to this thing. Again, this is the data from India. This is the mortality data from India. And even in India, if you look at the cause of maternal mortality, anesthetics are fortunately on the lowest compared to all other obstetric causes. So we are doing good job, but we can always better ourselves, and we can always enhance the quality care that we provide to our young parturients, because not only we save the mother, but we also prevent an orphan in the country. So reviewing our data, our anesthesia-related mortality, more than 1.5 lakh anesthetics have been nil, fortunately. An oral survey from public hospitals where the delivery rate is more than 17,000 per annum. Direct causes, like about 8 cases died. And if you see, majority of the time, the problem occurs during GA, and often because of premature extubation, or when the mother requires elective ventilation, but because of lack of facility or infrastructure, you give double reversal, triple reversal, give calcium cocktail and all those things, and you hasten up extubation process, which should always be avoided. So fortunately, the government now is investing in ICU, building up ICUs in even district general hospitals, district level hospitals. So have a low threshold to ventilate the patient. If it doesn't matter if it's in the theater, but do not hasten up extubation when the patient is not fit for extubation. Regional anesthesia indirect cause most of the time is because the patient is with massive obstetric hemorrhage. You still continue under spinal, or sometimes you struggle with difficult airway if you start under spinal. So you need to have a very clear-cut algorithm. So if you look at the failed intubation. This is the data which form the basis for the Difficult Airway Society Guidelines UK. This was a paper published in 2015 with Kinsella and Mary Mushambi as the main authors. And if you see, the incidence of difficult airway was difficult intubation 1 in 390, and maternal mortality was 1 in 90 failed intubation. So after every 90 failed intubation, there was one maternal mortality. It's very high. And front of neck access was obtained in 3.4 of 1 lakh GS, and 1 in 60 failed intubations were, but it was a late rescue. So please upgrade your skills about cricothyrotomy on a regular basis on the animal model. What we train is the goat's trachea. And if at all unforeseen reasons, if any such thing happens, you have at least some skills. And believe me, last 25 years after the institution of radiolaryngoscope and laryngeal intubating LMA and procedure LMA, I have never used front of neck access as a rescue in pregnancy. Either it is a planned elective fiber optic intubation or LMA was successful as a rescue mechanism. But front of neck access as an emergency was not necessary, and we need to have this in mind. So always keep these beautiful devices in your armamentarium. They don't cost much. They are less than 2,000 rupees. A disposable intubating LMA, ProSeal LMA, intubating LMA. The number 3, number 4 is what you need to have for pregnant women, and see that the IDA guidelines and difficult airway guidelines are engraved in your brain, or you can put cognitive aids in your theater so that they form the ready reckoner. And whenever the anesthesia or mother dies under anesthesia or during surgery, it is not because of anesthesia alone. There are a lot of underlying comorbidities. And this is what was when the mothers who died under anesthesia were analyzed, obesity was one of the common thing, and pre-existing medical disorders like bleeding or hypertension or cardiac disease or so on and so forth. So see, there is no complacency in doing a primary or a proper PAC. Many a times we do PACs, the patient appears to be a grade 1 fit individual, and we end up with problems because they are great mimickers. Pregnant patients are great mimickers, and we need to have a proper PAC. So when you have, when I said obese, you need to have a proper armamentarium to tackle obese patients like HFNC. Fortunately, we have all these facilities in our hospital. But tackling obese patient is because it can be a complication for surgeon also, because like you may have PANUS and you may end up with NIV during surgery. Like this was the case where we gave combined smile epidural for cesarean section, but we ended up with like she was having baseline hypercapnia. When we did blood gas analysis, she was having obstructive sleep apnea because of obesity. Our baseline PaCO2 was high, and if you see, this was what the baseline CO2 was. So you need to have a planned extubation also. And as I said, more problems happen during extubation. So to conclude about anesthetic-related mortality, we certainly can eliminate, we cannot eliminate difficult GA, but we can eliminate improper or unsafe general anesthesia. So a safe regional anesthesia, yes, we can enhance the safety of regional anesthesia by proper guidelines, preventing medication errors. We have heard several cases of tranexamic acid being used, high spinal, total spinals. One of the things of tackling high spinal, total spinal is use adrenaline early. Do not rely on ephedrine and atropine if the patient has intense bradycardia. Use adrenaline early. All cases of high spinals where patient has intense bradycardia, use adrenaline 1 in 1,000, just 1 in 10,000, 1 to 2 cc, and you may end up with good outcome. And yes, you need to have a long length needles if you are tackling obese patients, but I can take questions as we are running out short of time. But more importantly, point which I want to emphasize is stat cesarean sections or category 1 cesarean sections, or giving GA after a failed spinal. That means your plan B is not activated in your brain, and that's where most of the mishaps happen. So if at all you have a failed spinal, or always have plan A and plan B, and see that in difficult cases you have plan C also. And before you start or any plan, there is no delay. So for stat cesarean sections, beware and be cool, because the decibel levels in the theater is very, very high. So this is what I was talking about, the algorithm for spinal hypotension. Whenever you have hypertension under anesthesia, You may have anesthetic causes, you may have surgical causes, you may have patient pathology, you may have miscellaneous causes. And as an anesthesiologist, we need to activate this algorithm. It could be simple spinal, or it can be exaggerated oxytocin response to spinal, or it may patient after delivery may start bleeding, exaggerating spinal effect, or they may have underlying cardiac diseases or sepsis underlying cause. So unless we activate the algorithmic approach, we may not end up. And this is one entity which I want to emphasize, because varicose veins, we don't look for it. But I remember a patient who went into almost near arrest situation following a combined spinal epidural. It was me again who was there. She almost patient after recovering from hypotension, sir, मेरे को यमराज दिख गया. Literally, she said, मेरे को यमराज दिख गया. And we had to inject adrenaline. And when I saw her later, when the nurse told me that, sir, she has large veins. And this is what we found. She was having huge varicose veins in both the limbs. So after giving spinal, there is extensive pooling of the blood, and the central compartment is literally hypovolemic. And this is what happens. So when the mother is having varicose veins, beware. So look at the antenatal chart, and as obstetrician of this entity, generally we tend to ignore this entity. But there's one case which I remember, because this ended with near arrest situation, and we could prevent aborted disaster. Or when the mother collapses in the perioperative period, again, same causes. It could be drugs, it could be antihypertensives, which exaggerates the effect of spinal, medication errors, pneumothorax, or other 4Ts which are happening in cardiac arrest. But the point which I want to emphasize is amniotic fluid embolism also can happen intraoperatively. And when the mother requires resuscitation, believe me, they require super aggressive resuscitation intraoperatively, to the extent that they may end up with 40-50 units of blood transfusions, noradrenaline support, ARDS, multi-organ failure, and we need to have aggressive multi-organ supportive strategies. And I'm glad to say that last 25 years, we've had 5 cases of amniotic fluid embolism. By exclusion, we have diagnosed these cases, and 80% survival rate. And this is one of the patient who was a primary gravida, came with abruption, and IUFD. Despite being a primary gravida with IUFD, we had to sacrifice the uterus. But 6th day she was discharged, or 7th day she was discharged home. So the last entity, maternal cardiac arrest and perimortem cesarean delivery. Yes, we need to know. We have several phases, almost 58% is survivability in our hospital. Is the couple, like mother had cardiac arrest, but at the end, both you can see the mother and the child survived. And we have these drills regularly conducted in our hospital. Every 4 to 6 months, we have this drill conducted where we teach the obstetrician basic airway management skills and basic CPR and perimortem cesarean section skills. And you can see the proud father and the child who had mother had perimortem cesarean delivery. So I would conclude that anesthetic or why mothers die, hypertension, hemorrhage, sepsis are still the commonest causes. Anesthesia, fortunately, is the rare. But we need to standardize the curriculum of anesthesia so that the skill sets and the knowledge sets are same during the MD or DNB training. Adequate exposure and guidance for complex cases is mandatory. Call for early help, equipment check, capnography is of paramount importance. Invasive monitors available, at least arterial line if you're not cardiac output monitor. Early transfer to higher centers. And major medical comorbidities, you need to have protocols in place like major obstetric hemorrhage, massive transfusion protocol, hypertensive management protocol, and you need to have safe GA airway algorithm, capnography, LMAs, high spinal, total spinal, early use of adrenaline, last ABCs, lipid emulsions, high risk cases, multidisciplinary team. A regular clinical audit is this is what we do every year. We have been doing last 25 years, and we know where we stand. And this is what the data of confidential inquiry is also. If you look at the anesthetic cause of maternal mortality in 1950s, were almost about second or third leading cause of maternal mortality. And over the years, they have become the least common cause of maternal mortality. So to conclude, I would say that anesthesia is a very safe specialty. We need to enhance the safety by our implementing our knowledge sets, skill sets, and have a physician in us awaken so that we can become a better perioperative physician and have standard protocols for handling common medical scenarios. Thank you very much for your kind attention. Any questions I can take?
Thank you, sir. It's very heartening to know that anesthesia is not the leading cause of perioperative maternal mortality. Dr. Godbole, your comments and questions, please.
Yeah, thank you very much, Dr. Pandya, for a wonderful talk. We have always enjoyed your talk, particularly your workshops and the interactive sessions.
Thank you.
Yeah. So that reminded me, and I went into sort of a nostalgia today. But it was wonderful that few additions were there. And wonderful thing was that early blood gas analysis can indicate whether you can terminate pregnancy or not. That is a wonderful, wonderful thing. Because this had not struck in the initial workshops. So we're happy that we got, every time we get something new from you. That was great. One thing I want to ask you is the early use of adrenaline. How much dose and the method you suggest for the hypotension under spinal and the section?
So generally, the protocol is in our anesthesia work session daily morning. One like ephedrine 1:6, phenylephrine 1:100, and adrenaline 1 ampule with 10 ml syringe and loaded. Distilled water, normal saline is kept unloaded. So what we do is whenever we have this perturbations, ready reckoner is ephedrine, atropine, and all those things which are readily loaded and available. But adrenaline, we just take the ampule, the syringe is there, saline is there, we just dilute it to 1:10,000 and just inject 1 cc. And that is enough, because when the patient has intense bradycardia, not responsible, adrenaline, atropine doesn't respond, because we know the vagolytic dose of atropine is almost about 2 amperes, 1.2 milligrams. But sometimes that 145 seconds also appears to be very, very late when the patient has intense gradient hypertension. So just 1 cc of 1:10,000 adrenaline, and especially if the patient, so what we do is we ask the patient to grip the fingers. If the patient is able to grip the finger, that means the level is below D8. But if the patient is not able to grip the fingers, of the voice is not good, or she starts whispering, that means it's a high spinal. You don't have to waste time in checking the dermatomal level. Just push adrenaline, give oxygen, 100% pain circuit, and within 1 or 2 minutes, things start improving. And of course, not to forget your left uterine displacement, the wedge under the right hip.
Yeah. That is the most, the prophylactic one.
Yeah, prophylactic. Yes.
Yeah, prophylactic one. That is the most important thing.
Absolutely.
Yeah. Any other questions?
So in the chat box, there's a question: what is the medical legal implication of giving anesthesia to a patient in a place which does not have an ICU? If the gynecologist can be implicated, can the anesthetist also be implicated?
See, again, when you don't have ICU, when you are tackling a problematic case, you need to decide what category cesarean section it is. It is category 3 or category 4 or category 2, where you have at least 2 to 3 hours. Transfer this patient to a higher center. Because in this current era, there is no point in taking headache, because when something happens, it is not the obstetrician that is involved, but by default, vicarious liability comes also on the anesthesiologist. So we, both of us, can be implicated. And if it is a category 1 cesarean section, you justify on paper, then yes, because for the sake of mother and the fetus, we have taken this decision to do the delivery, and the best of setup, best of our hands, or best of circumstances we have done for the benefit of mother. But those situations, what happens is, in our own colleagues, they contradict our statement, like this is not a category 1 section, this is the category 2, what was the need to do? So those things, discussions will come up. So it is always better to play safe rather than overdo in the current medical legal era. But if you're working in a remote place where you don't have facilities, or the transfer to a higher center is going to take hours, then for the benefit of the safety of mother, you can take the decision and you will be safe medically. But see that proper documentation, counseling, preferably audiovisual counseling. Now mobiles are there. You can do audiovisual counseling on the mobile and see that necessary documentation, everything is there beforehand.
Yeah, that's nice. Also, one more question. Is there any role of the anesthesiologist in the antenatal period? Would seeing the patient early in the 3rd trimester or so help?
Absolutely. In fact, this is where we say a team approach is important. Whenever you look at the high risk obstetrics, complex obstetric cases, a maternal cardiac arrest. See, as I was telling you, when I was discussing about cardiac cases, the quickening happens around 16 weeks. That's when the first peak in cardiac output occurs. So generally, all cardiac cases, complex cases, we see the patient pre-conception period also. Like when the patient comes for pre-pregnancy counseling, they are put under our radar. And once they conceive, we see them, the first PAC we do around 16 weeks of pregnancy. Second PAC we do around 28 to 30 weeks of PAC. And third, we do before intervention, the labor epidural or cesarean section, whatever it is. So having an antenatal clinic having a joint, we have an obstetric medicine clinic where all high-risk cases, the obstetric anesthetist, obstetric physician, and obstetrician, the BC jointed together so that we can do a combined counseling from everybody's perspective and give a global view. And this also helps us in enhancing the other part of practice, which I didn't emphasize much about labor epidural and the painless delivery options, because most of these high-risk mothers, they benefit from epidurals for pain relief.
We used to put it with the obstetrician, pediatrician, and the anesthesiologist addressing the long-term.
Yeah. So pediatrician, we involve them when the mother is ending up with preterm or premature delivery. But yes, you can always have a team. Yes.
Thank you, sir. Thank you for this enlightening topic. And Dr. Godbole, thank you for chairing this session. Would you please honor Dr. Pandya with the floor?
Yes.
Thank you so much. And we'd like to honor Dr. Godbole also with the bouquet. Appreciate it, sir. Over to you, Manisha.
Thank you, Shamini. I would just like to make one comment. A lot of nursing homes, maternal homes in Thane city at least, do have a sonography machine. And if we as anesthesiologists learn 2D echocardiography and just run the probe and see how the condition of the heart is, because like sir said that every pregnant lady should undergo echocardiography, which is not normally done many times. So that would be learning something new and benefiting ourselves also.
I didn't touch on this, but yes, definitely that will be a very adjunct. And I'm sure another 5 years we'll be having, in addition to stethoscope, we'll be having ultrasound probe around the neck.
Yes, I hope so, sir. If the MTP and PCA rule allows, we will definitely. That was a wonderful, wonderful talk, and pregnancy is such a beautiful journey that it is not fair if a child comes into this world without its mother. So that brings us to the end of the scientific session, and I request Dr. Parna Thakkar, our Treasurer and Governing Council member, to give the vote of thanks. Dr. Parna.
Dear friends, colleagues, and seniors, it's been a wonderful day of academic feast. I sincerely thank my branch, Thane ISA, for giving me this opportunity to give the vote of thanks. As the treasurer of Thane ISA, on behalf of all my team members, I thank the National ISA President, Dr. Venkatagiri sir, for granting and sponsoring this national CME. A special thank you to the National Vice President and GC Coordinator for the CME, Dr. Anjali Bhure Madam, for the hand-holding all through the journey of our CME. ISA National Secretary, Dr. Naveen Malhotra sir, needs an applause for keeping his faith in us and guiding us. Thank you very much, sir. We couldn't have done without you. I thank National ISA President-elect, Dr. Bhimeshwar sir, and our friendly treasurer, Dr. Virendra Sharma sir, for gracing the occasion. I'm grateful to the editor-in-chief, Dr. Lalit Mehdi Rata sir, respected National ISA past president, Dr. Murlidhar Joshi sir, and National ISA GC member, Dr. Ashok Deshpande sir, and Dr. Rajiv Gupta sir, for being here with us today. From the bottom of my heart, I thank our very own Maharashtra State Chapter ISA President, our very own Maharashtra State Chapter ISA President, Dr. Manisha Katekar Madam, for extending all the help and the support for the finer details. I appreciate and thank the ever-smiling Maharashtra State Vice President, Dr. Anita Nete Ma'am, Maharashtra State Honorary Secretary, Dr. Avinash Bhosle sir, Maharashtra State Treasurer, Dr. Samir Sohni sir, and my friend and colleague from JJ Hospital, the MISA News editor, Dr. Hemant Shinde. I offer a bouquet of thank you to the main pillar of Thane ISA, Dr. Sunil Katkade sir. Forever, we will be grateful to you, sir. I express my gratitude to all the chairpersons for their valuable time and inputs. I thank the great Dr. Balabhaskar sir, humble Dr. Anjali Bhure ma'am, Dr. Ashok Deshpande sir, Dr. Saleh sir, and Dr. Milind Paul sir for the practical tips, a lifesaver and ever energetic Dr. Hitendra Mahajan sir, a silent strength Dr. Godbole sir, the lovely lady Dr. Indrani Hemant Kumar ma'am, and Dr. Manohar Bharne sir, who's also a great artist. Thank you, all the great speakers. We couldn't have pulled this off without you. Thank you, dynamic Dr. Jigi Diwatia sir, lovable and kind Dr. Naveen Malhotra sir, graceful Dr. Manisha Kartikar ma'am, encyclopedia of heart, Dr. Deepak Tempe sir, master of obstetric anesthesia, Dr. Sunil Pandya sir, Dr. Paliwal sir, Dr. Kodi ma'am, and Panchwag madam for the excellent presentations. I also thank pediatric anesthesia queen, Nandini Dave. I also thank Dr. Bala Venkat sir, Dr. Aruna, Dr. Vidya for gracing this August occasion. I thank all our moderators, Dr. Bhavesh, Dr. Parna Thakkar, Dr. Nilima Kelkar, Dr. Manjri, Dr. Shamini, Dr. Sonali Sarab, Dr. Vineet, Dr. Ketki, Dr. Viral Harya, and Dr. Shweta in place of Dr. Vineet at the last minute. We make a fantastic team, friends. Thanks a bunch to all the team members, Dr. Gaitonde Madam, Dr. Parna Thakkar, Dr. Vidya Desai, Dr. Shweta, Dr. Viral Harya, and Dr. Vineet Jadhav for all the little and the big ways that you have pitched in spite of all the odds faced due to COVID. Many thanks and hugs to our junior family members, the genius, Mr. Rajat Ghosh and Miss Preksha Patil for helping us day in and day out for all these silly technical queries that we had. I thank both my children, Vyom and Tej, who helped me tremendously while making the film on the history of Thane ISA. Thank you, our back office team members, ever enthusiastic, Ms. Vaishali and Mr. Abhay. Thank you, our digital partners, IP Lit Ideas and Sandeep Thote sir for the smooth conduct of our virtual CME. Thanks a ton to all our 1,000+ delegates for an overwhelming response. The CME was not possible without you guys. I'm grateful to Torrent Company for supporting us. I thank Torrent MD, Mr. Peter, Deputy MD, Ms. Akshara Pant, Sales Director, Mr. Vinod Verma. I also thank their marketing and sales team. Last but not the least, I thank my ISA family members, our President, Dr. Meenal Gadgil, and Secretary, Dr. Manisha Ghosh. You guys are awesome. Our hard work and teamwork has made this CME possible. Thank you, both of you. Thank you, all the team members of Thane ISA for joining hands and making this journey memorable and successful. Thank you, Almighty, for everything from the start to the end. Dear friends, soon we will be back with a bang for the state conference. Katkade sir, we are coming close to achieving our dream. Jai Ho, Jai Maharashtra, long live Thane ISA, long live National ISA. Thank you very much. Now I would call upon our President, Dr. Meenal Gadgil ma'am, to lower the National ISA flag. Ma'am, please.
We'll have the thank you film before that, Parna.
Okay, okay. Now I call upon our President, Dr. Meenal Gargil, ma'am, to lower the national ISA flag. Ma'am, please. Thank you very much, ma'am.
Thank you, everybody. That was a really great session, and I'm getting quite emotional at the moment. It's been 1.5 months of lots of work, and everybody's done so well. I'm so proud of you, and I'm thankful to all the speakers, the moderators, and chairpersons for putting the background, which we shared with them at the end hour. Actually, it's been a great journey. Thank you, everybody. Thank you very, very much.
Two people have taken a lot of
Great, great.
Excellent.
It was excellent,
Excellent.
excellent
Great.
CME.
Thanks to congratulations. Thanks to everybody. Meenal, Manisha, Parna, Chandrasekhar, Bharani sir, Mr. Sandeep Totan, every person, every speaker, every person who was involved in organizing. Great. It was one of the, the greatest day in the history of Thane Anesthesia, ISA Thane.
You have been the top.
Thanks to all national the national office bearers. Good, great, fantastic.
Thank you so much.
Let me tell everybody that this has been an absolutely virtual CME. All of us met only once when we were planning this and to decide who the speakers would be. We sat there and then called up everybody, and everybody agreed immediately to be a part of our CME. And after that, all the meetings that we have had have been totally virtual on Zoom or on WhatsApp. I think I must have typed at least 50,000 messages in the last few weeks. And thanks Sandeep Thote also of iPrid Solutions. He's done a marvelous job. I've been on his head at at any time of the day and night, but he's given me solutions to every problem that I had. And thank you, everybody. I'm just too overwhelmed at the moment.
Great. Wonderful.
Actually, I have small suggestions in the official and unofficial. Yeah. Okay. Now Dr. Pandya is here. Anyway, we'll discuss. Dr. Pandya, sir?
Yeah, I'm here.
Okay, I think Dr. Pandya, sir, when we heard of the obstetrician, let us put it as an unofficial part.
Yeah.
In most of the